You have to remember that there's how many steps? There's 4 steps to securing someone's airway and ventilating for them. Remember, ventilation means air in and out. So here's a mnemonic I want you to remember. First, we need to open the airway. Then we need to clear the airway if necessary. Then we need to keep the airway open. And then we need to ventilate the patient, right? So, how do we open the airway and which one do we choose? On a medical patient, no fall, no trauma, okay, nothing. It's a medical patient, but they're found responsive and they need an airway secured by us, EMS. Head tilt, chin lift for medical calls. So if you get a medical scenario and you want to ventilate somebody or open their airway, the first step is opening the airway. I will say this one more time. When you're in exam, if you get a scenario, and let's say they've opened the airway, but there's secretions, right? The answer is not BVM. The answer is the next step. This is where people mess up. The next step is suction. Let's say that you open the airway, you've suctioned, but there's no adjunct. The answer is the adjunct. Let's say you've done all 3 of these, right? The next step is BVM. Okay? Now, first thing we're going to do is open. Medical head tilt chin lift. Jaw thrust maneuver is for trauma. Now, clearing the airway. So, we have 2 types of suction that we can use. There's flexible suction, there's rigid suction. We have the Yankauer suction, that blue suction. Whichever you use is fine. You know, for most patients, this is BLS level, we're going to be using the Yankauer clearing secretions that we see. Now, the golden rule is you have up to 15 seconds. So our goal is we want to suction for 15 seconds or less. And to make it easier, if you go down in and then suction on the way out, then you're going to get maximize your time. Maybe you've heard that before. Now, keep. Once we suctioned if we need to, let's say we suctioned out blood or vomit or secretions. Now we have a clear airway. Well, now you got to keep it open. You keep an airway open with an airway adjunct. We can use an OPA or an NPA. So OPA, that is a good thing, oral, like it goes in your mouth, and NPA is nasal, so your nose. Okay. Now I actually have them right over here. Now there's a video you can watch to follow up on this. It's under EMS Skills Mastery. That video, I actually insert these in the mannequin and show you how it works, right? And we do BVM too. So watch that video if you're at the BOS level. Now, here's an OPA. Okay, we're going to measure this OPA from the corner of the mouth to the angle of the jaw. Okay? Now we have here our NPA. This is nasal, right? So we measure from the nose to the ear. NPA. Here they are. OPA, NPA. Okay, we have it all here. Insert your adjunct. And if you want an example of that, EMS Skills Mastery in this course right here. Then we ventilate. Now we get our EC grip. So this makes a C, this makes an E with a grip. And then we attach oxygen 50 liters per minute and we start ventilating our patient 1 breath every 5 to 6 seconds. So what's a mnemonic? Open, clear, keep, and ventilate. There it is. Nasal cannula, non-rebreather, BVM, when do you use it? All that stuff so you have it down cold for exam, because the exam is going to ask you on scenarios and out in the field. You need to know when to use these things. There's a stepwise fashion of doing this. Now I'm going to define some things here and give you some advice, some tips. Then I want to show you a mnemonic that you can actually use out in the field and on the test when you get a scenario, and you'll actually be able to uncover what do I need to use. I'll show it with you. So let's start with the basics. Ventilation is defined as the movement of air in and out. So if your patient has a problem getting air in and out of their lungs, that's a time where they need to be ventilated. Okay? So right now, as I'm talking to you, I'm ventilating just fine, right? If I was unable to protect my own airway, Let's say I was unresponsive on the floor and my respiratory rate was 8, right? And let's say, for example, I had secretions in my airway, right? Secretions, I had vomit in my airway. Pretty sick patient, right? Right. I would not be able to ventilate myself. Now, could my oxygen rate be low? It sure could. But that patient needs an airway adjunct, and that is suction of his airway, and will need to be ventilated by you because the rate is too low. That makes sense? Now, looking over at oxygenation. Oxygenation, you can have an oxygenation problem, but be ventilating okay. So air is moving in and out, but you're having more of an oxygen problem that we can solve. First, you're still able to protect your own airway. You're still breathing on your own, but you need more oxygen, right? With oxygenation, this is a problem of how well oxygen binds to the hemoglobin on the red blood cells. That's our SpO2 level. It's showing us that, how well oxygen is binding to the hemoglobin on the red blood cell. That's your oxygen levels. So I just want to paint you a picture, if I can. The first patient I talked about was unresponsive, vomit in the airway, respiratory rate of 8. That needs a BVM. I like to paint you another patient. Let's say I was tripoding, right? Or I'm on the couch and I'm sitting up. You get my SpO2 and it comes back, let's say it comes back at 89 or 90. You can see I have accessory muscle use. I have some cyanosis on my fingers, right? That's somebody in respiratory distress. Accessory muscle use. The respiratory rate is up, let's say it's 30, right? Their SpO2 is low. Someone is in acute respiratory distress. That's when we give them a non-rebreather mask. To give you an idea, think about this. A patient with COPD that you may see in the home, they have chronic symptoms. Are they on a non-rebreather every day? No. They have chronic symptoms which make them have mild trouble breathing every single day, which is why they're on a nasal cannula. The nasal cannula is for mild symptoms. Maybe you go somebody and, I'm feeling a little short of breath. Maybe their respiratory rate is still normal, within normal limits, but you notice that their oxygen rate is a little low, maybe 92, 93, a few points off. Try a nasal cannula first. Right? That's totally cool to do. So that's nasal cannula. It's 1 to 6 liters per minute. Non-rebreather is 15 liters per minute, and the BVM is always 15 liters per minute. Okay? So remember, nasal cannula, mild symptoms, okay, and I'm going to show you the mnemonic to make it make sense in your head, but there's a low SpO2, so we need to give them oxygen, but they're not having accessory muscle use. They're not tripoding to breathe. They don't have cyanosis on their lips or their fingers, right? They still have good cap refill, right? But they need a little bit more help. Nasal cannula. They're in acute respiratory distress, like someone having a full-blown asthma attack, full-blown anaphylaxis, right? A major CHF event. Oxygen. Non-breather, oxygen. Okay? Now, again, if they can't manage their own airway, they're not breathing at a good enough rate, if you go up to the patient and think, I need to breathe for them, that is ventilation land. Now here's our mnemonic. The mnemonic is RR Owl. I learned this mnemonic from one of my mentors who's a PA. It is called the Pirate Owl mnemonic, like R Owl. Now here's what we have. It stands for, what is the patient's respiratory rate? What is the SpO2 give us back as feedback? What's their SpO2 level, their pulse oximeter? What are they speaking as far as words per sentence? And does their breathing appear labored? So when you walk up, is their breathing look labored? Do they have signs of distress? Yes or no? Accessory muscle use is one of the ones you want to watch out for. Okay? Now, let's do a scenario here, shall we? Let's do a little scenario. I have my eraser, I got my marker. Let's do it. So I'm going to give you a few scenarios. Let's say our first patient's respiratory rate is 20. Now we know the normal respiratory rate is 12 to 20. 20 is normal. Okay. Let's say the SpO2 comes back at 92%. Okay. Words per sentence comes back, let's say about 4 to 5. Now, 4 to 5 word sentence, I'm saying a few of those here. So I'm almost speaking in full sentence. Okay. Labored breathing. We don't see any sign of accessory muscle use, but the patient says they've had a difficulty, walking up the stairs, difficulty moving around, so you find them sitting on the couch. So they're just sitting on the couch. So sitting, they're found sitting, but when they're walking around, they are having some shortness of breath. So short of breath, I'll put that there. Okay? Now, just giving you that information, this is what I'm talking about by a clear-cut, let's trial a nasal cannula first patient. Almost speaking in full sentences, right? Maybe even full sentences. Not in respiratory distress at this time, but we see a low SpO2. They need oxygen. This is a patient I would start off at nasal cannula. You could start off at 2 liters, work your way up to 4 liters, and then you have up to 6 if you need to. 4 liters per minute is a good solid dose to see if you're going to get movement or not. I like 4 liters, okay, to give you an idea. Now again, you'll always want to work your way up. If a test question says, is it 2, 4, or 6, you start, work your way up, okay? Most commonly though, it's going to say 4 liters or 6 liters, just to give you a tip. This is nasal cannula patients. Now, what do you notice? Low SpO2, but mild symptoms. And let's do the next one. Next we have now our breather mask. Let's see what that patient might look like. So let's say their respiratory rate is 28. Normal or abnormal? Abnormal, okay. SpO2, what does that come back at? Well, if we're giving oxygen, it's got to be low. So let's say this patient's SpO2, let's say, and this one is 90%. Okay, words per sentence, let's say they're able to speak in only 1 or 2 words. So that looks like something like this. Hey, I'm having a hard time breathing. That's 1 or 2 word sentences. Okay, now labored breathing, what does that look like? Well, we talked about it. Tripod position, accessory muscle use, right? Anything on a skin assessment that might clue in hypoxia. That means we're going that way. Look out for those 2 positions. Now, labored, we're going to say yes. This patient is found in a field, they're in tripod position, and they're having accessory muscle use on exam. This patient, what's their issue? Think about this, guys. Are you going to lay this patient down in the middle of the baseball field and insert an OPA and do BVM ventilations? No, they're wide awake. Right, they need an on breather. You might understand, well, I get if the respiratory rate is too low. If it's too low, I'll give a BVM. What if it's too high? Yes, you can give a BVM if it's too high. The thing is, the patient has to be unresponsive, right? Because their ventilations are off, right? So that's why I say most commonly, you give a BVM when someone, it's usually the respirations are low. Okay, that's the way the process works. The majority of the time, if someone is going, let's say they're having an asthma attack, they're going to go up with the rate, and then if they're going into failure, they're going to go down in the rate. And then when you see them, when it's BVM time, it's under low rate, okay? So the rates can be variable, but the difference is their responsiveness. So in this BVM case, the words per sentence, they're not talking to you. They're unresponsive, okay? The main thing is they have no control of their airway. You need to take control of it. That's when we take the BVM out. That's why we do it in cardiac arrest. That's why we do it on an overdose, right? So words per sentence, nothing. So, and also, I think here, they are unresponsive. There's no ability to control the airway. No ability to control the airway. So that's zero air, no control. Labored breathing, well, you can see that they're in a sign of failure, right? Which the big hallmark of respiratory failure, what we talked about earlier, could be cyanosis, but really in failure, the patient is weak, tired, they've given up at this point. This is how bad the emergency is. Pulse oximetry is going to be obviously down with these patients. It's going to be below 94. It could be anywhere in that range. Usually, it is going to be lower than the other patients that we talked about, but it still could be in the 90s. But let's just say, for example, this is like, let's say 85%, just to go with it. Okay, but it's going to be lower than 94, we know that. And the respiratory rate in this patient, again, most commonly, these patients are going to be under 12. It's going to be classic question. Your respiratory rate's 8, what do you do? BVM, okay, 8. These are the 3 main lung sounds. You will see another video in this accelerator talking about stridor. We'll get there, but let's talk about lung sounds first. Here are the 3 main lung sounds. So remember, these lung sounds are heard over the chest. That is where the lungs are. Stridor, may call it a lung sound, but it's an upper airway sound that you'll hear. Stridor will be another video. Now, the first lung sound that we hear on auscultation is wheezing. Now, wheezing, remember, wheezing, think AAC. That is a mnemonic for you. Asthma, anaphylaxis, COPD, they're going to have a wheeze, okay? So when you hear wheezing, in your mind, pair that up with the bronchioles are being constricted, okay? That is wheezing. Bronchoconstriction. The bronchioles, the highways in the lungs, constricted. There it is. Rhonchi. Rhonchi means, very simply, junk in the lungs. There's a hypersecretion of mucus in the lungs. Most commonly, infection is in the lungs when you hear rhonchi. Now, we're talking about mucus, possible infection. A common patient to have rhonchi would be a pneumonia patient. Okay, that is going to be your rhonchi. Now, rales. Rales is fluid in the lungs. So the most common patient to have fluid in the lungs would be CHF, which stands for congestive heart failure. You'll see a video on that as well. Now, with CHF, that is pulmonary edema. Okay, pulmonary edema. Fluid in the lungs. Pulmonary means the lungs. Edema means fluid of some sort. So, CHF is pulmonary edema. Rales, think pulmonary edema. Rhonchi, mucus, infection, green, yellow sputum, junk in the lungs, pneumonia. Wheezing, I'm tight. Asthma, anaphylaxis, COPD. There are the lung sounds. More fun to come. Stridor. Now, stridor has 5 main causes. Before we get to the causes, though, what do we always do? What is it? Let's understand what it is. Now, stridor is a high-pitched sound. You can hear it across the room. Okay? You walk up in the call, you'll hear stridor. It is someone with a partially obstructed upper airway in the area of the epiglottis and the trachea. That area is being constricted. Remember we talked earlier in the course about wheezing, how it's bronchoconstriction? This is upper airway constriction. Trachea, epiglottis area is closing, which means our airway is closing. With this being said, there are 5 main causes, and I'm going to give you a bonus thought just to get it in your head. These are the 5, for lack of a better word, medical/traumatic reasons why. I'm going to give you a bonus. So, number 1 is a pediatric condition called croup. Second is epiglottitis. You have an infection that is inflaming your actual epiglottis, that's closing the airway. That can happen at any age, epiglottitis. Foreign body airway obstruction. All that means is you're a choking victim. You're a partially obstructed airway, you're a choking victim. Number 4, inhalation burn. So let's say you were involved in a fire and you're breathing in that hot smoke. Inhalation burn, that can swell up. And then everyone forgets anaphylaxis. Anaphylaxis can cause you to have that stridor sound. Now, a bonus thought for you, as we're picturing this, stridor could be heard. Let's say there was a baseball player. Let's say in both case scenarios, it could be a baseball bat, someone assaulted and struck in the trachea in this region, or it could be a sporting thing, a baseball, a football in this area. Could it be high enough to cause stridor? It's not impossible. It depends, now we understand what it is, how much damage there is, how much swelling is there to the epiglottitis trachea region. Remember, stridor is, for lack of a better word, folks, is our epiglottis and tracheal region. It is constricting and or inflamed and or infected, and you get this right here. That's stridor. You gotta watch out for it. Asthma is one of the most common emergencies that you're going to see. It's also a very frightening experience when they have a full-blown asthma attack as far as the patient. It's a common emergency and we need to know it cold. Now, like all my other diseases, here are our 4 steps. So what is asthma? Number 1, asthma is defined as it's a medical emergency that we're going to see when a patient has bronchoconstriction. So the bronchioles, the airways in the lungs, the bronchioles are, number 1, being constricted. Smooth muscle constriction is causing a tightening. It's harder to breathe, right? Number 2, we have a hypersecretion of mucus. This can get so bad, imagine the bronchioles can actually plug up, mucus plugs. There's so much secretion of mucus and constriction, the patient has a hard time breathing. That's asthma. And it happens not over a few days, happens quickly, right? Now, what are the risk factors of having an asthma attack? Well, there's different types. So you look over here. There, for example, if someone has an allergy, let's say to pollen, oh, there's a lot of pollen in the air, they can have an asthma attack. Okay. Smoking is a risk factor for developing asthma, and also some people can get asthma on physical exertion. So some people, their asthma triggers when they're working out hard in the gym, for example. Okay. Now, number 3, what are the signs and symptoms of asthma? The number 1 takeaway you gotta take is wheezing. Remember my mnemonic, AAC is what wheezes. Asthma, anaphylaxis, COPD. Asthma is the first one. So wheezing, and you're going to hear wheezing on both sides of the lungs. Bilaterally means both sides. Now, another pearl. Asthma presents with cough and tight. They're coughing and they're tight. They're coughing because of the mucus. Well, why do they feel a tightness in their chest? Because they have bronchoconstriction, tightening, and they feel it. So they'll say to you, I have, my chest hurts, it's tight, and I'm coughing. They also will have accessory muscle use. So muscles in the neck, muscles in the chest that aren't normally shown, and they're straining to breathe. One last pearl on signs and symptoms. If you notice they have a hard time exhaling, this goes back to remembering about the mucus. There's so much mucus they breathe in, and they have a hard time breathing out because they're so plugged with mucus and constriction. Something to think about there. Now, how do we treat this? Well, if you're watching this video right now, we're talking about the asthma patients at the BLS level and what we do to treat them, right? So BLS means EMT level. This is your BLS care. We start with oxygen. So remember on NREMT, everything is a stepwise fashion. If you see a scenario, and let's say that scenario, it's clear-cut asthma, but they haven't gave oxygen yet. You notice the oxygen level is low, under 94%. Oxygen's the answer. So oxygen's the first thing we do. If the scenario already gave oxygen, well, there's something else we got to do because they already got oxygen, right? So a non-breather mask oxygen would be great, 15 liters. I love that. Now, over here are your next steps. The next best step would be to assist with an inhaler. It could be albuterol, could be levobuterol, could be a duoneb, ipratropium's in there. If you want to learn more about those medications, it's an EMS Medications Mastery. Just look them up and you can see them there to learn more about those. Now, the final piece, so 1, 2, 3. Let's say we give oxygen. We're giving it, but no real change. We try the albuterol, no real change. We can consider CPAP. Now CPAP, the dose on CPAP, here's how I like to do it, and this is also with protocol too, is for asthma, 10 on the actual setting of CPAP, not the oxygen, but the actual setting of CPAP would be a 10, would be the maximum. So I would start the patient at 5, and you can work your way up. 10 is the maximum, right? If we had a patient with CHF or they're drowning in their lungs, we may start with 10. But with asthma, about 5, and then work our way up to 10 as the maximum dose. There it is, folks. That's asthma. An allergic reaction means one body system is being affected. Anaphylaxis means 2 or more body systems are being affected. Well, what's a body system? Well, if you've gone through anatomy and physiology here in the course under A&P Mastery, you know I broke them out by like respiratory, circulatory, gastrointestinal. Those are body systems, right? So let's say your patient has hives. That's skin, right? That's one body system. Hives by itself, that's a simple allergic reaction, right? That patient, here's some oral Benadryl, thank you very much, right? That'll be it, okay? Now, with someone who with anaphylaxis, this is where 2 or more body systems are being affected, okay? Meaning I have hives and nausea, vomiting, hives and stridor, hives and wheezing, hives, nausea, vomiting, stridor, wheezing, 2 or more body systems. Now, how many did I name there? I named 3. Well, skin, respiratory, GI. What about heart rate? That's circulatory. You can also get tachycardia as one of the signs and symptoms. Now let's go through our 1, 2, 3, 4 method. What is it? Anaphylaxis is defined as a severe allergic reaction that can be life-threatening. It's the body being hypersensitive to an allergen out there. Now, what are the risk factors? Well, the most common allergies are insects, medications, food, and yes, bees, okay? Now, signs and symptoms are stridor. So what is stridor? We've watched the video on that hopefully by now. If we didn't, stridor is that get partially obstructed epiglottis, partially obstructed trachea. So it swells up. Wheezing, that is bronchoconstriction, and we have constriction of the bronchioles, and then we also have mucus as well. Wheezing. Hives, okay, hives, skin, and nausea, vomiting. Now what we do, what's the first thing we do at anaphylaxis? The first thing we do, EpiPen, okay? So EpiPen is given on the lateral side of the thigh, okay? We're going to hold it for a period of time and let the medicine release. Now, if the acid dose, an EpiPen adult holds 0.3 milligrams, and the EpiPen Junior holds 0.15, so about half, okay? Inside of medicine, most Epi doses for kids is 0.01 milligrams per kilogram. Follow your local protocol on that when you do it out in the field, but on test day for BLS, that's what it is. Now I put over here that I want you to start thinking about this. We go to an anaphylaxis patient. What are we going to do? We're going to do an assessment. We're going to see they're in anaphylaxis. What's the first thing we do at anaphylaxis? Epi. Okay. What's the next thing that we do in anaphylaxis? Well, oxygen might be good if they have stridor and wheezing, right? And then what can we do from there? Well, depending on your protocol that you have, if you have the ability to give oral Benadryl, great. Now, at the paramedic level, we would be doing other things. I'm not going to get into it in this video. You can watch the ALS on that. But that's your mindset. I also put albuterol here. At the ALS level, we would give albuterol to open the airways. But I want you to know this cold, and to know that you have to understand, what do we want to do with this patient? If they have stridor, they have tight upper airway, tight lower airway, wouldn't it make sense to give them epinephrine, which we know is going to open the lungs up? Wouldn't it make sense to give albuterol to open their lungs more? Wouldn't it make sense to give oxygen when they're being constricted? Wouldn't it make sense to give Benadryl, which is what we give to an allergic reaction? Does that make sense? Even if you're at the EMC level, it all needs to make sense for you to understand this. So there it is, my friends. That's how it works. First, going to break down the difference, because COPD has 2 subtypes. So COPD, it could be chronic bronchitis or emphysema. So let's characterize what these are. So first off, COPD, chronic obstructive pulmonary disease. So it's a pulmonary disease, affects the lungs. It's chronic and obstructive. Well, that sounds like we're having a hard time breathing in and out. That's correct. Why? Which one? Let's talk about it. So chronic bronchitis. Chronic lasts a long time. Bronchitis. The bronchioles are inflamed. Bronchitis. Okay? Emphysema, we'll get to in a second. Let's start with chronic bronchitis. So chronic bronchitis, a few pearls here and then we'll chat. They are called blue bloaters because blue due to chronic cyanosis. You might see in the nail beds, for example, okay, in the skin, for example, a blue color. They're usually overweight, okay? They have a productive cough. So a productive cough with sputum, okay? The issue with chronic bronchitis is they have an increase of mucus. So they have excess mucus in their airways. That's problem one. So picture a normal bronchitis, normal. It's going to be bronchoconstricted, and then it's airway tightening, we can call it. And then we have increase of mucus production around that. That's going to be some tight airways. So they have a hard time on inspiration and expiration. They have hard on both ways, okay? Now emphysema, while it's under COPD, it's a different disease going on inside the body. It's not a mucus issue, it's not a tightening issue, it's an alveoli issue. So let's go back and remember this. The alveoli is where gas exchange occurs, right? This is where we're going to get oxygen and carbon dioxide to switch places, and we're going to get oxygen in the body, we're going to breathe out carbon dioxide, oxygen's going to go into the body, and it's going to get on those red blood cells. Go through the alveoli into the capillaries, the pulmonary capillaries. Now, with emphysema, they're called pink puffers. Why? Here's why. If you picture an alveoli the way it normally is, it should normally be, they call it elastic. Open and close, open and close, open and close, right? So when you make an exhalation, the air can go out easily, right? People with emphysema have a hard time exhaling because the alveoli becomes rigid. Air will go in, and it gets trapped. It can't get out. It's because the alveoli has a hard time squeezing to go in, bring the air back out on exhalation. So this emphysema, it's a non-elastic alveoli issue. It's a destruction of the alveoli. It is a destruction of your gas exchange. That's why they have such a hard time breathing. Because they're straining so much to exhale air and get it out. They're called pink puffers. They have a thin barrel chest. And they have a cough, but they don't produce anything. There's no sputum. Why? It's not a mucus issue. They're coughing because they have a breathing issue. It's an alveoli issue. And this is the pursed lip breathing because they're just straining to get air out. But it's being trapped. They have a barrel chest from all that air trapping. That's what it is. So chronic bronchitis and emphysema. In the next section here, I'm going to break down our 1, 2, 3, 4 for COPD. Let's do it. COPD is a chronic pulmonary, chronic respiratory disease that can cause the following things. Bronchoconstriction, tight airways, tight bronchioles, increase of mucus production. That's the chronic bronchitis side. On the emphysema side, destruction of the alveoli causing air trapping, which will cause that barrel chest appearance, right? So, quick thing about which side. Could somebody have chronic bronchitis and emphysema? Yes. It's not a one or the other issue. It can be combined. It can be one or the other. But either way, it falls under the COPD umbrella. Number 2, what are the risk factors? Smoking, irritants. Secondhand smoke, by the way, can cause this long-term secondhand smoke. And you may have heard about people working in hazardous areas. Could be, military. Could be shipyards, factories. So there's a lot of irritants in the air. Now, what are the signs and symptoms? Wheezing is the tightness in the airways. You can even hear rhonchi, which remember is increase of mucus in the airways, right? Rhonchi. Tight. Anytime we have tight airways, your patient might say they feel tightness in their chest. My chest feels tight. I'm having a hard time getting air out, right? Emphysema. Low SpO2, under 94%, and obviously difficulty breathing, right? Let's think about this. We go to a patient with chronic bronchitis or emphysema, COPD. Let's say their SpO2 is low and they're having a hard time breathing. The first thing we want to do is increase the oxygen. Give them more oxygen, get them back to normal SpO2 of 94%. That's what we're going to do. So if their oxygen is not adequate enough and they're below 94, we want to get them back to 94. Okay, so that's number one. Get them back to 94% at least. Now, two other things I want you to think about. We're still at the BLS level, EMT level, but still we think about this. Could we assist with albuterol? Sure. Albuterol, levoalbuterol, Duaneb. Sure. Now, what about CPAP? Again, same deal. It's in your protocol. CPAP would be next. If you have a test question where they've already gave oxygen, but they're still in the stress, the next step is either going to be increase the oxygen if it's an answer, or one of these two. There's going to be CPAP, getting 5 of 10, or albuterol, right? Assist with their albuterol. That's what we have here for COPD. Pulmonary embolism is one of the sneakiest emergencies out there. The reason it's so sneaky, it's not like asthma or CHF or pneumothorax. Someone has a hard time breathing with pulmonary embolism, but their lung sounds can be completely ineffective. You may even hear clear lung sounds with an early on pulmonary embolism. Let me explain what's going on here. So with pulmonary embolism, you know when we have a heart attack, and we talked about how when a heart attack, well, the coronary arteries are under attack. Could be a clot or constriction, but there's no blood flow to the heart's muscle. That's a heart attack, right? Well, a stroke is when we have the blood flow that supplies blood to the brain, the tissues of the brain. Could burst, it could have a clot. That's a brain attack, a stroke. A pulmonary embolism is a lung attack. So the blood that feeds the tissue, the vessel that actually feeds and blood supply to the lungs is blocked. It's a lung attack. The lung tissues are under attack. Pulmonary embolism is a thrombosis or a blockage or a clot of the pulmonary arteries. It's a lung attack. The lungs are dying. This is what occurs in pulmonary embolism. Now, here are the risk factors. Cancer, smokers, any sort of long travel or rides, long plane rides, bus rides, car rides, birth control usage, pregnancy. These are all the risk factors. And one I didn't mention, recent surgeries. Especially if it's a vascular surgery, think about that. Now, what are the signs and symptoms? Number 3, shortness of breath, chest pain. Again, you may hear clear lung sounds bilaterally, right? You're either in pulmonary embolism, you're either going to hear clear lung sounds, or later on, maybe you'll hear diminished bilaterally. Maybe. But most likely, they're going to be clear. Okay, just a food for thought when we're thinking about that. How bad a shape are the lungs in, right? Shortness of breath, chest pain. Now here's a hallmark sign. We're going to have a patient with clear lung sounds, chest pain, difficulty breathing. Most likely, one of these risk factors you're going to find in your history, and the heart rate's going to be up like 120, 130, 140, and their SpO2 is going to be like under 94%. And they're going to hit one of these risk factors. Will you find it? Hope so. It can be sneaky. It's been missed before. It can be misdiagnosed. Don't let that be you. Focus. Okay? Number 4, how do we treat it? First thing we do with these patients, you need to be thinking about is this. High flow oxygen, get them to maintain at least SpO2 of 94, 99. That's great work. Second thing, rapid transport. Get going. And then bonus, if you have the ability, you could say, transmit a 1280 kg to the hospital at the EMT level. That's what we have there. Just so you're aware, the paramedic level, there's not much more we're going to do for pulmonary embolism. Really, there really isn't. We're going to do IVs, rapid transport, do a 12-lead. Same deal, right? Final note, watch out for patients who are young men, young females. They're heavy smokers. Watch out. I've had patients, young, 20s, 30s, 40s, PE. In hospital, they will give them heparin in an IV bag to break the clot. But remember, this is a life threat. This could cause cardiac arrest, rapid transport. Welcome to Heart Blood Flow. This is the ultimate heart blood flow lesson. Watch this video once, twice, even if you want to watch 3 times. I guarantee you will understand heart blood flow after watching this presentation. Now here it is. First thing we're going to do is we have to understand arteries and veins. I'm going to actually write this out for you live, okay? So first, we have arteries. Okay, let's write it out. And we have veins. Okay. Arteries have what letter in it? A. So in heart blood flow, how the heart is able to pump blood around the body, how the heart gets blood. In this, arteries go away from the heart. Arteries go away. Arteries, away. They are together. Veins go towards the heart. Arteries go away from the heart in heart blood flow. Veins go towards the heart in heart blood flow. So now we know that. We're going to start over here. What is the SVC and the IVC? This is the venous side, venous blood coming back, pulling together in what we call the superior above, superior vena cava, and the inferior down here coming up here, inferior vena cava. Superior because it's blood from up here, inferior comes from up here. So they come and they like this, and they enter the first piece, which is the right atrium. This blood all is coming back to the heart. So which means this blood does not have oxygen in it. We need to get oxygen. So the right atria, remember, the atria, they always push down. They always push down to its ventricle, its partner ventricle. The right atria goes through the tricuspid valve. A way you can remember this, we're not getting too far ahead. 3 comes before 2. So tricuspid, so 3, 2, right? So you remember that? So tricuspid valve comes down here. Now, with the right ventricle, we're going to give each ventricle a job. Why? The ventricles, I want you to think of them as being stronger than the partner atria. So here, right ventricle's job is to get the heart oxygen. How are we going to do that? We'll figure it out. The left ventricle's job is to pump blood to the body, partnering up with something we'll talk about later. Now watch this. The blood right now, we do not have oxygen. It was already dropped off earlier. So we need more oxygen. Keep pumping. The right ventricle is going to think, okay, how do I get oxygen? Well, I'm in the right ventricle. I don't have any oxygen. Who has oxygen in the body? The lungs has our oxygen. Right there. It says it right there. Let's make a pathway like this called the pulmonary artery. And Evan told me that in heart blood flow, arteries go away from the heart. So the pulmonary artery is a bridge from the right ventricle to the lungs where we're going to get oxygen. Make sense? Now, we're in the pulmonary arteries, we've got oxygen, we have oxygen-rich blood. All right. Well, how do we get back to the heart? And we're in the lungs. The pulmonary vein. And veins go towards the heart. Remember the veins over here? Where are they going? Towards the heart. Where's pulmonary vein going? Towards the heart. Now we're back in the left atria, and the left side of the heart has oxygenated blood. The atria, remember, always passes down through the mitral valve, and now we're in the left ventricle. Left ventricle's job right here, pump blood to the body. It's going to partner up with the aorta, which I don't want to draw here because it could confuse you with the pathways. But the aorta basically comes up like this, and it's going to cross like this, and then we're going to have a hook down. So basically here, if this is my heart right here, and we're going to have the left ventricle, it's going to go up to the aorta. The aorta goes down here, and then we're going to flow up like that. That's how it works. And that is, folks, your heart blood flow. Watch this video over and over again until you have it down cold. I'm always here for you. Now I want to break down my 1, 2, 3, 4. Let's do it. So, CHF. CHF is when the heart fails as a pump. The biggest life threat of CHF is pulmonary edema. Pulmonary edema is fluid in the lungs. You are literally drowning in your own fluids. Blood is coming up in the lungs, which is why we have that pink, frothy sputum. Your heart has failed as a pump and blood and fluid is in the wrong place. The risk factors: smoking, diabetes, high blood pressure, high cholesterol. What are some of the signs and symptoms of CHF? Well, we learned blood backs up into the venous side. So, JVD, jugular vein distension. We can have pitting edema down here in the lower leg. Okay, fluids in the wrong place, right? We see that more with right side heart failure. Now, left side heart failure, that's the ominous one. That's where we have that pulmonary edema. I can't breathe. I have chest pain. My heart is failed and blood's backing up into the lungs, right? That's where we get pink frothy sputum with a cough. That's where we get rales bilaterally. Rales on lung sounds, both sides. If you haven't watched the lung sound video yet, make sure to watch that. Now, what do? Well, we're here at the EMT level. What do we do at the EMT level for CHF? Well, here's what we do. 1, we want to raise their SpO2 back up above 94. So, 94 and 99 is our good range. So, we're going to give an hour breather. High flow oxygen. Remember we talked earlier about respiratory distress. You see that, we got to get up on oxygen, number 1. Number 2, do a 12-lead EKG. So if you have the ability to do a 12-lead EKG and transmit to the hospital early, do that. And number 3 is, again, if you're able to do it, use CPAP. So these are the steps. So test question goes, what do? Oxygen, 12-lead, CPAP. Now, with CPAP, the range of CPAP, when you're setting the actual CPAP, the actual device, could be anywhere from 5 to 10. Remember, your max dose is around 10. 5 to 10 is going to be a good range. With CHF, I like, me personally, you're talking about in the field, what you do, I like to push a little more with CHF to really make sure we have a good outcome, because we have literally the patients drying in their own fluid. Where asthma, we might start a little lower. With CHF, you might be a little more aggressive. Just something to think about. Okay, we don't want to be a cookbook, EMT or medic, but that is what I think about. There's CHF, folks. What occurs in CHF? Like, why do we get JVD with CHF? Why do we get rales with CHF? Why is your patient coughing up pink frothy sputum? Those are some of the symptoms and signs of CHF. Why do they get fluid in their legs? Why? Let's talk about it. So, if I can give you one thing and write this down, when your heart fails the pump, which is exactly what's happening, your heart is so weak that it is not able to push blood forward anymore. It is dying. The heart is weak and dying. It needs support. It needs help. That's why we're here in EMS. CHF, when the heart fails, blood backs up. Blood backs up. Say it with me, guys. CHF, blood backs up. Hear me out here. This is the left side of my heart, right? Well, we know normally the left ventricle, if you watched, make sure to please watch the heart blood flow video before this one. It's in the list as after. Make sure to watch heart blood flow first, so it'll make more sense. Now, with the left ventricle, it connects to the aorta to pump blood to the rest of the body, right? But if blood backs up, it's gonna go this way. Watch. Here goes the blood. Backs up to the left atria, back up pulmonary vein. Now we have back up down here, where gas exchange occurs, right? Ooh. What do we get? Blood in the lungs. Fluid in the lungs. And the reason it's pink frothy sputum is blood tinged. Blood and fluid are going up. If the left side of my heart fails, I get more, so left, I'm going to get more respiratory symptoms. Now what I can tell you is, with CHF, a combination of things can happen. With a CHF patient, you could be having a heart attack and your heart's failing as a pump because your heart muscle is dying, right? You can also be a patient who has diagnosed chronic CHF. They're a CHF patient, and over the last few days, their breathing has gotten worse and worse and worse until, boom, pulmonary edema. Pulmonary edema is the fluid in the lungs, okay? That can happen too. Now, why do we get JVD? Why do we get fluid in the legs with these patients? Well, here's why. Right side heart failure. If blood backs up on the right side, well, it's supposed to go from right ventricle up to the pulmonary artery. Instead, it leaks back into the venous system. SVC goes up, IVC goes down. What's down? Fluid in the legs. What's up? JVD. There it is, folks. That's it. It's literally as simple as that. Do not overcomplicate it. If you remember this, you'll know CHF cold. You'll know all the signs and symptoms literally for the rest of your life. Let's say you have a 65-year-old male patient. He's outside and he's going for a walk. Let's say it was a 1-mile walk. About 5 minutes away from his home, the patient, 65-year-old man, has chest pain. The patient has pain, is still able to walk, sit in the sidewalk, has chest pain, calls 911. Let's say that within a short period of time, under 15 minutes, the pain goes away. By the time the first responders come, the pain's gone. What did the patient do? The patient was walking, then sat down, pain went away in under 15 minutes. That is a stable angina. So a stable angina, what that means is the patient's pain went away with rest. He was in a 10 out of 10 pain, called 911, took a seat in the sidewalk, pain went away. Stable angina. Pain stops with rest, okay? An unstable angina means, let's say with the same scenario, patient went to sit down, the pain got worse, or the pain persists. That's an unstable angina based on the definition of how does the patient feel with their pain, okay? That's number one. Now, when we're talking about chest pain, and we're talking about cardiology and cardiac, I want you to know that the coronary arteries are the vessels that we're talking about when someone has a heart attack. Another word for heart attack, myocardial infarction. We call it an MI. Some people call it AMI, an acute myocardial infarction. Same thing, but names get thrown around. We want to make sure you understand it. It's the same thing. It's a heart attack. Now, you are not going to know this piece here out in the field. When we're talking about angina, I want to give you a little tip. You may not have even been taught this in class. This is what a normal heart attack looks like. Plaque builds up on the walls of your vessels, and we can see here, there's not a lot of blood flow going on. That's a classic heart attack, right? It's a clot in the coronary artery. It's blood can't flow through, so the heart muscle doesn't get enough blood, so the heart muscle starts to die. Myo, muscle, cardiac. Infarction means death. A heart attack means the heart muscle is dying. This is why we have a bad outcome with that. Make sense? Now, what if we have an angina that is not caused by a clot, but it's actually caused by stress of the vessel? It's a vasoconstriction. There's no clot, but the coronary artery decides just to clamp down, like enclose. That is called a type of angina. It's called Prinzmetal angina. I just felt like giving you a little bonus tip. It's a paramedic level thing, but we're talking about angina. I thought I'd tell you too. There it is. MI, myocardial infarction, is one of the most common emergencies that is talked about among EMTs, advanced EMTs, and paramedics. You're going to learn about it right now. It's a heart attack. Let's break the word down first. So, myocardial infarction. We got to know all these breakdowns. Myo is muscle. Cardial, think cardiac, I'm talking about the heart. So we're talking about heart muscle, and okay, so what's the heart muscle doing? It's infarcting. Infarction in medicine means death. So what this word says, the heart muscle is dying. We call that, in common terms, a heart attack. It's called an MI. Okay? So you may see in documentation, if you see MI, that's a myocardial infarction. If you see A is an alpha, AMI, that's an acute myocardial infarction. Same thing, but you might see it on documentation in their history, whatever, they may be talking about it. Oh, he's having an MI. Oh, he's having an AMI. Same, it's the same thing. Okay? They're talking about a heart attack. Just want you to know about that. Okay? Unfortunately, not every provider that you may hear, a nurse, a doctor, EMT, medic, whoever, they don't always talk in plain English. So I want to share that with you. Let's continue. So here's our 1, 2, 3, 4 breakdown. So what is an MI? Well, an MI, what it is, it's a blockage of the coronary artery. There's multiple coronary arteries. There's different types, and some on the left, some on the right, some middle. But it's a blockage of a coronary artery. It could be one, it could be multiple, right? But it's a blockage of a coronary artery that is causing the heart's muscle to start to die. Okay? If the heart muscle dies, well, the heart doesn't have any muscle to pump blood, right? That's how your patient ends up eventually, if we do nothing, in cardiogenic shock. Because the heart can't pump blood, so blood doesn't go anywhere, and shock, you get low blood pressure, right? So MI is one of the ways you can go into cardiogenic shock. It's the heart's fault, right? So, a blockage, right? Number 2, risk factors. So I have a mnemonic for this. It's called SAD-CHF. SAD-CHF. It's a mnemonic to remember what are the risk factors of having a bad cardiac outcome. Smoking, age greater than 50, diabetes, high cholesterol, high blood pressure, and family history. Okay? Now, are there other things like lack of exercise, obesity, nutrition? Yes, but those are secondary to these. Number 3, what are the signs and symptoms? Classically, crushing, I feel like an elephant's on my chest, crushing pain, right? Pressure, pain. Left-sided chest pain goes into the shoulder, the arm, up the jaw, all in here and in here. Where's the heart? Right here. So it's on this side, right? More described as a crushing, a pressure, right? That's how it's described. Some people mistake it for severe heartburn, right? It's that pressure, right? Crushing. What else? Well, sneaky stuff. Nausea, vomiting. Of course, a classic one is difficulty breathing. Another sneaky one could be shoulder pain in the back or back pain, which is the shoulder blades. Another one is I'm just weak, I'm just tired. Watch out for a patient that normally walks, talks, is fine, but all of a sudden there's no signs of infection. Blood sugar's fine, but the patient just is too tired to get out of bed. They're too tired to move. Do an EKG if you can, right? Right? So just start thinking about, could this be a heart problem, right? Right? Number 4, how do we treat it? If we suspect the patient, we go to a patient, they're having crushing chest pain, pain on their arm, hard time breathing, they're nauseous, they vomited a few times. You suspect they're having a heart attack. What do? Number 1, give oxygen. Get their SpO2, their pulse ox, get that pulse ox reading above 94%. Give them an out of breather, 15 liters. Now, what do we do after that? Well, number 2 is give aspirin. So like any medication, ask if they have an allergy. If they have no allergy, give them 4 baby aspirin. That's going to be 81 milligrams. So 81, 81, 81, 81 is 324. And that's going to be the dose. Okay, so it's 4 baby aspirin. They chew it up. Now, 2 more things. We can assist with the patient's nitro they're prescribed. They're in a state where they're not able to, don't think about it, they're having a heart attack, a lot going on. They may not be able to take their own medication. They have a nitro prescribed and their blood pressure is within normal limits. They haven't taken any sort of erectile dysfunction medications. We got a video on nitro coming up, but just think about it, okay? You can assist with nitro. More on that in another video, okay? And then over here, if you have the capabilities to do a 12-lead EKG and transmit to the hospital, great. Okay, so this is the hierarchy: oxygen, aspirin, assist. Can I do a 12-lead? There it is. These are the 9 pulse points you need to know as an EMT. First, we start with the head. It's the temporal pulse. Right here, this is the tragus in the ear right in here. So right on this section, you're gonna feel a pulse. Okay, that is number 1. Number 2, the carotid pulse. The carotid pulse, you go out of the trachea and slide over this side. Both sides have the carotids right in here. Okay. The apical pulse, a little fun here. I can't do it with the mic to show you. You take 2 fingers and you're going to slide down the front part of the chest. You find a little notch. That's a sternal notch. You're going to slide over to the second intercostal space. The second to the left side, I didn't tell you the left side. The second intercostal space. What is an intercostal space? An intercostal space is a space between ribs. So meaning the first intercostal space is between 1 and 2. The second intercostal space is between the second rib and the third rib. So you're going to go down from the second, go 3, 4, 5, look at the clavicle, go right in the middle of the clavicle, and right on that mid-clavicular line in the 5th intercostal space, that is going to be your apical pulse. You'll feel it pretty easily. You can try it on yourself. The brachial pulse, that is for our blood pressure. So I tell all my students, and I'll tell you in this video, always do a blood pressure. When you're doing a blood pressure, get a pulse here first. So you feel the pulse, okay, and then put the scope right on top of that baby. That's perfect. Radial pulse, right here, okay? Femoral, that's gonna be deep in the groin for that pulse. The popliteal pulse, you wanna actually bend the knee, and it's gonna be back in here on the knee. The posterior tibial pulse is on the inside of the ankle. Remember, on the inside of the ankle. And finally, the top of the foot pulse is going to be your dorsalis pedis. I won't be shocked if on NREMT you get a question asking you about one of these pulse and where it's located. Quick tips for you there. Stroke will block or hemorrhage, causing your brain to not receive oxygen. It's a brain attack. So I'm going to break down my 1, 2, 3, 4 here. There's so much to talk about with signs and symptoms. I'm going to share with you actually the treatment out loud. But the board's pretty packed, so let's get into it. Now, stroke. Stroke stands for cerebrovascular accident. Okay? CVA. You may see on a list, CVA. It's a previous stroke. Now, what it is, again, a stroke can either be an ischemic stroke. An ischemic stroke means we have a clot in one of the cerebral arteries that is blocking blood flow to the brain. We can also have a hemorrhagic stroke, which is when we have a vessel burst, there's blood coming out of that vessel. So the blood is not being received to the brain because of the hemorrhage. Now, out in the field, we are not going to know if someone's having an ischemic versus hemorrhagic, which is why the patient needs to go to hospital quickly to get a CT scan of their head to see what's going on. That will determine what they're going to do with the patient, surgery versus meds, and so on and so forth. Now, let's continue. That was number 1. Number 2, what are the risk factors for somebody having stroke? Well, it's very similar. If you notice the risk factors for having any clot in the body, it's kind of the same. It falls to the same stuff. We notice smoking isn't all of them. So we have smoking, high blood pressure. You can even put in high cholesterol as well. That's totally fair, right? We also have diabetes, right? Now, notice a few things here I want to talk about. AFib. Okay, so atrial fibrillation, you've probably heard it on the commercials. AFib, you're at a greater risk of stroke. Yes. Also, you're at risk having another stroke if you had a previous stroke or clot anywhere in the body, right? So that's something to think about. Number 3, here's the real deal when it comes to stroke. What are the signs and symptoms? Now, as far as vitals are concerned, you're going to see initially high blood pressure. So look out for high blood pressure as far as vitals. That's a big key one. As far as the signs and symptoms, we say be fast. Be fast is our mnemonic. So B stands for the patient's balance. Is the patient's balance off? Is that one of the main reasons they call the ambulance today? Because their balance is off and they have high blood pressure and so on and so forth? Is their balance normal? Number 2, eyes. Have they lost vision or they have blurry vision? And I will add in, you could do a test with a pen light to check for nystagmus. You can take a light. Now, what is nystagmus? Nystagmus is basically, it looks like a fluttering of the eye when the patient looks up. So you can look up. If the eye flutters like this, has a vertical nystagmus, that could be a sign of a stroke. So, B-E. F, facial droop. So very simply, is one side of the patient's face drooping down, right? That is facial droop. Arm drift. Arm drift is a test. We have them close their eyes, both arms up. If one arm drops off, they can't hold their arms up, right? This would be weakness in this side. Is the patient saying to you that they have a weakness in a particular side, left or right? Right? It's a unilateral weakness. So, oh, my arm is so weak I can't even move it, right? That's a sign, okay? Speech. Is there speech confusion? Would be altered mental status. That's something to think about too. But with speech, really, we're talking about, is their speech clear? Are they stumbling on words, right? Is the speech slurred? Are they unable to speak? Right? Those be a check for speech problem. And T is for time. When was the last time they were seen normal? Because in hospital, that medication I was talking about, it's called TPA. And that has a window of time where we try, if, let's say the patient was last seen normal 2 hours ago, and now you're there. You train in a hospital, 15 minutes, right? We're under the 3 to 4.5 hour window where they could give TPA. Now, TPA is given to break the clot up. So let's say you have a ischemic stroke in your brain. An ischemic stroke is you have a clot in your brain. You can give TPA to break the clot up so the blood supply is back, right? We do not give TPA to people with hemorrhagic strokes. It's only going to make it worse, okay? So as far as treatment for stroke, not on the board, but I'm going to tell you what it is, so you take note on this. Or number 4, oxygen, get the SpO2 above 94%, get a blood sugar, make sure the blood glucose is in normal limits. Someone with hypoglycemia could appear to have a stroke. No stroke is a stroke until you get a blood glucose level. So if you walk up to a stroke, let's say the patient was right here. I'd walk up, I would do my B fast, get a history, get vitals, right on scene. Then, I'm pretty keen, I'm pretty sure it's a stroke. I do my B fast, my vitals, I'm going to give oxygen and get a blood sugar. Let's say the blood sugar comes back at 130. That's normal. Oxygen level, let's say it's 90%. For example, we give oxygen, get it up to 94, blood sugar's normal limits, I'm calling a stroke alert. Get my radio, call a stroke alert, and then we're going to start moving the ambulance, rapid transport. The only real difference between ALS and BLS, EMT and paramedic on stroke, is the advanced EMT or paramedic could put an IV in and possibly read a 12 lead. But that's not what the patient needs. So I always tell everybody the patient needs to be recognized early that they're having a stroke and transport to a stroke center as soon as possible. Because either the TPA or a surgery is going to save them. And there it is. Early recognition of cardiac arrest, early CPR, and early defib, use of an AED, and great post-resuscitation care. Those are the 4 main ways of a good cardiac arrest outcome. We talk about lay people knowing good compression-only CPR, right? So their goal is to recognize, do compression-only CPR, activate emergency response, EMS, 911, find an AED. continue, right? Now right here, I want to talk about CPR pearls. So let's go through them. With CPR, you want to check the carotid pulse. We give you about 5-10 seconds to accomplish that. From there, you want to think CAB, circulation, airway, breathing. That's going to be your mnemonics. Remember the steps we're going to go over. It's coming up. You'll see it. Now, as far as the amount of chest compressions, you want to do between 100 to 120 a minute. You want to allow full chest recoil and a chest depth. When you actually, how deep the compressions go, I've labeled them here for you. So adult and pediatric is 2 to 2.4 inches, and the infant is 1.5 inches. This right here is the start for understanding good cardiac arrest care at the EMT level. So right here is our BLS algorithm. Remember these steps? You're going to be in good shape. So first things first, BSI, scene safe. We have our gloves on, we're going on scene, they're scene safe. So now, under the BLS, right, in the algorithm, they will say activate EMS, but we are EMS. So if we think of this, it's activate EMS, call 911, get an AED, right? Let's say we're out and this is happening, right? But if you think about this, we are EMS, so we show up, we have an AED, we have our equipment, we're showing up, we have the AED. Okay, so what are we going to do with the patient? Patient unresponsive, what are we going to do? Well, the first thing we're going to do is we're going to check pulse and breathing. We have about 5 to 10 seconds to accomplish this. Remember, check pulse is the first thing we're going to check. So we check if the pulse and breathing are good. Well, we're going to monitor the patient and we're going to place, we could, for example, we could place the patient in the recovery position and start assessing the patient, right? Right? If the patient has no breathing, we're going to start rescue breath, right? Now, over here, if we're in cardiac arrest, okay, so look at the adult patient. I'll show you the slight change with pediatric patients. 30 to 2, which means 30 chest compressions for every 2 actual ventilations. We want, when the AED arrives, we're going to hook it up and see if it advises a shock or not, and we're going to allow the AED to kind of control what we do. It will walk you through everything that needs to be done, shocking, continuing CPR. This is in 2-minute cycles. We're going to keep going with these cycles. And you also, one big key I didn't talk about is you want to constantly change responders. So it'd be great if every switch, every cycle, you could change responders. That's ideal. If you have that many, that's great. When you actually do CPR, you'll see how much effort it takes only in a 2-minute time frame. So think about that too. So there we are. This is our algorithm here with CPR. Remember the early recognition, early CPR, early AED. That's what's going to help the patient. This is what we got to train so many people on this. Now, your homework. Inside EMS Skills Mastery in this course, I have a skills video. I go over BVM. I go over chest compressions. I even have a video on defib. So I want you to go watch those videos to get more keen on this topic. I promise the only difference that we're going to see as far as compressions. We talked about the depth earlier, right? 2 to 2.4 adult and PD, 1.5 we want to look at for infants. But the compression changes. So 30 to 2 is everything for adults, no matter how many rescuers. But with pediatrics, if one rescuer, you get 30 to 2, compressions, breathing. With 2 rescuers, you go 15 and 2. That's the only difference. And there it is. Hope you enjoyed the cardiac arrest tips. And when I think about it, I think about 2 things. Syncope, which is a medical term for somebody passing out. A near syncope, which is dizziness, feeling like they're going to pass out. And any patient I see with unexplained hypotension, whether it's chest pain or abdominal pain, you can have a rupture of your aorta. Now, what we're talking about here is a AAA, which is a medical emergency. What happens, it's called an abdominal aortic aneurysm. Now, you can have, we know the aorta attaches to the left ventricle. You can have a thoracic aneurysm, but that's usually more common in trauma and the, for lack of a better word, the death rate. It's a very lethal emergency. This emergency, while it is a true emergency, and you can lose a lot of blood if it ruptures, there is just a little bit less pressure in the abdomen versus right up on the left ventricle. This is more lethal than this, but this is still a true emergency, and this is a true 911 call. I remember the first AAA that I had. I remember the exact patient. I can go back to it right now. It's going to tick all the boxes when you have your first AAA. Now here it is. It's a tearing or rupturing of the aorta. It can start off as a bulging of the aorta, and they'll monitor it, and they'll monitor it, and it may have a history of it, just a dilation of it. It's an aneurysm. It's swelling of the aorta. It's not going to be pumping as strong. It's a weakened aorta, and it can get so weak it tears or ruptures. All that blood, the aorta is the biggest artery in our body, if you will. So that blood goes right into the peritoneum, and it's going to cause peritonitis, blood all in there. It's going to be a massive, massive bleed. Now, of internal bleeding, risk factors, any cardiac risk factors. So we can say SAD, CHF, smoking, advanced age, diabetes, high cholesterol, hypertension, high blood pressure, family history. But with this case, I'm looking at men 60 to 70 years old. This patient I still think about to this day, the first one I had, was around that age, and it was a man. Had a syncope, unexplained hypotension, just like I'm telling you here. Unexplained hypotension. Why did you just pass out and your blood pressure is so low? And you have abdominal pain, and you look a little pale? It's all there, right? But there's one thing that stuck out. Bradycardia. Why? This is going to blow your mind. Have you heard the vagus nerve? Well, a vagal response, when we have someone with a really high heart rate and we tell them to bear down to stimulate your vagus nerve, well, that vagus nerve, when it's activated, it causes a low heart rate, right? There are sections of the vagus nerve that are wrapped around the aorta. So when the aorta ruptures, it could cause it to be turned on and you get bradycardia. Because think about this. In every other scenario, like I taught you in shock with BLS, right? What happens? Your heart rate goes up when you try to compensate for the blood loss. You have bradycardia starting from the beginning here. You see how bad this emergency can be? This is the oxygen, rapid transport, and at the ALS level, IV fluids, rapid transport. Hey everyone, I'm back here with our next video, and it is on cardiac tamponade, and we're going to talk about a very special condition after this. So here is cardiac tamponade. What cardiac tamponade is a result, 99 out of 100 times, is a result of penetrating trauma. So it could be a gunshot wound, it could be a stabbing that involves the chest, that involves the heart. So when we have cardiac tamponade, which can also be called pericardial tamponade, the penetrating trauma, okay, again, 99 out of 100 times it's penetrating trauma. 1 out of 100, it could be blunt trauma. It's pretty strong to do it in blunt trauma. But again, stabbing, shooting is most common. It could be on your test question, out in the field. Stabbing, shootings are what this cause cardiac tamponade. What cardiac tamponade is we have the pericardium, okay? We have the pericardial sac that actually is around the patient's heart. The pericardium is the outermost layer of the heart. Hey, did you watch the A&P yet? Okay, so now we understand that. What happens if we have little tears in the side of the heart and we get blood into our pericardial sac? Well, I'm here to tell you that all we need is about 60 cc's of blood to enter around the heart into the pericardial sac. That 60 cc's is enough to squeeze your heart into pericardial tamponade. Tamponade is another word of saying to stop, to stop your heart. So this is what it is. Cardiac tamponade essentially doesn't electrically stop your heart. It's a type of heart failure because the blood is squeezing around the heart's pericardium. So the heart is unable to pump effectively. So your heart fails to pump. And if you watch the heart blood flow video, if you watch the CHF video already, if you haven't, go watch that. We all know that when the heart fails to pump, blood backs up. And when blood backs up in the venous system, here we go. We get right here, folks, Beck's triad is cardiac tamponade. This will be on your exam 100%. So Beck's triad is three things. JVD, jugular vein distension. Blood backs up into the venous system. Okay, go watch the heart blood flow. Go watch the cardiac tamponade. Actually, go over heart blood flow twice in scores. Okay, watch your A&P. Now, when blood backs up in the venous system, JVD is jugular vein distension. The patient's neck, the jugular vein will be distended. That's the hallmark sign of many things that cause heart failure, but including cardiac tamponade. Hypotension, what? Evan, why in cardiac tamponade do we have hypotension? Why? Well, because your heart is failing as a pump. If I can't pump blood, is my blood pressure going to be high or low? It's going to be low, okay? And if I went and listened to heart sounds, to be muffled because I got fluid around my heart, so I can't hear the heart as well. That's Beck's triad. So Dr. Beck, what he found was this was the three hallmark signs of cardiac tamponade. You also see narrowing pulse pressure. So you have your blood pressure more close together. Okay. Now here is a condition. Okay. Commitochorus. This is Latin for a commotion or disturbance of the heart. So this is very simple. You may have a question on this. I want you to know what it is. All it is very simple. Someone is struck with a high mechanism from, let's say, it could be a baseball, could be a golf ball, could be a lacrosse ball, could be a soccer ball, could be basketball. The force is so great and it hits right over the chest, right onto the heart, struck at the right moment to actually place the patient. It goes, for example, it can hit a T wave, and essentially the force is so great, the patient goes right into VFib, and they go right into cardiac arrest, which is sudden death. So imagine a pitcher at a baseball game, throws the pitch, batter hits it, the ball comes right back to the pitcher, strikes him squarely into the heart. That's commitochorus. Okay. Now, this is rare, but occurs in these main sports: baseball, soccer, hockey, lacrosse. Okay. So, could you be called to a young athlete? This normally occurs in young men, 20 to 40 years old, is most common. And then, could it happen in females? Sure, of course. But young people, but it just happens to be that young males get it more. It happens to be. But it's going to be young people, 20 to 40 years old. Most common because athletes, it's the most common. Baseball is the number one ranking in this. So my friends, I hope you now understand these two things. Now you're probably wondering, what do we do for this cordis? Well, we're at a cardiac arrest. We treat cardiac arrest, like your BLS algorithm. What do we do for cardiac tamponade? Well, we're going to treat the patient's symptoms, and we're going to get them to, they need a trauma hospital. They need trauma care. So then we're going to take them however we need to the trauma hospital. We're going to provide oxygen, keep the patient comfortable, and we're going to get them to the hospital. They need a procedure called pericardiocentesis, which is basically going to draw that fluid out of the heart. Okay? Now, again, just so you're aware, I talked about 60 cc's or 60 mLs. Just so you're aware, mLs and cc's are the exact same thing. It's the same exact system. Just so you're aware. Okay, friends, I'll see you in the next video. Tension pneumothorax We're at a major trauma event. Let's break down our 1, 2, 3, 4. Tension pneumothorax is the collapsing of one of the lungs. For example, if I have a bullet and I am shot over here on the right side of my chest, what's going to happen is this lung here is going to collapse, right? So I'm shot, it enters, this lung now starts to collapse, right? So it's essentially leaking air, right? Now what's going to happen at this point is we have a few things going on. One, we can have a sucking chest wound here. So there's air coming in and out of here. Well, that's bad. We don't want that. What else is going on? Well, the lung, as the air pressure starts to collapse this lung, over time, it starts off as a simple pneumothorax. And then as it gets worse and worse, the pressure gets so great, the lung, if you think about it like this, becomes all the way over here like this. So this entire, we can say right side of my chest is full of air. That is not the inflated lung. The collapsed lung is like this. What's going to happen is that pressure is going to get so great from air being outside the lung that air is going to move all the way to the middle of your chest and start putting pressure on great vessels that move blood and the heart. All the way over here is going to push. So that is why you get hypotension. You have the air pushing over on that heart, which causes the heart to actually fail as a pump because so much air pressure it's being squeezed, right? From so much pressure coming over here. The risk factor of any pneumothorax would be any traumatic risk, right? But sometimes you can't help it. And then thin, tall, young men. So let's say there was a guy, let's say he was underweight and he was 6'4", 5'6", you know, that's a risk factor, young, right? So now we understand what a pneumothorax is, right? A pneumothorax is the collapsing of the lung. What makes it a tension pneumothorax is the pressure on the heart, is the hypotension. So a pneumothorax, no pressure on the heart, no hypotension, pneumothorax. Tension pneumothorax, we have hypotension and the heart is starting to feel the pressure, starting to feel the burn, okay? Signs and symptoms. Well, the affected side where we have been struck by this bullet, for example, will have absent or diminished lung sounds and can get to the point where the chest rise and fall is even different based on the side because this is not inflating, right? So that's lung sounds. What else do we have? We already talked about the hypotension. This patient's going to have difficulty breathing. This patient is going to have sharp chest pain, and they're going to have JVD. Now, if you're at this point in the course, I hope you've watched the heart blood flow video. I hope you've watched the CHF video, so you see what happens when the heart fails. Well, in this case, the air pressure is allowing the heart not to squeeze, right? This tension pneumothorax is actually a type of obstructive shock because the air pressure is obstructing the heart to actually pump and we get hypotension. If we do nothing with someone in tension pneumothorax, they'll die of obstructive shock. Okay, it's one of the types of obstructive shock. Now, how do we treat this? Well, I got a few things here for you, but let me just go over. It's real simple. BLS level, we got to give oxygen. Remember, the goal of every patient is to get them above 94% on the SpO2, the pulse oximeter. So we do that, okay? So we're going to give oxygen. Now, what else? Well, we can do a three-sided dressing. So we can take, for example, it could be a simple dressing, right? It could, I mean, make you understand how simple this is. In countries that are, let's say, third world countries, they'll take a piece of plastic and just tape it three sides, and that works. So you take a dressing in the ambulance, okay, place it over, and you're gonna go 1, 2, 3. Three-sided dressing. Let one side be open. That's gonna do is going to allow air to escape the chest, but not more to come in, okay? That's a three-sider. And the final piece is going to be BVM ventilations. If your patient is at the point where they can't control their own airway, positive pressure ventilations can actually help that lung to actually reinflate and kind of push back from the actual pressure that's going on from the air sliding over. So your hierarchy is going to be oxygen, 3-sided, BVM. Now, if you have a scenario where the patient is still speaking in full sentences, but they have a pneumothorax, a BVM is not going to make any sense. They're still control their own airway. But once they lose control, that's when the BVM comes in. So here it is, my friends, tension pneumothorax. Hey everyone, Evan here, the paramedic coach, back here with a new video, and we're going to do some head trauma review this is for every level. It can be EMT, advanced EMT, or paramedic, but this video will be placed in the EMT section, remembering that trauma is basic life support, but everyone needs to know it. So here we go. So the first thing I want to go over is concussions. Now, in this little section here, I've gone over the main key terms that you need to know in head trauma. Basically, essentially saying, the ones that trip everybody up. We're going to understand this cold in this video. So what exactly is a concussion? Well, what it is, inside the brain we have the axons. The axons are basically the highways between one nerve and another. With a concussion, what we have is those axons getting a disruption. And it can either be mild or moderate damage to the brain in a concussion, and then we grade those out depending on what the patient's signs and symptoms are. We're going to go over that. Okay, so let's just read it here. A mild damage to disruptions of axons, which are basically the process that the brain uses to speak from nerve to nerve. This is why the patient's confused, because we have our highway system of the brain, the axons, are damaged. So we have a period of altermentation. The concussion event causes a mild, sometimes moderate impact of the skull, and the brain will move within the cranium. So when we have a concussion, we can either have two things happen. Okay, so we can have the brain move about the cranium, hitting the wall of the cranium, or we have a direct impact. Okay, usually it's both, but just be aware that we can have a direct impact or a juggling of the brain. Okay, both or one of these will occur, usually both. Now, what are the main signs and symptoms you need to know on test day? So let's go through them. The main thing that you're going to have with concussion is you're going to have confusion. So just to name a few things here, sporting events, football, rugby, any soccer, contact sports. We also have falls, which is a very common cause. And of course, motor vehicle accidents, the main three culprits here for concussion. Now, anytime we talk about anything to do with the head, if you injure your head in any way, what you need to know, we need to watch out for. It's true with concussion, but it's true with anything, any head injury. If somebody hits their head, what's the first thing you think about? Headache, nausea, vomiting, dizziness, drowsiness, right? These are ominous signs and symptoms. If somebody strikes their head, first thing I ask them, do you have a headache? Are you nauseous? Dizzy, drowsy? Check their pupils, right? We want in a head injury patient or a concussion patient, we want to see reactive pupils on both sides. We do not want fixed dilated pupils. That won't be good. Okay? Talk about that later. So, nausea, vomiting, dizziness, drowsiness. Photophobia means that you're very sensitive to light. Photophobia happens with migraines too, if you didn't know that. You can also have balance problems and even be a little combative because you're altered, right? So now let me explain to you the concussion grades. There's how many? 3. There's 3 grades to concussion, okay? Grade 1 concussions means you are indeed confused, but you did not lose consciousness, which means in plain English, you did not pass out, okay? Just so you're aware, in EMS, we use a slang term. It's a definition. Everyone uses it all the time. Okay, just so you're aware of it. LOC. They had no LOC means they had no loss of consciousness. AKA, no LOC means they didn't pass out, right? So grade 1 means, hey, they're confused, but they did not pass out. And within 15 minutes, so 15 minutes or less, the confusion's gone. The amnesia's gone. Talk about that in a minute. Grade 3 is the same as grade 1, except the symptoms continue for more than 15 minutes, my friends. Okay? Now, grade 3 means throw everything else. You are grade 3 if you have any, it could be 3 seconds, 5 seconds, 10 seconds. It could be 1, 2, 3, 4 minutes. Any period at all of you passing out, aka LOC, aka loss of consciousness, my friends. If you have any of that, you're grade 3. It's the worst type of concussion. So a boxer gets knocked out, right? They've suffered a concussion, okay? Right? What grade is it? Grade 3, because they were unresponsive. You okay? All right. Now here's what I call a buzzword alert. You got to know this. You got to know this. You know, when we do these kind of these buzzwords here, and you'll see them. As you're going through the course, you know, a lot in A and P too. These are the kind of key terms you got to know. You'll be asked about them. If you don't know them, you're going to have no idea what's going on. So let's review this buzzword. Retrograde amnesia. Retro means we're talking about the old days, the past, right? So retrograde, so back. Amnesia means you forgot about it. So this simply means, retrograde amnesia means I forgot what happened before a traumatic event took place. Football player gets hit, they don't know where they're at. Where am I? Who am I? What's going on? So if they have that amnesia for under 15 minutes and it goes away, grade 1. That amnesia stays for longer than 15 minutes, grade 2. If they passed out and they wake up with amnesia, you don't got to even think about the grades. It's grade 3. It's the worst type, right? Now, I'm just going to tell you something here. Are concussions severe injuries? Yes. They're not minor injuries. They're severe injuries, okay? So let's continue. So part 2 here of head trauma, I want to talk about another buzzword. What exactly is ICP, which is intracranial pressure? So it's an increased intracranial pressure, okay? Is increased ICP, right? So let's talk about this. So what exactly is an increase? I'm going to actually add this in here real quick for you. Because ICP just means intracranial pressure. There we go. So what exactly is increased intracranial pressure? So here it is. Okay. Now I'm going to read this out to you, and then we're going to talk about it together. Okay, so let's just do this first. Intracranial pressure is caused by either edema, which is swelling of the brain. Edema is swelling of whatever we're talking about. If I have edema in my legs are swollen. Okay. If I have edema on my heart's swollen. If I have edema on my brain's swollen. Okay. Just edema means swelling of whatever it is. So we have edema on the brain, swelling of the brain. Or it's an expanding brain bleed, which we classify in medicine as a brain hematoma, which we're going to talk about that. So when the brain swells, it becomes more difficult to perfuse the brain because of the mass swelling. The body tries to compensate by raising blood pressure. The body thinks, okay, so the brain is not getting enough perfusion. It's not getting enough oxygen. So the body thinks, I got an idea. I can raise the blood pressure. But you raise the blood pressure to the brain just gets more swollen because it's bleeding inside the brain. So all that does is expand the intracranial pressure when it's already too high and our brain is already swelled or expanding in a bleed. As you can see, my friends, it is a very, very bad cycle of events. Now here's the big buzzword here. It's called Cushing's triad. Cushing's triad is the early onset symptoms that you see with somebody who is having an increased intracranial pressure, which means either have a brain bleed, or what we call a brain hematoma to be proper, or we have swelling of the brain. So here it is. Hypertension, you raise the blood pressure. Bradycardia, you lower the heart rate. And slowing irregular respirations. Respirations slow and then they get irregular and slow. That's Cushing's triad. So BP up, heart rate down, respirations down, and irregular. So they're not normal pattern. They're irregular. They're off. Now, what did I say earlier, my friends? Any single head trauma event, we now know what's the first thing we ask? Headache, nausea, vomiting. If you have a traumatic event and you have headache and nausea, vomiting, I'm concerned. I'm concerned. So these are other signs and symptoms on the exam. Headache, nausea, vomiting, badness, altermentation. We're not going to go into story land, but the first case I ever had this was someone that fell from a construction site, and they had all these symptoms. Remember that case. Now, what are later signs? Okay, so these are the early. So Cushing's triad is not. It's these events with the brain bleed, and we'll call them brain hematoma, or even brain hemorrhage. When they continue and they go on, they move fast. So when I say earlier signs, we don't have hours to play with here. This person is going to need surgery, especially to have a brain bleed. Now, what I mean by later signs, another word of saying that could be, this is an ominous sign that your patient is about to go into cardiac arrest. So, got another buzzword here, folks. Here we go. Abnormal flexion of the body, which is decorticate posturing. Okay? In this posture, the arms go to the core. Okay? We have a flexion. So we are tight. Our legs are tight and flexed. Our arms go to the core. We are flexed. Now, did you know that most commonly, it's not a rule, but most commonly, if your patient is in, you can take this word, you can go to Google Images yourself, you can see what it looks like. You can see it, exactly the positioning. But it's your arms flexing. So flexing when you go in, extension, you go out, right? So this decorticate posturing, it goes along with another buzzword, okay? Now, there's many ways that people say this. And I've even seen instructors say this in many different ways, right? They might call it Cheyenne Stokes, Chain Stokes, Sean Stokes, Chain Stokes, a million ways to say this, okay? Now, the main thing is that you understand what it is and what it looks like, all right? So here it is, okay? So we have our Chain Stokes breathing here, all right? Now I want to show you this, okay? It is cycles of breathing fast and shallow. I'm going to explain it to you. I'm going to read it first. Cycles of breathing fast and shallow, then slow and deep, then apnea. So when somebody has this Stokes type breathing, this is very common that you see in movies where somebody is about to go into arrest or about to die. Okay, they're nearing agonal breathing. So when they first get in trouble, they have that rapid and then they go into apnea. That's it right there. You've seen it in the movies. Now you know what it is. So the decorticate posturing goes with that Stokes breathing. Now, ataxic breathing, my friends, what that is, it goes along with the abnormal extension. We're going to extend our arms, okay, like we're celebrating, but we're not celebrating in this case, okay? In this posturing here, the separate posturing, you have arms locked by your side. You have legs completely extended. You have arms that are twisted in, and they are locked out laterally. So your hands are not facing your thigh. They are turned to the other opposite direction, okay? This is an even worse sign and goes with our friend ataxic breathing. So our friend here, ataxic breathing, it sounds like agonal breathing. Well, guess what? You are one step away from agonal breathing, which means you're in arrest, okay? Now, ataxic breathing, is irregular pauses of breathing. So you're going along breathing, you're breathing slow already, and you just stop breathing for a while. Then you start again, okay? But you're not in a rest at this point, you're about to be. It's going to transition into agonal breathing, okay? Now here's part 3 of a little head trauma here. Here it is. People get confused, and this part comes from a question I get asked a lot. It has to do with different layers of the brain, the hematoma. Now, we talked about different layers in A&P, and we talked about the meninges and all that stuff, right? Now, meningitis, right? I want to talk about the layers when it comes to bleeds. So here it is. The outer layer of the brain, okay? And try to picture this in your head. The outer layer, picture a circle in your head. This is how I picture it. We have the outer layer of the brain. We'll obviously have our skin. Then below that, what's below our skin? Well, eventually we hit the cranium, which is basically our skull. Okay, the bone around our brain, right? Our protection cage, if you will. It's the most outer layer of our brain. Okay. Followed by that is the dura mater, then the arachnoid space, then the subarachnoid space or layer. It's really the space, and then the pia mater, and then we actually have the brain matter, the brain gray matter itself. Okay. So think about it. An epidural hematoma is a brain hemorrhage, a brain bleed, slang term in EMS. An epidural hematoma is a hemorrhage that occurs between the cranium, the bone, and the dura mater. It's the most outer bleed. A subdural hematoma, it's below the dura mater, occurs between the dura mater but above the arachnoid space, right? Good, because it goes cranium, dura mater, arachnoid. So subdura means we're right here. We're between the dura and the arachnoid. And if we have an epidural hematoma, it's between the cranium and the dura. Exactly. Subarachnoid hematoma is exactly where it sounds like. It's right here. So technically, we would say it's between the arachnoid and the pia mater, which is the subarachnoid space. Right? Now, how do all these things present? The same sign, the exact same sign and symptoms that we talked about here that you need to watch out for. Headache, nausea, vomiting, nystagmus, balance issues, right? The same exact drowsiness, dizziness, the same exact sign and symptoms that we talked about with increased intracranial pressure. I'll go back up here and show you. They're all right here. They're all right here. Right? Because remember, if we have edema or a bleed, it's the same. But now you understand, when you hear someone say epidural hematoma, now you know where it is. Now it makes sense. Okay? Pretty cool? All right, my friends, so this was an awesome video. I hope you enjoyed it. I hope you got a lot of value out of it. And I wish you luck on your upcoming exam. If you're watching this video early and you're getting ready for school, you're way ahead of the game, my friend. I'll see you soon. Hey everyone, Evan here again, the paramedic coach. I'm back with a video here, and we're going to go over spinal trauma. This will include, you'll see at the end, spinal shock, neurogenic shock. This is your spinal trauma lecture for the EMT Accelerator. Here we go. Before we start, I just want to say that, again, with all our trauma lectures, anyone here can get value out of this. So here we go. So the first thing we're going to go over is what the main 4 mechanism of spinal injuries are, and we will rank them in order. Motor vehicle accidents are number 1, about 40% of all spinal injuries, followed by falls, then assault, then actually sporting events is the last one on the list, but still brings a good majority. Okay, so MVA, fall, assault, sporting events. You got to think, could there be a spinal injury? Now here's the deal. Our spine is made up of 33 bones. Bones are as in the word for vertebrae in the spine, okay? So our spine is made of bones called vertebrae, okay? Now there are 5 main sections to the spine we need to know, okay? We start from the top, like the neck, right? We do our cervical neck exam, there you go, okay? Then we go down to the thoracic, the lumbar, the sacral, and then the coccygeal. Okay, so the coccygeal is basically your tailbone. Right now, I'm going to explain this to you. So look, if we have an injury to the cervical spine, I am going to say here this is the worst case scenario. Now, why is that? So you see here I put in bold the diaphragm. If we lose our diaphragm, we are unable to breathe. We're unable to inhale. Okay? So this is why we say a lot of times a cervical spine injury is the worst, right? So obviously when we have the diaphragm, you may hear the saying C3, 4, and 5, right? That's diaphragm, okay? Remember that. C3, 4, and 5 is the diaphragm. Okay, great. So cervical nerve tracts include the head, so movement of the head, neck, diaphragm, delts, biceps, wrists, triceps, hands. Basically just mention everything, your upper extremities, okay? And your breathing, and your head and neck. Thoracic, we have, one more pearl I want to give you. If I didn't mention this, is very important. Probably what these numbers are. Our spine is made up of 33 bones. It's a vertebrae. Well, there's 5 main sections. Okay, Evan, I got that. But what are the numbers next to each one? There's 7 vertebrae in the cervical, and there's 12 in the thoracic. Okay, now here we go. See 7, 12, 5, 5, 4. Okay, cool. So, thoracic is going to innervate your chest muscles and your abdominal muscles. Okay. Now, I have T12 starred. Now, why is it starred? Well, that's the point where we cross, where we say that someone is a quadriplegic or a paraplegic is T12. That's the cross section. Why? You can see clearly, move to lumbar. Lumbar affects your leg muscles. Okay, there's the para. Okay, so sacral, bowel, bladder, sexual function. If we have an injury there, that's what we can expect. Okay, and the coccygeal, well, there's nothing there. Why is that? Well, there's no nerve roots. You literally just have a bruised tailbone. Okay, if you have injury there. So let's move on to some buzzwords. So now, these are big buzzwords. The reason why I go over these buzzwords is a lot of people go through class and they end up really not having any idea what these buzzwords are because there's so much overload information. That's why you're here, okay? So now when you see this word on the test, you're not going to go, oh, what is that? You're going to go, oh, I know what that is. So here it is. Axial loading axial loading means I have a direct force striking down onto my spine. Of striking the top of my head. So let's say my head, for example, goes straight into the dashboard and right on top of my head. Let's say I'm diving into a pool. My head goes right and down, straight down, top of my head into the pool. That's also known as a compression injury. So what's going to happen is the vertebrae of the spine is literally going to fracture on itself. It's going to crumble in on itself like a building collapsing, and it compresses. Okay. So a drowning victim would have axial loading. That could be a question. Now here is the next one we're going to talk about, which is going to be the sublux. Okay. So in this case, what we have is we have a patient who either has a severe case of hyperflexion. The most severe could be of hyperflexion or hyperextension. It's a really bad car accident, and the C-spine in this case, in this severe case, this is the sublux part of it, is C-spine can actually dislocate and end up hitting the core directly. This is really bad, okay? As we can see. One of the worst injuries we can have. Distraction. Distraction involves somebody who, let's say, is committing suicide, okay? A hanging victim, okay? In this case, the cervical spine is stopped and held in place while the weight of the body is pushed downwards. It's called a distraction injury. Okay. Hyperflexion and hyperextension. Simply, flexion goes forward and down of the neck. Hyperextension goes way back, right? So the cervical spine is forward in flexion and is back like whiplash. Excuse me. The hyperextension is like whiplash, so it's very common Maybe, I know I've had whiplash before. Maybe you have too, from a roller coaster or rear-ending in a car accident. Now we're going to go over a few more things here, and then we're going to go over the two shocks, okay? So here is another buzzword, Babinski sign. Heard of that before? Here we go. When we have a trauma patient, I always say that you have a pen on your person, in your chest pocket. We take the pen, and I'm actually doing it right now, live with you. I'm just on myself, so we can do it together. If you want, get a pen, do it yourself over here. Why not? So take a pen, go to the back of your heel. Now what you're going to do is take that pen. You only have your big toe, also called the great toe. What we're going to do is we're going to take that pen and go on the opposite side laterally, slide across, and it's not slow, it's fast, like quick. And you can't really do it on yourself. I just want you to do it yourself just to go through the motion. You're not going to see much of anything. But if you do it on somebody else, what you're going to see is if they're of adult age, which we'll talk about in a second, if they're over 2 years old, their toes should curl in. That's normal. If your toes fan out when you do that, I've done this a million times on trauma patients, a million times. Sometimes it's positive, sometimes it's negative. Well, guess what Babinski sign means? It means that you have a spinal cord injury. Okay. Now here's the pearl. Children younger than 2, their toes fan out and it's completely normal. So if we keep it simple here, if a question says, could you use Babinski sign on a 1 or 2 year old? No, it doesn't make sense. Could you use it on someone older than 2? Sure. Okay, sure. You sure could, right? You're totally clear there. So there it is. It's all written out on the video too. Now here's where everyone gets messed up, and I'm going to explain this very simply to you here, is spinal shock and neurogenic shock. So spinal shock is very simple. Now here's how I'm going to frame this, okay? Have you ever heard, before you got into EMS, before you got into medicine, you ever hear of someone being in shock and they were like in a motionless state of emotional shock? You know what I'm talking about, right? Emotional shock. And they were frozen. They were frozen. Emotional shock. Spinal shock is a 24-hour period. In a 24-hour period of a flaccid paralysis state of your body that lasts 24 hours. With me? Okay. So someone has a spinal cord injury. They have a positive spinal cord injury. You see them in EMS. They're completely flaccid and paralyzed on scene. They go to the ER, still paralyzed and flaccid. The next day, over 24 hours later, when they're admitted into the hospital, they regain their leg function back, but their arm function does not come back. This is an example of spinal shock, a 24-hour period where we have a part of the body that's flaccid or paralyzed, but they still have movement. They're just in shock for the 24 hours. Make sense? Got it? Okay. Now, neurogenic shock is very simple. Now, you may have heard in other videos I say that, neurogenic shock is so similar to septic shock. Because in septic shock, the body has an abnormal vasodilation. We lose our sympathetic nervous system response. We lose that sympathetic tone, and when blood pressure just goes straight down. So we get a blood pressure in a septic shock patient of, let's say, 80/30, right? It's the same thing in neurogenic. Due to the spinal cord injury, what happens is it ends up messing up your autonomic nervous system, which in turn messes up and screws up the pathways to your sympathetic nervous system. So you lose any sort of sympathetic response, and the body is only running on parasympathetic response, which leads your neurogenic shock patient to have hypotension, to have bradycardia, then they cannot perfuse their organs. They're in neurogenic shock. And it leads to an overall vasodilation. There it is, folks. All right, these are the main pearls you need to know cold for spinal trauma. You know this now? Whew, you're way ahead of the game. Hope you enjoyed it. Watch these videos over and over and over to get it down cold. Good luck. Hey everybody, what's going on? Evan here. I hope you're doing well. It's the abdominal trauma. Let's dive into it. So the first piece is we got to understand exactly what is in each quadrant. So let's start with that. If we get struck by either blunt or penetrating trauma, we have to know what's inside each quadrant or we're not going to know what's hurt. So here we go. Right upper quadrant. Liver and gallbladder are best friends because they both have to do with bile. The diaphragm goes straight across the upper border edge, if you will, of the right upper and left lower quadrant. I'm sorry, right upper and left upper quadrant. Diaphragm goes straight across, both upper quadrants straight across. We get that. Now the left upper quadrant, I want you to think SSP, that's stomach, spleen, pancreas. Those are the main players. The spleen is the most at risk by getting struck on that side by its location. On the right lower quadrant, what we have is the appendix and the large intestine and also the female reproductives. In the left lower quadrant, the sigmoid colon, large intestine, is the main player, and we have the female reproductive. Midline centered in a little bit of every quadrant is the small intestine. Okay? And then retroperitoneal behind our abdominal wall. Retroperitoneal, we have the kidneys, flanks, flank pain, kidneys, kidneys, kidneys. Now, a few more pearls I want to give you about abdominal trauma for the exam. So, if we have a patient that has a part of bowel actually coming out, it is called the evisceration. I'll say it again, evisceration. And evisceration, what that is it could be a bowel or organ that is coming out of the skin in a trauma. 99% of the time, it's a loop of bowel because the bowel is right up against there, okay? So we cover it with a moist sterile gauze, and the outer cover is an occlusive dressing, okay? Now, there's a few more signs I want to talk about here. Cohen's sign and Gray-Turner's sign have to do with acute hemorrhagic pancreatitis. Whoa. Acute means it just happened. Hemorrhagic means there's a lot of blood. Pancreatitis means the pancreas is inflamed. So you have an acute, inflamed, bleeding pancreas that results in two signs. Cohen's sign and Gray-Turner's sign. Cohen's sign is the one that's around the patient's navel, where there's bruising patches around the patient's navel, okay? Also known as hemorrhagic patches. Gray-Turner's sign is bruising of the skin around the flanks. This comes from the pancreatitis. Now a buzzword here, hematuria. Hema, blood, okay? Turia, urea, sounds like urine, right? Blood in the urine. Okay. Now peritonitis is an inflammation, okay? So that's the peritoneum. That's the lines or our abdominal wall. Is an inflammation of the lining of the abdominal wall. Usually this happens when a hollow organ leaks its contents. So imagine we have a patient with appendicitis. We miss it. It bursts. The infection contents from the appendix burst out, and where are they going to go? Well, they're not going to go into a black hole. Where are they going to go? They're going to go into the abdominal wall, the lining of it, which is the peritoneum. It's going to be inflamed, and that causes you to become septic. Now, the other one is called a hemoperitoneum. In a hemoperitoneum, it's trauma, you see? So Kerstein talks about this. Now, Kerstein is very simple. You get struck in the left upper quadrant. You think of the spleen, right? Remember we talked about that? You get struck there. When you get struck there, your spleen ruptures. When your spleen ruptures, the spleen includes a ton of blood. So what this means? Well, the blood, again, not going to a black hole, it's got to go somewhere, goes in the peritoneum. And the peritoneum is the lining of the abdominal wall where everything sits in the abdominal cavity, right? So hemoperitoneum is blood in your abdominal cavity wall, right? So Kerr's sign is, look, this event happens when there's blood in the peritoneum. We get left shoulder pain, which is caused by the leakage of blood from the damaged spleen rupture into the abdominal wall. It's most common with spleen rupturing. It's called Kerr's sign. So in this case, you get a patient, trauma event. Let's say they were hit with a baseball bat, 5-6 times, super hard into the left upper quadrant. They're on the floor screaming in pain. You can see the damage that was done. And they say their left shoulder is killing them. You ask them, did you get hit in the left shoulder? You see no abrasions, no deformity, nothing. Spleen rupture. There it is, folks. There are 3 different degrees of a burn. First degree burns are superficial burns. Second degree burns enters the dermis partially. Third degree burns, also known as full thickness burns, can get so bad it's a charring of the skin. It is to the point where bones, muscles, tendons, and nerves become damaged and affected. Now here's a punk question you may get, a common question you might get on an REMT. Which burn is the most painful? It's a second degree. Because second degree, we enter the dermis, it's painful, a lot of damage, but the nerves are still intact. There's no sensation when a third degree burn because it's so much, that's how damage is, no nerves. So let's break these down. I'll just go through everything I've written down here for you. First degree, think of a superficial, like a sunburn. So epidermis only. This is my epidermis. Here I can see it right here, epidermis, right? The outermost layer of my skin is the epidermis. It's similar to a sunburn, right? A second degree is a partial thickness. It's the most painful. It's still a deep burn. There's still breakdown there that enters into your dermis, but the nerves are still intact. So it enters epidermis, partial dermis. Full thickness burn, it enters the dermis and a lot more than that. Bones, muscles, tendons can be affected, nerves, but has no sensation at all because there's no nerves. So these are our 3 degrees. Remember, first degree burns, okay, I can deal with it. Second and third, as we go on, it gets worse. Thermal burns, they're the most common. And it's determined based upon what the heat, how high the level of heat is, and also the contact time. Thermal burns are the most common burns that you'll see, right? Second is chemical. Chemical burns have to do with acids and alkalis. We talk here about specialized areas. What that means is you don't want an acid or an alkali to enter for like an eye, for example, your eye, right? Because when an acid or alkali burns you, it doesn't just burn you, it will make changes to the actual surface of the affected skin or eye or affected area. So that's something to really watch out for on that. It will make changes to the skin or affected area. You want to watch out for that. Now, electrical. That could be a lightning strike, electrical current, and then radiation. It's either ionizing or non-ionizing or radiation burn. These are your 4 types. Thermal is the most common. Let's go to the next part. This right here is the 3 zones of a full thickness or partial thickness burn. You're going to hear about this, and I want to make sure it's covered. Now, the way these zones work, as we go out to the periphery, to the outside, that means there is less contact time with the element of the burn. So on the most outer part, we have the zone of hyperemia. Zone 2, which is zone of stasis, is right here in the middle. And number 3 is a zone of coagulation. just know these zones. It's 1, 2, 3. And the most inner piece is most contact time. The rule of nines and the rule of palms. So rule of nines is our chart here, and I got a quick tip on the rule of palms. So here is the rule of nines. Let's break it all down. Now if I just look at the chart, everything's pretty straightforward, but there's a few things we got to discuss. So I just want to show you here how I have it set up. This is the adult patient. Okay, this is a child, 1 to 8 years old. This is an infant under 1 year. Okay, and I have labeled head, torso, back, arms, both arms, and both legs. Okay, so let's start with the head. So you got to remember that a pediatric or an infant's head is going to be larger proportional than we are as an adult. It gets more proportional. So if you look here, the head in an adult is 9%, while children and infants 18%. Now the torso, which is our entire torso here, the front, 18%. The back, 18%. Okay, the arms, so I have 2 arms, 9% across. Now here's where it gets interesting in the legs. Now legs for adults are 18%, infants are 14%. Here's the quick pearl. You may get a question on this. Every year the child gets closer to 8 years old, they go up by half, 0.5%, on how much their legs are worth on the rule of nines. So the closer they get to 8, the larger the leg is going to be as far as the rule of nines. Now what is the rule of palms? The rule of palms says take the patient's palm. Let's say they have like a burn on their thigh, a burn on their stomach, a burn on their shoulder, a burn on their back, and they're all scattered. You're trying to do rule of nines, and you're like, I can't really. The rule of palms will take the patient's palm over the burns. The amount of area that's burned, and each palm is 1%. Not your palm, the patient's palm is 1%. Now I want to give you just some guidance here. We're talking about minor burns, moderate burns, and then major burns. Also, with any burn patient, you want to be thinking about, is there a burn center near me? Is this patient a major burn or even a moderate burn? Should they be going to a burn center versus the emergency room? Now, and I'll give you a quick treatment pearl, something to keep in mind. So minor burns. So here we go. An adult patient with less than 15% of their body surface area burned would be minor. A child, infant, 10% or less, that would qualify as minor. For a moderate burn, if it is a second-degree burn, and it's 15 to 25%, that's a moderate. If it is 10 to 20% in a child or infant, that is moderate. If it's a full thickness burn, which is our 3rd degree burn, remember that, over 10%. Okay, that would be moderate. A major burn would be body surface area above 25% for an adult and above 20% for a child or infant. Okay. Now, these 3 burns are severe burns, I would say. They are severe types of burns we want to watch out for, and they can be called major burns just based on it's that type. Chemical, inhalation, and high voltage burns. So watch out for those, and especially if they're in a specialized area, again, like the eyes, right? Watch out for that. Now, how do we treat these burns, right? Well, what we want to do is we want to use dry, sterile dressings. Why? To keep infection out of the burn. That is our goal with the burns patient. Dry, sterile dressings and a rapid transport. Hey everyone, welcome to the video. This is everything you need to know on environmental emergencies, hypothermia, hyperthermia, drowning, and much more. Let's dive into it. So first, our buzzword, our key term here is thermoregulation, which all that means is we're going to maintain and the maintenance of our core body temperature. CBT is core body temperature. Now, what is the normal core body temperature? Well, it's going to be 98.6 degrees Fahrenheit, right? Anytime we're playing with temperatures here, it's going to be in Fahrenheit. Now, the body temperature, the location of where we actually regulate our body temperature, is found in the hypothalamus. And this is regulated by the brain by a thermoregulatory center. So the way that I always remember it is you have your hypothalamus. Pretend there's a little command center in your hypothalamus. And the goal of it is to maintain our core body temperature of 98.6 degrees Fahrenheit. Okay, let's move on. So now we have two things. How many things? We have two things. Well, we're talking about receptors. So receptors in the body pick up different changes. Remember, there's central versus peripheral. Anytime I say central anything, I'm talking about the CNS, the central nervous system. I'm talking about peripheral, that's different. That's going to be the peripheral, right? Nothing to do with the brain and spinal cord. Okay? Now, central thermoreceptors, again, they're found in the hypothalamus, in the brain, like I just talked about there. Neurons that are sensitive to change in temperature. That's all they are. Now, if there needs to be a change, they're going to send messages to the skeletal muscle when needed in the CNS. They'll affect your actual vascular tone, sweating, and metabolism, right? Now, peripheral thermoreceptors are found on the skin and mucous membranes. The way that I remember it is, okay, if central has to do with CNS, so it's found in the brain, in the hypothalamus, okay, I got that. So peripheral, anytime I hear the word peripheral, I think about arms and legs. Well, the periphery, the outside of your body, the skin, right? And then you have mucous membranes too. So these are just simple nerve endings that have both cold and warm receptors. These receptors help us regulate, right? So now let's talk about I'm too hot, which is hypothermia. Hyper, too much, okay? So hypothermia is simply caused by how many pathways? Two main pathways. Simply being too hot of an environment. So let's say you have the patient and they're in an environment that is just way too hot. And they've been out there for too long, right? So in this case, we think about, let's say someone who is elderly and they go walking in a park and they, let's say, get lost in that park and they were supposed to only go for a quick 20, 30 minute walk. And instead that 20, 30 minute walk, now it's midday. Now it's 90 degrees outside. Now they've been out there for 3-4 hours. That's an example of example one, which is they're just in the environment too long. Example two is usually of healthy younger people, which is they're exercising vigorously in a hot environment. So they can take the heat, but it's because they're exercising so vigorously that you put the two together and then they become hypothermic. So there's three main levels. How many levels? 3 levels to hypothermia. You need to know this cold. The first is heat cramps. The second is heat exhaustion. The worst possible is heat stroke, right? Now, how do you remember these terms? If you just look, if I didn't tell you what these were, and you said I told you heat cramps, heat exhaustion, heat stroke. Well, stroke, we know it's one of the worst things in the body. So that's the way you can remember that stroke is the worst, right? Cramps, okay, a cramp. That sounds like it's going to be the minor. Then all you have is the one in the middle, which is the exhaustion, all right? So that's how I remember it. So now let's dive into the details here, okay? So heat cramps is simply muscle cramps that develop and affect the most used or most tired muscles, okay? And they're usually caused by losing too much water and sodium. So here are the signs and symptoms of someone on exam that has heat cramps. They're alert, they're oriented, so they're not altered. Okay, this is just cramped. Excuse me. But they're found with hot, they're diaphoretic. In this case, we're saying they have sweaty skin, they're diaphoretic, all right? They're sweating. They are found tachycardic, so they have a high heart rate. but their blood pressure is completely normal. Their chief complaint is muscle cramping. Okay? And we'll talk, and I'm going to talk, once I go through these, we'll talk about, well, that's great that we know the symptoms and signs. How do we fix it? I'm going to talk about it. Now, heat exhaustion. Level 2. It's a more severe illness. Why? Well, at this point, our core body temperature is going to go up to 103 degrees Fahrenheit. And what we're going to have is dizziness, nausea, headache. And at this stage, near syncope or syncope is very common. If you don't know, syncope means, near syncope means I feel like I'm going to faint. Syncope is I have fainted. So they passed out. Okay. The big pearl with heat exhaustion, here's a big pearl for you, is they at this stage we have the near syncope and syncope, but they also show for the first time signs of blood pressure changes, which we're going to call here orthostatic hypotension. Now, what that is the person going from sitting to standing, or laying down, sitting up, laying down, standing. Excuse me. And their blood pressure changes. That is orthostatic hypotension. We have a blood pressure change when the patient goes from sitting, standing up, or laying down, standing up. That is orthostatic hypotension. So when they stand up, their blood pressure goes down. That's the big pearl with heat exhaustion. Okay. Now here's heat stroke. Now heat stroke is a nickname for it. Total body collapse. And let me fix this here. My apologies. It will autocorrect. There we go. So heat stroke is, the nickname is total body collapse. Now, when the core body temperature reaches 105 degrees Fahrenheit or higher, what's the big key with heat stroke? We start to damage tissues in the body. And the body starts to actively shut down. And there's, again, these are some more buzzwords. I talked about the two main people that have heat emergencies, but now we have to actually define these two different things. Now here it is. Classic heat stroke affects the very young and very old because they simply have spent too long in a hot environment. The classic heat stroke, this is the elderly man that gets lost in the park on a hot day. This is the young child who's left in the hot car while mom is in the mall. That's what that is. Classic heat stroke. Exertional heat stroke, that is the young, healthy athletes that's been playing basketball for too long. That is the athlete who's in a high school event, and the event is a very rigorous sport, right? And they have used so much of their energy, and it's hot out. Okay? Now, the example I gave here was playing multiple games of basketball back-to-back on a hot concrete court without water, right? So we can solve a lot of these issues by staying well hydrated. But if you're constantly an athlete and you're going, you can't, if you think about sports, we can't just stop in the middle of the game, right? Okay, pretty cool? Okay, good. Now, what are the signs and symptoms? At this point, remember, when I say total body collapse, I mean collapse. When there's someone with a heat stroke, you're gonna arrive and it's not, I think they're gonna pass out. That's heat exhaustion. Heat stroke is they have passed out. They fainted. There is a positive syncope. And if you get to that patient when they wake up, or if they are awake by the time you get there, they're going to be 100% confused, altered mental status, seizures can occur, they will be tachycardic and hypotensive. This will mimic, basically, if you think about it, someone who's in hypovolemia and they've lost so much of fluids there, right? Make sense? Now, here are the 4 pearls. So pearl 1, whether it's heat cramps, whether it's heat exhaustion, whether it's heat stroke. I want to just put a line in the sand here, okay? So here's my line I'm going to put right here. between heat cramps, heat exhaustion. Heat exhaustion and heat stroke are common EMS calls. Very common EMS. These are emergencies. If someone has heat exhaustion or heat stroke, you should probably call the ambulance. If someone has heat cramps, it's not a rule, I'm just telling you from my experience, that usually somebody with heat cramps can be treated with simply just putting fluids. So, drinking water, drinking Powerade, Gatorade, getting electrolytes back in them. That usually does the job, right? Because they need water and sodium. And what are they? They're alert and oriented to be able to do that. At this stage, if we had somebody who feels like they're about to faint, at this point they need IV access to get them back to par. And this patient who's altered and fainted, well, obviously, that one should have been called a long time ago at this stage. Does that make sense? So if we really think about this, the most vulnerable to heat, again, is the very young and very old. Because they just don't know what's going on. Or they get lost, right? So I just wanted to make sure we're clear on that. Now here are our treatment steps, okay? Step 1, get the patient to a cool environment. So if we go on scene and we have a patient who is actually hypothermic, we don't want to mess around on scene. They're in a hot environment. Or we want to literally bring our stretcher up or if we need to extricate, in a situation, whatever it may be. It could be a type of stretcher. If you might need to use stair chair, you know the whole drill with that, okay? We understand lifting, moving patients. But once we get that patient, we want to get them on the stretcher as soon as possible and move them straight into the ambulance. So we'll get a quick little history on scene, and then we want to start moving the patient to the stretcher, and then we want to start getting into the ambulance, and then we're going to do our workup, especially if we see signs of exhaustion or heat stroke. Because step 1 is we need to get them out of that environment to start to turn the tide. So put the AC on full blast in the back of the ambulance. Now, while we're moving the patient, we can grab ice packs. Place the ice packs in the neck, behind the neck, back of the neck, the groin area, and underneath the arms. Okay, this is going to help them cool down. So we obviously know we need to replace sodium and water. So how do we do that? Heat cramps, we can do this. Usually they're not calling 911 for heat cramps. They could though, by the way. And it's not that you cannot. It's not that you can't give an IV to somebody with heat cramps. You definitely can, but just usually they're so alert that at that stage still they're able to take care of themselves, rest, and do their thing, right? If we're going to be calling 911, seeing somebody with heat cramps who's lost, I mean, it's not impossible, but if they're that lost, they may be in exhaustion or stroke, right? So our goal is to replace sodium and water. Could be done orally or via an IV drip. Now here's a pearl, 2 pearls. The body's under stress. Anytime the body's under stress, we want to do an EKG if available, right? And the other pearl is altered mental status, near fainting, using a lot of electrolytes. Check a blood glucose level, blood sugar on all these patients to make sure that we're not having 2 issues, or we think it's hyperthermia and it's not, right? So now let's talk about I'm too cold. Hypothermia. Hypo, not enough. Hypothermia is described as a core body temperature underneath 95 degrees Fahrenheit. That is true hypothermia. Okay? Remembering our core body temperature is 98.6 degrees. Okay? So we have a little buffer there. Or we're truly hypothermic. Now, I'm going to explain here, just like there was 3 types with hypo has 3 types. But they don't have as much cool names. They're just named mild, moderate, and severe. Okay? So here we go. Mild hypothermia is typically between 93 and 95 degrees Fahrenheit. The goal with this patient is to get them into a warm environment. Notice that's always the first step. Remove any we have to remove if you can remember one thing about hypothermia the rest of your career, it's remove wet clothing and get them into dry clothing as soon as possible. At the very least, wrap the patient in a dry blanket after removing wet clothing. That's going to help them tremendously, more than you think. Tremendous help. Wet clothing is really, really hurting them if it is wet. Now, usually at this stage, they'll be lethargic, tired, And I wish I had a better word to describe it, but they basically will be dulled mentally. So they may be speaking a little slower. They might, if you think about it like this, think of the way someone acts when they don't have their morning caffeine. That makes sense? That is going to be kind of how this patient will be. Like almost like they just woke up, kind of. That makes sense? Tired, lethargic? Okay, cool. But they're going to be fully alert and oriented at this stage. Make sense? Okay, good. So moderate hypothermia here should be less than 93 degrees Fahrenheit, but it's still above 86 degrees Fahrenheit. Okay? At this stage, altered mental status and confusion will occur, and they'll lose the ability to shiver. So if I can tell you one thing about moderate hypothermia, they're altered, and they lose the ability to shiver. Good night. Right, that's what we got to know. Okay? Now, I'm going to talk to you here about, EKG disturbances. When we have patients in hypothermia, we don't want the patient to move or exert any physical activity. Even the slightest strain can cause a lethal EKG disturbance and get them into arrest. So we do not want to, walk this patient out. We want to do everything we can to help them with that. Now, severe hypothermia is below 86 degrees Fahrenheit, and here are some pearls. Number one, they are always found unconscious and unresponsive. Again, gently move the patient so you don't have any worsening of EKG disturbances, right? We don't want to go put them into arrest. Now, if we have this patient and they're in need of CPR and defib, you can perform CPR and defib on hypothermic patients. You can do this. Of course, you can do that. But let me talk to you about a few things about this patient. So number two here. The key with all this hoopla about, CPR and don't move them is when someone's in severe hypothermia, it almost looks like they're in rigor mortis, but they're not. Rigor mortis is when the body stiffens up due to them being deceased. But this could appear in severe hypothermia, but they're not in rigor mortis and still viable. So I like to call it like a simulated rigor mortis. It's not real. It looks like it, it's not. The patient is literally just stiff from the hypothermic event. So what does that mean? CPR and reset attempts are favored in this case versus no action in these patients. Now, here's a saying you may have heard before. They're not dead until they're warm and dead. This still reigns true today. The reason why is most EMS systems and ERs won't call a patient dead on arrival, won't call a code until their core body temperature is nearing normal before calling the code, just to ensure that it's not the hypothermic event alone that is causing all this. Now let's continue. Here is submersion and drowning. Okay, now here's the first key I want to talk about. Most drowning accidents really break down to just these categories. The first is a non-swimmer or an exhausted swimmer. An example of, let's say, an exhausted swimmer could be someone who knows how to swim, but they're trapped underneath the water, right? So they got exhausted by trying to get out of being trapped under the water, and they're exhausted. Now, how could this happen? Well, a piece of clothing could get caught, right? All types of different things. Just giving you a visual idea. Now, two is persons who suffer a medical emergency while swimming. So, for example, a man swimming out in the ocean goes into cardiac arrest. What happened? He drowned. How did he drown? He had a medical emergency, right? A stroke, anaphylaxis, right? Panics, drowns. It can happen, right? Now, obviously, the non-swimmer and exhausted swimmer is more common, and the medical emergency while swimming is obviously more rare. But it doesn't mean it can't happen, right? So I put each step here of what happens during a drowning event. So submersion is the body being submerged in the water, okay? So once the body is submerged in the water, the patient then panics and struggles. And then we have a situation of what happens first. Do we get laryngeal spasm or aspiration, right? So one of these events is going to occur first, and then the other one is going to follow right after, right? Okay, think about it. Then from there, we're going to have hypoxia, and then we're going to have death. Now, people talk about the different events. Oh, it's if you're going to drown, it's better to drown in cold water versus, warm water or hot water. Well, why is that? Well, let's talk about it. The reason why cold water may, a big word here is may, have a better outcome is because the hypothermic protocol the patient's getting, so if they were to drown, the brain is better protected, and cold water can make them hypothermic. For warm waters, there's none of that being in place. Now, the mammalian diving reflex is going to shunt blood to the brain and the heart. That's what you need to know in exam for the mammalian diving reflex. Very, very important. Okay. Now, here are 5 keys about drowning that I just want to make sure that you're clear on, because I know people have heard a lot of different things. Let's talk about it. So one is airway, airway, airway. You need to take care of this patient's airway. Okay. Now, what's the event about? Submersion, panic struggle, laryngeal spasm, aspiration, hypoxic. This is a hypoxic event, right? Whether it's they go into arrest, or maybe you get them and they're still alive, right? Either way, the airway and the ventilation is the main issue here, right? That's what caused the event. So we need to get an airway and secure our ventilations. And we need to give oxygen, right? We had some downtime there. IV EKG and follow your, continue to follow, whether they're in arrest or not, right? Usual stuff. Now, other pearls. Remove any wet clothing. That has to do with the hypothermia risk. Keep the patient warm. Again, same deal, okay? And then we're going to dry the patient and wrap the patient in dry, warm blankets, okay? So that's going to be your drowning protocol there. And my friends, I hope you enjoyed this lecture. Of course, like any of the videos here, if you watch the video over twice, 3 times, you're going to learn even more. Hope this lecture here gave you some light bulb moments, and I'll see you in the next video inside the NREMC Accelerator. I know you can do this, and I look forward to your success on exam. Let's go. Shock is hypoperfusion. Hypo is low, hyper is up. Hypoperfusion. Shock is hypoperfusion. But what exactly is normal perfusion? What's perfusion in the body? Well, we're either perfusing or we're not. If we're not, we're probably in shock. Perfusion needs 3 main elements. For our body to be perfused, what that means is the heart is an effective pump of pumping blood to the body. Number 2, we have oxygen, we have good gas exchange. Oxygen from the outside world coming into our body, crossing over the alveoli into the pulmonary capillaries, and then going through our heart blood flow, and then that is being pumped through the aorta to the cells and the tissues and everything and the organs in our body. Right, that has to be done. We accomplish that through the container of the vessels. So, we need to not be losing blood. We need to be able to absorb oxygen. And we also need our heart to be an effective pump. If one of these 3 things is off, is not in perfection, if it's not effective, really, truly, we're going to have a problem, and we can lead to hypoperfusion, which is the body not receiving enough oxygen. The tissues and the organs are not receiving enough oxygen. So, heart, O2 container. When we go over, as you'll see, in this shock section here, we're going to go through it all. Remember this, and you'll have it down. These are the 3 stages of shock. Stage 1 is a compensation stage. Stage 2 is a decompensation stage. Stage 3 is irreversible shock. You do not want to end up in irreversible shock. Like the name says, it is practically irreversible. There is damage that has been done that cannot be reversed. We want to get ourselves with the patient to not reach stage 3. Now, I have some buzzwords here. I'll share the buzzwords with you first, and then we'll get into like exact tips. So I like to think about stage 1 as the body in crisis mode. It's compensating, it's trying to fight back against the type of shock that the body is in. The body is in a crisis mode state. It's trying multiple different things, I'll share with you in a moment, to try to compensate for the shock that's happening. In stage 2, when decompensated, we call this system failure. You're not in a rest yet, you're not in a coma just yet. You're trending that way though. And what's happening here is everything in stage 1 is getting increased, and now you're getting hypotension. I'll explain in a moment. In stage 3, this is where you could call it the lethal stage. You could also call it the arrest or coma stage. That's what you'll be in that stage. Now here are some, I'm just going to read these out to you here. Stage 1, the body starts to react to the event. We have tachycardia, vasoconstriction, increased respiratory rate, and the kidneys retain fluid. Now, as far as what your patient will be like, signs and symptoms wise, they're right here, but the patient will still be awake. They may be confused and altered, and they'll have cool extremities, cool skin. And again, crisis mode. This is what we want to look at here. So in stage 1, now think about this. Let's say this patient was in hypovolemia, right? And we're losing blood volume. Well, what the body's trying to do in these early stages of shock is really bring everything in and bring all the blood into the core. So we're going to vasoconstrict, increase our heart rate, try to get more output from the body. That's what we're trying to do. But eventually we'll hit, as the shock gets worse, we bleed out, as the pump fails, whatever is going on, whatever type of shock it is, we'll end up in decompensated. Decompensated, if I can give you one definition, one thing to remember, decompensated shock, stage 2, this is where we lose our systolic blood pressure of 90. We're not perfusing our organs anymore. This is where we're at right here. This is the, system failure stage. So what's going to happen is it's hypotension. We have the first hypotension in stage 2. The confusion, altered mental status gets worse. You can in this stage be unresponsive. It is possible, but you're going to be at least severely altered mental status, semi-responsive. Your tachycardia, it gets worse. So let's say you were 110, 120, now you're 130, 140s. Your respiratory rate, let's say it was 22, 24, now it's 28, 30. It's getting worse. Look out for these buzzwords: delayed cap refill, cyanosis, right? And then cold extremities. Everything is going to go into the core. Stage 3, nothing good here. Severe hypotension, lethal EKG changes. What I mean by that is you're going to go to VTAC, VFib, bradycardia. The heart rate goes down first before we go, and then arrest coma, the final. So here are your 3 stages of shock. Remember, compensating, crisis mode. System failure, arrest coma. There it is. I want to go a little more in depth on how the body actually compensates and show you where it is in the body. Now, did you watch A&P Mastery yet? Is it in your study plan? If it is, check that out. Make sure you go over it. I'm going to give you a little preview here, so let's get into it. How the body compensates stage 1 of shock. So there's 3 pathways, you could say, if you will, here. The sympathetic nervous system's going to activate. 2 different hormones are going to activate. And the adrenals, got a hormone there too, epinephrine, going to activate. These measures are used to keep you alive in compensated shock. It's trying to fight back against the shock. Okay, now here it is. The sympathetic nervous system is going to release all its hormones. Heart rate increases. Vasoconstriction is going to increase. So the blood vessels are going to get tighter, increasing the blood pressure. The heart rate is going to increase. The contractility of the heart is going to increase. How strong the contractions are. The goal of this, the body's trying to do, is increase its cardiac output, which is how effective the heart is at its job. Okay, think about it like a report card for the heart. Now the hormones. The pituitary and the adrenals. So the pituitary is going to release ADH. The adrenals are going to release aldosterone. They have the same goal, which is to retain and hang on to sodium and water. The adrenals are going to release good old epinephrine. And epinephrine acts on 3 receptors to help out. So the alpha receptors vasoconstrict. The beta 1 receptor increase heart rate, increase strength of contractions, contractility. Beta 2 open and dilate the lungs. And also with all this epi going on, you will get an increase of cerebral to the brain blood flow. So this is how the body compensates, and a little more in depth, now you know it. This right here is the 4 types of shock. The first type is cardiogenic shock. Cardiogenic shock means it's a primary heart problem, meaning the heart itself is having an issue and causing shock in the body. Remember, we first went over shock. The heart needs to be able to pump effectively. In cardiogenic shock, it can't do that. The heart is either having a heart attack, which means the heart muscle is dying, or congestive heart failure is going on. One of the sides of the heart is failing, or both, and it's causing heart failure. Now, I give you a treatment plan here with shock. Over here I have some examples of what you might do at the BLS level. Down here I want to show you everyone in shock gets oxygen, keep them warm, vitals, reassess, rapid transport, and as soon as we recognize shock, I would like you to, in the field, put in a patch to hospital. Well, at the hospital, know as early as possible, we're bringing you a shock patient, and then you want to get them moving, right? In a smooth fashion off scene. Okay? Now, let's say they have an MI and you think they're in cardiogenic shock. We give oxygen, get above 94%, and we can do aspirin as long as they're awake. Okay? Obstructive. We have tension pneumothorax, pulmonary embolism, cardiac tamponade. Why are these here? What does this mean? Obstructive shock, what it is we have blood flow that's stopping in the body, but blood flow is being stopped. Why is that? So what happens here is tension pneumothorax. Let's say I get shot over here, the pressure comes on the heart, and it's but air pressure, the heart can't move. So the heart can't pump, it's being obstructed. Pulmonary embolism, we have a clot in our pulmonary arteries. We're obstructed. Cardiac tamponade is going to be essentially an inflammation around, caused by trauma, around the heart, so it can't pump effectively. So this is obstructing blood flow. But it's not the heart's fault. The heart isn't having a heart attack. The heart isn't failing as a pump. These other factors are messing with the heart's ability to pump, right? So what we do here is an example. Let's say with tension pneumothorax, give oxygen. We can do a 3-sider for tension pneumothorax. And obviously, if your patient wasn't awake, we can do BVM ventilations. Okay? Here is distributive shock. Distributive shock has the one with 3 subtypes. Say it with me again. Distributive, 3 subtypes. Anaphylaxis, septic shock, neurogenic shock, right? Anaphylaxis, a severe overreaction to an allergen. Septic shock, very commonly pneumonia, UTI patients. If we get bacteria in our blood, we get sepsis. When that sepsis becomes hypotensive, we end up in septic shock. Neurogenic shock has to do with the brain and spinal cord. There's damage, there's injury there, okay? So let's just say we have a patient with anaphylactic shock. We do oxygen and an EpiPen for anaphylaxis, okay? Hypovolemia, what do? Well, there's trauma. We could be internally bleeding, losing blood. So it could be external trauma, internal trauma, don't forget that. Or it could just be literally severe fluid loss, severe dehydration. You're hypovolemic, right? You're losing volume, right? The goal is oxygen in it for the bleeding out event, if we can do it. Stop trauma, if you have quick clot, use something to stop the bleed. Stop the bleed, direct pressure first, work your way up. O2, keep warm, and rapid transport are your hallmarks of shock care. Hey everyone, let's dive into seizure disorders. By the end of this call, you will have seizures down pat, and you will be at a really, really high level as far as seizures. So here we go. So first, let's define what a seizure actually is first. So a seizure is usually, and we're going to talk about it, a brief alteration of the patient's behavior or consciousness, okay? So it has to do with an abnormal electrical activity in the brain's neurons, right? And we're going to talk about the 2 different types of seizures that there are. There's two main types and there's subtypes. So remember, if you watch the video on shock, there are main types and subtypes. Same with seizures. There's main types and subtypes. So we got to know them, and we're going to know all the buzzwords, and we're going to know all that stuff. So get ready for the ride. It's going to be a great lesson here for you. So a patient can either have a seizure disorder, or they can have a seizure because they have a certain illness, because they have a certain infection, because they have a certain emergency, okay? So here is a quick list I put together for you of the most common emergencies where seizures can develop. Alcohol withdrawal, medication withdrawal, sedatives. Like, let's say you were coming off benzodiazepines, right? Like, to name a few, Xanax, Ativan, right? Let's say you're withdrawing off like opiates, for example, like oxycodone, OxyContin, morphine, right? Strokes, head injuries, very common. Toxins, drug overdose, brain tumors, very common one again. Eclampsia. Eclampsia is literally defined as someone who's preeclamptic and then the seizure happens, now they're eclamptic. So, of course, that's one. Hypoglycemia, one of the most common calls in EMS. And sepsis, infection, fever pathway. Sepsis is bacteria in your blood. Infection, just an infection. And fever is, well, your temperature raised up because your infection is attacking your body. So here's a pearl. In EMS, of course, we want to, have an idea of what's going on with our patient. Why? Like, we want to understand why this is happening. But really, here's what we want to figure out. Can we stop the seizure? Do we have meds that can stop the seizure? And then two, we'd like to figure out if we can reverse these effects from occurring. So, for example, if we go up here and look at these emergencies, just to give you an example, hypoglycemia, we can fix that, right? Now, can we fix a lot of other things? Not really. But can we treat the patient's symptoms? Sure, we can. Can we make sure that they're stable? Sure, right? Can we, do the ABCs? Sure. Airway, breathing, circulation control? Sure, right? And we get them in the appropriate hospital, right? Okay, so that's our goal here, right? But we do want to relay the best information. And here's the big thing. We're the one on scene. The doctors and nurses aren't on scene. So we got to tell the story of what happened, especially if the family isn't coming to the hospital. So we really got to know about and describe what happened so we can understand what type of seizure may have happened. You with me? Here we go. So two buzzwords I got for you first, okay? What is a recurring seizure episode? So what do we call a disease where the patient has seizures? They're known for having seizures all the time. That's epilepsy. So epilepsy is a disease where someone is known to have seizure activity. Now this is different from status epilepticus. So status epilepticus, think about it as it's a status, it's a code red, it's a status epilepticus. This is a really bad emergency. It's under status, okay? So it is defined as a seizure that will not stop. There's no postictal periods. It just keeps going. You'll see what I'm talking about later by that. Keeps going. And it lasts over 30 minutes in duration, and it keeps coming with recurrent seizure activity. There's no pauses. This is a life-threatening emergency, status epilepticus. Now, there's two main types of seizures, and they're categorized by generalized or partial seizures. In generalized seizures, we do not know what area of the brain is actually being affected. We just know what they look like and appear like. In partial seizures, we can actually know, oh, that's the lobe. That's the lobe that's affected in this seizure. In generalized, we have no idea. Okay? So here, but we determine what type of seizure it is by what is seen when the patient has a seizure. Now, I just want to bring up two things. When are we actually going to see a seizure in EMS? Well, actually seeing seizure activity in EMS is actually more rare because it takes a few minutes to actually get to the actual, home or apartment or building or wherever the patient is, right? So most commonly, you're going to see seizure activity when it happens right in front of your eyes in the back of the ambulance, which has happened to me many times, or you're going to see seizure activity in someone who's in status epilepticus, and they're still going while it took you, 10 minutes to get to the house, right? Okay, so let's continue. So generalized seizures there's 4 types. How many types? Hey, how many types of generalized seizures are there? How many types? Well, there's 4 types: absence, atonic, myoclonic, and tonic-clonic. Now, these seizures, again, they don't have a focus in the brain that we don't know. We just know what they look like. So here we go. Absent seizures are called petit mal seizures. Now, I didn't name these, okay? I just got to tell you about them, all right? So absent seizures are petit mal seizures. These most often occur in children from 4 to around 12 years old. Now, hear my words. Absence seizures will simply have a brief loss of consciousness of about 15 seconds, but the patient keep their posture. They don't collapse. So they just essentially, in layman's terms, they just pass out, but they keep their posture. Okay, it's an absent seizure, hence the name. There's no motor activity usually seen. Again, lasts about 15 seconds or so. When the patient wakes up, they appear completely normal. But of course, when they're having the event, they're not responding, right? This is a very common call you'll get for children. Now, later in life, if they're having these and the doctor, for lack of a better word, prescribes them of having a seizure disorder, later in life, in their 20s, they may have grand mal seizures. We're going to talk about that as we're going along. Okay, now don't forget, how many types of generalized seizures? 4 types. We're still under that realm, okay? But I got to keep moving. Here we go. Atonic. Atonic seizures, the patient will lose muscle tone, will lose their posture, and they'll suddenly collapse. That sounds much different from the absent seizure, right? A nickname for these seizures are drop attacks. So these are the type of seizure patients that you see wearing helmets. So not only do they have a primary seizure disorder, but they're commonly the victims of falls and trauma. Okay? Helmet's the key thing with atonic. Hey, what type of seizure disorder wears a helmet? Atonic. Okay, myoclonic. So this is very simple. This is the first type. You're probably wondering, Evan, if you're just learning this for the first time, you're probably saying, Evan, I thought a seizure was when they move their muscles around. Well, we're getting there. A myoclonic seizure, myo means muscle, okay? So myoclonic is the first type of seizure where we have brief muscle contractions that usually occur on both sides of the body. That's myoclonic. This is different from, they call the grand mal seizure, the tonic-clonic seizure, which has a tonic-clonic phase and a post-ictal phase. So here we go. The tonic-clonic seizure is what we call the classic seizure that everyone thinks about in shows and movies and everything like that. So here we go. These are also the first seizures that have the aura, or the feeling of the patient. An aura is the feeling the patient describes right before, like seconds before they're about to have a seizure. It could be a smell, it could be a sound. Now this seizure usually will start off with the following. And I'm going to break it down for you, okay? So let's start with this first piece. This seizure causes loss of muscle control and loss of consciousness. So we got a lot going on here. Here are the phases, and here's what they look like. Here we go. The tonic phase only lasts seconds, not minutes, okay? The tonic phase, you have flexion of the muscles, and you have apnea. Apnea means A, I'm not doing whatever I'm talking about. Apnea is I'm not breathing. Tongue biting, urinary incontinence are common here. Again, tonic phase lasts only seconds, not minutes. The clonic phase is the one that lasts minutes. Okay, how long? About 1 to 3 minutes is the clonic phase. What is it? The clonic phase is where the body goes rigid to relax, rigid to relax, rigid to relaxed. It cycles for about 1 to 3 minutes. Hey, which phase lasts minutes? Clonic. Hey, which one seconds? Tonic. Oh, okay, thanks. So what does this mean? By definition, a tonic-clonic seizure and those two phases are going to, the average grand mal seizure is going to last how long? At least a minute, right? Exactly. At least a minute. Could be anywhere from 1 to a little bit over 3 minutes if you add up, 3 minutes and a few seconds, right? So what is this postictal phase? The postictal phase occurs like this. We have the aura, then the tonic, then the clonic, then postictal. As we're going from clonic to postictal and we're having that relaxation phase, we then go into a brief period of unresponsiveness and unconsciousness. Okay? The patient will then awake. When they awake, they will be combative, but fatigued and confused, and ultimately they will become, honestly, from my own experience, they become a little embarrassed of the events. Okay? So, anyone during this phase, you want to kind of, make sure that they become awake enough to move. But once they're able to move about and they're coming out of their postictal phase, we want to get them away from any of the general public, just decency for the patient. Okay. Now, that's it for tonic-clonic. That's the pearl there. Now you're probably wondering, Evan, what about partial seizures? And then, well, you told me what it is. What do I do? I'm coming. Don't worry. Here I come. Partial seizures. We have simple versus complex. And there's how many types? 2 types. Let's go back. How many types are there for generalized seizures? 4. Oh, okay. Just want to make sure you got it. Partial seizures, how many are there? 2. Simple versus complex. Okay, here we go. What's the difference between generalized and partial? Generalized, I have no idea where it's coming from, but I know what it looks like. Partial. Oh, that's the lobe. That's the lesion of the brain that can be identified. Here we go. Simple partial means we have an event where the patient typically does not lose consciousness. So they're still awake, okay? And this activity is categorized under clonic activity, okay? So remember what clonic is. We have that rigidity and relaxing, and it's active on just one body part. So it could be like one foot, one arm, one leg, right? To give you an idea, okay? So there's also a little subtype called simple sensory seizures that might affect their smell in an odd way, or numbness of an extremity, or taste, or a visual disturbance, okay? To give you an idea. Now, complex partial, we can pinpoint these to the temporal lobe, and they actually include an aura, okay? Now, to give you an idea of signs and symptoms, these are the patients that, I don't know what my father was doing. He was smacking his lips. He was chewing. I don't know what he was doing. This is a complex partial seizure, and then it lasted about a minute, and then the patient comes to. But they have no memory of the event, and they're like, "What are you talking about? What do you mean I was doing that?" Lip smacking, chewing, swallowing, those like automated movements, and the patient's not in control of it. It's the seizure. Lasts about a minute. Now, just so you're aware, partial seizures do not mean that you're about to have a generalized seizure. But you could. It is not impossible. It can happen that someone has a partial seizure, and then during your care, they can develop a generalized seizure. Just so you're aware, you want to be on the lookout. Can I give you a pearl? Let me give you a pearl. And I know we're in the BLS, but, I tell all the medics in this program, hey, you should really, go over the BLS, because BLS is still part of the, AMT and medic exams. So I'm going to mention this part about paramedics is, if you have someone with a seizure, a partial seizure, and now they're awake, or you have somebody who had a seizure and they're postictal, you should have your narcotics out of the lockbox, like in your pocket. So commonly, I'll give you an example. You're going to a seizure call. As we're getting dispatched, I'm taking the narcs out of the cabinet, putting them in my pocket, so I can go on scene with the narcs. So I'm not running back to the narc box in the ambulance. Okay, pretty cool. Okay, good. Hey, you can also help your medic with that too, right? So that helps. Okay, last piece here. Now that we know all that, that sounds great. Well, we're going to be on the 911 call. What do we do? So let's start with these two pearls. Now you have the information here. I'm going to go kind of all over the place. I'm not going to follow like the line by line. You have it all here. Take notes on it. Be sure to watch this video again over twice. What do I always say, my friends? You'll watch something once, you get light bulb moments. You'll watch something twice, you know it cold. So find a time to watch this video over again so you know it cold. And hey, for a lot of us, taking notes helps. For a lot of us, recording yourself. You write your notes down, you record the notes, listen back to it. That works. There it is. Now let's wrap this lecture up. So, first thing I want you to know is that oxygen and blood glucose are used a lot in seizures. So you want to get a pulse oximetry reading, and you want to give oxygen if they're postictal, and you also want to check a blood glucose level as soon as you can. Once somebody is in the postictal phase of their seizure, what we do to protect someone having a seizure is we don't want to touch them or move them or move their limbs. The recovery position, okay, the left lateral position is where we want to recovery, also known as recovery position 2, is where we want to actually go ahead and place the patient. Okay, so that's going to be our placement. They wake up in the recovery position, pulse ox, glucose, oxygen, great. Now what else? We want to make sure that if we're on a scene, maybe we don't have meds to stop the seizure, if we're, of course, BLS, then what do? Well, we want to remove anything away from, let's say the patient's having a full tonic-clonic seizure in the middle of the living room or out in public. We want to remove anything that they may hit into, like a table or chair, okay? And again, get them on their side and then let them have the event, okay? Right, postictal. Now, the final piece here is, if we're able to stop the event with Versed or Ativan, for example, and we're a medic, now people say, oh, you could just do an IV. Okay, well, so having an active seizure, I'm really going to start an IV. That makes no sense. You would go intranasal, which I don't recommend. I recommend going actually intramuscular is what I recommend. But it's completely up to you. IM works. IN works. Different medics, different things. I like intramuscular. They both work. And that's what we have, folks. So what do? Recovery position, vital signs, pulse oximetry, blood glucose. If we can stop it and we're ALS, let's stop it. Protect the patient from getting hit by anything else. And then do a little detective work. Some questions to ask. Has the patient ever had a seizure before? When was their last seizure? What are their current seizure medications? Another question you can ask, were there any changes in their medications recently? When was the last time this patient saw their seizure doctor, right? Have they ever been admitted to the hospital for seizures, right? Did this seizure activity look different from the last time they had a seizure? Questions to ask. Hope this helped tremendously. You watch it once, watch it again. Let's go. I'm proud of you. See you next time. There are 3 types of diabetics. Type 1 diabetics, it's sort of like a autoimmune phenomenon, meaning the body attacks itself. Type 1 diabetes, usually diagnosed early on. It could be childhood, early teens, young adults with type 1. 12 years old is a good frame of mind around that time frame. Could be earlier though too, but just keep that in mind. What happens is, it could be genetics, for example, that can cause this. The body starts to attack its own insulin-producing cells. So you're literally destroying what you already have. It's like an autoimmune type. So with type 1, they don't just need, they must have insulin. They need it. They don't have any insulin in their body. Type 2 is different, and I'll read it to you here. It's a decreased production of insulin and or low or faulty insulin receptors. Usually happens to adults over 40 years old, overweight or obesity. Let's talk about a few of these things. So first off, your insulin receptors, they don't work as well as they used to. So that can be it, right? Now, what about this overweight and obesity issue? Well, think about it like this. You know how people that are overweight or obese, their blood vessels, they have more blood vessels, so the heart, it's like they have expanded highways throughout their body. So what happens is the heart has to pump like harder and faster to support all this extra highways of the body, if you will. Well, the same thing is if you're overweight or obese, there's just more to you, meaning that in type 2 diabetics, there has to be more insulin receptors. There has to be more production of insulin, so it wears out faster. This can happen with adults over 40. The majority of people diagnosed with diabetes are actually type 2. So watch out for this one. You almost see it. Now, one thing I want to talk about briefly here. All of the type 1 and type 2 diabetes medications, if you want to follow up on this, is in Prescriptions Medications Mastery down below. You'll see them there, okay? Type 2 is most of the time just pills, but they could be on insulin if they're really bad. Type 1 is getting insulin. And the final one here is gestational diabetes. Diabetes that occurs to a patient who's pregnant. The majority of the time, once they give childbirth, it goes away, but sometimes it can last for 5 to 10 years after the fact. Hypoglycemia, also known as a low blood sugar or a low blood glucose level. Hypoglycemia, let's break down these 4 steps. Number 1, what is it? Well, it's defined as a blood glucose that is under 70, but symptoms usually are not present until 60, right? So textbook definition is going to be 70 or under is hypoglycemia, but usually there's a kind of a gray area between 70 and 60 if you'll see symptoms in people, and then under 60, you're going to see symptoms 9 out of 10 times. 60 is the number, right? A field tip for you outside of the exam, every diabetic is different. So you can have diabetic A who, when their blood sugar is 40, they're still awake and talking to you, but they're a little confused. And then diabetic B, when they're at 40, they're unresponsive in a coma. So 2 different people, but no, under 60, you got to take action on it. You can't just let it sit there, okay? What are the risk factors? Well, physical activity, so like vigorous or like maybe a new onset of physical activity. Remember, hypoglycemia can occur in anybody. Now, we're talking about diabetics, but hypoglycemia, if you can just not have enough blood sugar in your body. It's possible, right? So physical activity, too much insulin being given, that's for the diabetic. Gave them too much insulin, they didn't need that much. And drugs and alcohol can cause, wacky effects like hypoglycemia. So altered mental status, here are your quick signs and symptoms. Number 3, altered mental status, confusion, combative with cool, clammy skin. That is it right there. And what do? Well, if the patient is able to maintain their own airway, they're awake, and they're still at the point where they're of sound mind, we'd give oral glucose, right? Now, I know this is an EMT level video, but I just want to tell you the next step, just so you know it, okay? Oral glucose is for EMT, but the next step would be delivering a medication called glucagon, which would be intramuscular or intramuscularly. And the way that works is essentially the liver can change its stored glycogen, put it in the bloodstream, and transfer it over to glucose. So your liver will hang on to that. So if you have any stores available, it can release it, and glucagon does that. That's the next level up. The next level from there would be starting an IV and actually going ahead and giving dextrose sugar. So you can hang an IV bag of something called D10. Maybe it'll help your medic set that up if you know how to spike a bag, and then go ahead and give that. So that's what we're looking at as far as the treatment plan. That's what you'll see when you show up at hypoglycemia. Diabetic ketoacidosis is a state of hyperglycemia. If your diabetic patient has hyperglycemia, they're going to end up here. DKA, this is what happens in the body. Your patient takes in glucose, and glucose is hanging around the bloodstream. We know that the cell, it needs energy, which is glucose. So insulin is the key that unlocks the door, so glucose can go in the cell, and then cell's happy and gets the energy, right? Glucose is happy, it's in the cell. Insulin did its job, it's happy too. If we don't have enough insulin, or there's a high insulin resistance, like, look, this key isn't working, right? Then here's what happens. Our glucose stays in the bloodstream and it goes up and we end up here in DKA. So it gets so bad with DKA that the glucose is still hanging around. Your blood sugar is 300, 400, 500, 600, high on the glucometer, HI on the glucometer, right? And what happens? Well, what happens is your body can't get energy. So it looks for something different and it goes to fat. It goes to its fat, right? So any fat stores, it's going to start to attack those for energy. Now, infections, stress, no insulin being available, that are some of the things that can cause DKA. Coming down here, these are our clear-cut signs and symptoms. Warm and dry skin, tachycardia, abdominal pain, and that fruity breath odor we get from being in a metabolic acidosis, okay? Now, what is Kussmaul breathing? Well, Kussmaul breathing has to do with your body trying to reduce the carbon dioxide level. It's trying to get rid of the excess carbon dioxide. Kussmaul breathing is deep and rapid. So an increased respiratory rate and deep breathing and rapid. That's a Kussmaul breathing that goes with DKA. There it is. Esophageal varices. A lot to unpack here. Let's dive into it. Let's do a 1, 2, 3, 4 breakdown. Esophageal varices. These are thin-walled veins that are normally just fine. In a normal, healthy patient, there are veins that are found in the lower part of your esophagus. So picture that first, right? Now, if you're a patient that has advanced liver disease, cirrhosis of the liver, alcoholism, you can have something called portal hypertension. Now, what this is, I'm going to explain to you here, and we're going to walk you step by step. Let's go through it. So, esophageal varices, veins found at the lower end of the esophagus that can become enlarged as a result of portal hypertension. Okay, so we know this thing called portal hypertension is causing these normal veins in my esophagus to swell up. What is portal hypertension? How does this happen? Hang with me. Portal hypertension is an increase in the portal venous system. So the portal veins are being enlarged, right? There's more pressure, okay, in the venous system, which carries blood from the digestive organs to the liver. So the entire portal system is essentially under stress, under pressure. So what happens is these esophageal veins, which is part of that system, if you will, is going to enlarge. Is going to get engorged, right? So these veins that are in the lower part of my esophagus that are normal, they become backed up, they become engorged. And the first thing I said was, these are thin-walled veins. So now you have a lot of pressure under a thin wall in your esophagus. You have veins in your esophagus that have a thin wall that are engorged. They can rupture now because of the portal hypertension. Now, hear me out here. Risk factors: alcoholism, hepatitis, liver disease. Okay? What happens? The patient will not call you and call 911. They might not feel any symptoms, but they could call you if they have other symptoms, but not for esophageal varices. Somebody calls you for esophageal varices when that thin wall ruptures, right? Now, a food bolus could nick it and open it up under pressure. Could happen. The actual hypertension itself can get so great that it causes it to rupture, right? Like, think about it. A brain attack, right? A stroke, a hemorrhagic stroke could burst out. Same with this, it burst out, right? Because that so much pressure, the high blood pressure, it's not normal, so it bursts. When it bursts, what happens? The esophagus leads to our stomach. What you get is bright red blood going into the stomach, but then blood can't sit in the stomach, so you throw it back up. So it's a constant cycle of drops, you throw it up, drops, you throw it up. So your patient is actually having an internal bleed right now in front of your eyes and is vomiting bright red blood. And what's right next to the esophagus? The airway. So you got a patient who's having internal bleeding, can't control their GI because they're constantly throwing up from the blood from their stomach. And then we have a potential airway issue if they're having a hard time with this vomiting up. So we can easily have an airway issue and a shock patient at the same time. So what do? BOS level, manage the airway if needed. If they get to an unresponsive state, we need to suction, manage the airway, get your suction stuff ready. Rapid transport, explain, patch what you have going in. Reassess vitals every 5-10 minutes, and then you're going to treat for shock. Right? Get ready. So if you have esophageal varices, get your suction ready. Get the airway stuff ready. Do rapid transport. Don't wait around. Esophageal varices, it can be a life threat. Hepatitis, let's break it down. Anything HEPA in the body has to do with the liver. By the way, where's the liver in the body? It's the right upper quadrant. Have you done your A&P yet? I hope you did. All right, let's continue. Hepatitis. Now, anything that ends in itis is an inflammation of what we're talking about. So, hepatitis means you have an inflamed or infected liver. And that's where? Right upper quadrant. Where might you feel pain? Right upper quadrant. Let's continue. So, it's inflammation of the liver. It can be inflammation. It can be infection. This can be acute, like it just happened, or a chronic issue that someone lives with, okay? Now, we have hepatitis A that comes from food or water. Hep B, C, and D is blood or sexual contact. E is going to be water or food, all right? Now, here are the risk factors. Alcoholism, drugs and alcohol, sharing needles, so drug use like that, right? Also, medications can have adverse reactions and cause hepatitis. Autoimmune diseases, again, other infections, right? Viruses, it can happen, right? Now, what do we do here as far as signs and symptoms? Well, abdominal pain, right upper quadrant, okay? It's abdominal pain, nauseous, vomiting, general weakness, kind of malaise, like I'm just tired feeling. Jaundice means a yelling of whatever we're talking about. So I'm talking about yelling of the skin and yelling of the eyes. Okay, it's jaundice. We have fever, and then we have dark urine. It's kind of almost like a flu-like symptom, right? A little bit, yeah. So those are the symptoms. Now, what do we do at the BOS level? We want to recognize when we're dealing with a hepatitis patient. We want to be there for them, and we're going to transport with vital signs. If the patient, in this case, had stable vital signs, okay, patient goes basic life support, take them to the hospital, the nearest facility they want to go to, great. If this patient, let's say, was unstable vital signs, that's where we want to kind of go, all right, let's see if we can call a medic if the patient was unstable. That's my care direction on hepatitis. Appendicitis is an inflammation or infection of the appendix. Our appendix lies in the right lower quadrant. Now, the reason why appendicitis is so talked about and everyone knows about it is for this reason. If your appendix is to burst and it bursts itself and its contents in your abdomen, you can get something called peritonitis, which can lead to sepsis or an infection in the body. It can cause septic shock in your patient. Now let's break this down. So, appendicitis, enzinitis, inflammation of what we're talking about, the appendix. The appendix is in the right lower quadrant. This is my right hand. There it is. This is an inflammation of the appendix or infection. If the appendix bursts its inflamed contents into the abdomen, sepsis will occur and can lead to septic shock, peritonitis. There it is. Okay. Now here we go. Number 2, risk factors. Family history. More in men than women, but I've seen it in both, but more than men. And then most commonly, the ages between 8 to 25 are when this can occur, But again, I've seen elderly patients have this, so don't think it's not just for young people, just more common. Okay, it's a risk factor, right? But anything can happen. Now, number 3 is our signs and symptoms. So pain starts over the midline with appendicitis. As the appendicitis gets worse, or as hours and days go on, the pain shifts over. So here's a little thing you can do to learn about this McBurney's point that I'll explain to you about. Take 2 fingers, put it on your belly button. 2 fingers and put it on your front hip. I want you to look at yourself and go 2/3 closer to your right hand, which is on your hip. Press down that area right there. That is your McBurney's point. When you press down and let go, that's called rebound tenderness if you have pain when you release. That rebound tenderness at release, that's on McBurney's point, that is a sign and symptom of appendicitis, right? So what else? It's almost like, sounds like, again, like flu-like symptoms a little bit, but you know, you're weak, you're more tired, nausea, vomiting, fever, chills, abdominal pain, right? You can have some GI stress. That's what you're looking at with appendicitis. At the BLS level, what are we going to do? We're going to keep the patient calm. We're going to transport them, get vitals, transport to the hospital. Same deal here. Vitals are stable, BLS to hospital. Vitals are unstable, might you want to call a medic. There it is. Let's break down some vital signs. Now, I've chosen 3 different patients to just show you the difference in vital signs by age, right? When you're dealing with a patient, now there's different patients, right? There's neonates, which is like a newborn baby, right? A newborn, right? We have infants, right? Up to about 1. We have toddlers. We have preschool age, which I'll show you here, right? 3 to 5 about there, right? Then we have school age children. Then we have adolescents, adults, right? I want to show you 3 different patients here. So we have an adult patient, a full-grown adult patient. We have a 5-year-old child patient, right? They call it preschool age, okay? And then we have an 11-month infant. So let's break this down. So the blood pressure in a normal adult is 120/80. The heart rate in an adult is around 60 to 100, and the respiratory rate is 12 to 20. The only thing I want to talk about here is that if you have a patient who is an athlete or a runner, someone who exercises a lot, don't be so scared if you see their heart rate even in the 40s or 50s. It's very common to see. If you see that in your patient, you want to ask them, hey, is your heart rate normally in the 40s or 50s? Do you exercise a lot? If they say no, then you should be concerned, right? If they say yes, note it and just monitor the patient. Simple, okay? They did call the ambulance, right? 5-year-old child, let's say 100/60. And that range is good. Now with children, just like adults, every patient's different. But these are what we should be looking at as far as vitals. This does not mean that every 5-year-old is going to be, if they're not 100/60, they're not perfect. I know you want a clear-cut answer, but it's a range. This is like a normal land, if you will, we want to find. So a 5-year-old child, 100/60. Heart rate, 80 to 120. These are good normal ranges. And respiratory rate, 20/30. An 11-month infant would be 90/54. Good blood pressure for 11-month-old. 80 to 160 on the heart rate. The thing about infants is when they're in activity versus rest, their heart rate can change greatly. Keep that in mind. Respiratory rate, 30 to 60. Remember these ranges. I like this because you have the adult, you have like the 5-year-olds kind of out of the toddler, infants. They're getting almost to that 6 to 12. And then you have the 11-month. So it's a good range here. Hope you enjoyed the video. Inside this video, I'm going to be talking about GCS and the AFPU score. I have a lot on GCS. I just want to go over AFPU with you. So the mnemonic AFPU, what it has to do with is your patient's level of responsiveness. GCS, that's something different. We're going to talk about that in a minute. That's a Glasgow Coma scale, score. We're going to talk about that in a minute. AVPU I want to teach you first. It's a little easier, then we'll dive into this. So AVPU is A as in alpha, V as in Victor, P, and then U. AVPU. Now here's what we have. A stands for alert, awake. Your patient is alert and awake. Okay? So if your patient is alert and oriented times 4, talk about that in this. If your patient is alert and oriented times 4, they're alert to their time, their place, their self, and the event. Okay? That's alert and oriented times 4, right? The V would mean, well, they're not awake, but they are responsive to a verbal stimulus. Like I was like, hey, how are you? And oh, they come up. That's verbal. The P would be a painful stimuli. Let's say I did a sternal rub in the patient and then they were responding. That's a painful stimuli response. U is unresponsive. That's AVPU. So they're wide awake, they respond to a verbal response, they respond to a painful response, they don't respond to anything. That's AVPU. Now we understand that there's a score in emergency medicine called a GCS, the Glasgow Coma Scale Score. We're going to talk about it. So this is it. Now when you first look at it, you go, whoa, that's a lot of stuff. Watch this video over again, 1, 2, 3, 4 times till you have it down. But I'm going to show you some tips here to make it easier, okay? So let's start with this. EVM 4, 5, 6. So that's a mnemonic that I'm telling you. This is from me to you. Okay, it's not this is from me to you. EVM 4, 5, 6, what that means. There are 3 sections to this score. A perfect score is 15. So if we get a 15, we're perfect. We are a normal patient, essentially. If we get a 3, we are completely unresponsive, comatose. Okay? So, the E section is right here. The V section, the M section. The E section stands for eye opening. The V section stands for verbal response. The M section stands for motor response. And I'm going to grade the eye opening starting with 4, 3, 2, 1. As we go down, we get worse in each one. The 5 is our middle. That's the V. 5, 4, 3, 2, 1. M, 6, 5, 4, 3, 2, 1. So that's why we say EVM 4, 5, 6. 15 is perfect. 3 is you are comatose. If you got that so far, we're looking good. Now let's get into it, okay? Now, let's make this, I can make this even easier for you. Now we know EVM 4, 5, 6. So you know this is the patient's eye-opening response. This is their verbal response. How are they interacting with you? This is their motor response. How are they, when you put on a painful stimulus, how do they react, or what are they doing with their motor response right now in front of your eyes? Okay? The eye opening. 4 is normal eye response. Well, in each of these, a 1 is no response, no response, no response. It's unresponsive. We know that already. So I know 4 is normal. 4 is me right now, right? A 1 is unresponsive. That only leaves 3 and 2. So the thing that's very interesting is, remember I taught you at the AVPU score? It's very similar. It's not the same, but it's very similar, right? If you look at it, normal eye response, that means they're responsive, right? The eyes open to speech, eyes open to pain, no eye response, unresponsive. Very similar to an AVPU. So if you got the AVPU down, think of this as like a mini AVPU, right? That's why you can remember it first. Now we get into verbal. Okay. Alert and oriented times 4, you get a 5. Now this I want to share with you before we go any further. A patient, what if you come across a patient who has dementia? They may normally be confused at baseline. So when you go to a patient, you want to ask them, what is their normal mentation like? If there's bystanders around, you want to ask, is this normal for them? What is known for them? What's different today? That's how we get a good score here, right? This score tells the hospital and tells you how sick your patient is, how ill they are, how critically injured they are, okay? We give a 4 if they are confused, meaning they're able to speak in full sentences, but they're confused, okay? Inappropriate words versus incomprehensible words. This is where everyone gets messed up. Let me explain. Inappropriate words would be like 1 to 2 random words. They're getting out full words, but the words aren't really making any sense. So it's like broken sentences, inappropriate words. Incomprehensible words is like mumbling, basically. They're almost not even speaking, almost like a slurring of speech. It's incomprehensible. No idea what they're saying. So if you think about it, full sentences and oriented, full sentences, but I'm confused. Random words that are not being put together. Really, for lack of a better word, folks, like mumbling, yeah, incomprehensible words, and then nothing. Motor. If they obey commands, lift your arms, 6, okay? Localized to pain means, let's say they had an injury to their arm. They're now obeying commands, but they're grabbing the arm. They're grabbing the arm, right? Withdrawals from pain would mean, let's say if you squeeze their finger, they would pull away from it. They'd pull away from it. That's a withdrawal. So withdrawal, they're coming in from the painful stimulus, withdrawals. Now, one we know is no motor response. Again, notice that they have these 2 and these 2. Okay, we just make sure we know them, these 2. Now we have decorticate posturing, and then we have this posturing here. Let's start with this one, okay? Decorticate posturing means it's an abnormal flexion. So this decorticate is an abnormal flexion. The one down here, the decerebrate, that is an abnormal extension posture. So if you go with a patient and they are like this, clenched like this, and they have their arms to the core like this, eyes shut, this is decorticate posturing. Now, I'm going to show you here. I hope you can see me. I'm going to move my arms like this, so my wrists are like this out, and I'm going down. This is decerebrate posturing, like this. Decorticate, decerebrate, okay? And there it is. So, let's do a little test, okay? I'm going to get my marker. Let's do a quick test. Let's do it. So here we go. If your patient has a GCS, we get 3 up here, okay? Let's say we get a 4 here. We're at 7, right? And let's say we get a 4 here, right? So 4 and 4, we got 8. We add 3, we have an 11 for the total GCS. That's how it works. That's how you total it, right? And then in between, when you look at, 3 is comatose, 15 is a perfect score. What they say, you may see, you may have heard, is somebody that is under 8 is extremely ill. And if they're above 8, they could be in trouble, but they're not extremely sick. You may hear about that, right? A score of 11, you got to watch out for that patient, right? They're trending in the wrong direction. The majority of patients you see will be between 15 and 13, and then really, really ill ones will be somewhere on the scale. But this is how the hospital will ask you for this. What's the GCS? What's the GCS? This is how they determine how sick your patient really is. I want to make a video breaking down the 4 most common EMS mnemonics that pretty much every EMT class around the nation uses. OP, QRST, sample history, DCAT, BTLS, and AEIOU tips. Now, OP, QRST, let's start with this one first. We'll break it down one by one. So OP, QRST is used, it's mnemonic. It is used when a patient has chief complaint of a pain. Could be chest pain, could be abdominal pain, leg pain. Whenever the patient has pain, we use OP, QRST. So let's go through this. So the O stands for onset. A great question to ask is, did this, let's say, we'll pretend this is chest pain. So let's go with that. Did this chest pain start suddenly, like right now, or did the pain come gradually, right? So you ask the patient, did the pain come on today, or did it come on right a few minutes ago? Did it come on over a few days? That's what we're trying to get out of the patient, right? Did it start suddenly or gradually? Provokes. Now the P for provokes, what it means is, did anything make the pain better or worse? The patient might say, well, my chest pain, when I sit up, it feels better. When I lay back, it really hurts, right? The quality of the pain. What does the pain feel like? Can you describe the pain to me in more detail, right? What kind of pain is it? What does it feel like, right? Radiates, radiation. Does the pain go anywhere? Does the pain move anywhere or stay in your chest, right? So we're saying, if you today had a left side chest pain, does the pain move anywhere? Does it go up, down, to the side? They might say it goes into their shoulder. They might say it goes down to their stomach, right? Severity. From 0 to 10, 10 being the worst pain you've ever felt in your entire life, and 0, you have no pain at all. Where are you on that? 0 to 10, right? And then the time. One more thing actually before on the pain scale I want to mention. The pain scale, 0 to 10, someone's 10 pain could be another person's 4 pain. The goal of the pain scale, people jump and think it's, well, I want to see how bad the pain is. Oh, a 10 out of 10. It's actually to see if the pain is improving or if the pain is getting worse. If the patient comes to you and says, I'm a 4, and by the time we're in the ER it's an 8, they're trending the wrong direction. Does that make sense? Okay, cool. That's the real big pro pain scale. Time means, can you give me an approximate time, actual time on a watch, of when this all started, right? So do you know what time it started, right? Onset is like sudden versus gradually, right? So with onset, we're trying to figure out, has this been going on for a few days and it got worse, or just out of the blue, it just came up? Where time is, hey, do you know what time actually started? That's what we're looking at. So OPQRST, let's move on to sample. Samples, we want to get a history of the event and a history of our patient. This is called a patient history. Now, S-A-M-P-L-E. Let's define first, then we'll talk. S, what are the symptoms? So what is the patient actually complaining of, right? So a great question to ask is, what's going on today? And they'll tell you, I have pain, can't breathe, I fell, right? What does the patient complain of? A, allergies. So does the patient have, let's say you're talking about bystanders, and let's say it was a dementia patient, we're talking to the caregiver. Does the patient have any allergies that we need to know about, right? Can you ask the patient? Same thing. Do you have any known allergies? Ever had an allergic reaction before, right? Medications. May I see your medication list? Do you have a medication list? Do you take any medications? May I see her medication list, right? Past medical history. Any medical history that we should know about. Any medical history that involves the ambulance. So have you ever called 911 in the past? What happened then? Something to think about. Past medical history, right? When's the last time you called the ambulance, right? Last oral intake. So last oral intake meaning when's the last time they ate something or drank something. It also could be pertinent to the call, right? If it's an alcoholism call, well, when was their last drink, right? Last oral intake. Events leading up to the call. So a great one is, what changed today that made you call 911? Or the bystander, hey, so what changed that made you call 911, made you call us? Events leading up. That's what it could be, right? So there's our sample, and there's some examples. DCAP, BTLS. If you just got done with EMT class, you probably heard us a lot. We got to review this. If you're watching this and you're getting ready, you're going to love this. DCAP, BTLS is what we do in a trauma assessment. We're looking out. Is there any DCAP, BTLS? As we're scanning the body, doing our assessments. So here it is. If we see one of these, we want to pick up on it, we want to treat it, we want to tell someone about it, we want to move forward with it, right? So DCAP, BTLS. D-C-A-P, B-T-L-S. I'm looking for, on a trauma or any call, I'm looking and assessing when I do my patient assessments. I'm looking for my DCAP, BTLS. Deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling. DCAP, BTLS. So your patient is confused. They're in altered mental status. Your brain is thinking, what could be going on with this patient? As you do your patient assessment, as you get a medical history, you see a med list, you get vitals, you're trying to put it all together, and you remember, A-E-I-O-U, TIPS, is a mnemonic for altered mental status, right? Now, it's a long mnemonic to remember at a first impression. But if you're unsure, it's a great tool to use because it is so much packed in one little mnemonic here, right? So let's check it out. A-E-I-O-U, TIPS, T-I-P-S. A-E-I-O-U, TIPS. So A stands for, is it an alcoholic, like an alcoholism patient? Is it drugs? Is it alcohol or drugs that's causing the patient to be altered? Is it an endocrine emergency? Think about that. Definitely could be. Is it a seizure patient, like an epilepsy patient? Is it an electrolyte emergency, right? Is it infection? Like, could it be sepsis, right? For sure, right? What else? Overdose. Are we at an overdose or an oxygen deficit? Is the SpO2 just low, right? Uremia, right? Could that be the culprit? Trauma, tumors, temperature, okay? Insulin. Is it an insulin issue? Like hypo or hyperglycemia. Psychiatric, like a mental health crisis, poisons, and stroke and shock, right? So here's what we have. Now, at the BLS level, if I'm just going to look at our board here, how can we figure some of these out? Well, if we're trying to figure out alcohol, could be from the history, could be from what we find on the scene. Same with drugs, could be the history. The physician could tell us about the alcohol and drugs, right? Endocrine could be sneaky, but we could find that in a med list or a history, right? Think about all kinds of endocrine problems that there could be. Same thing with so med list for endocrine, that could be it. Med list for epilepsy, sure. Electrolyte, that's a sneaky one, right? That's a sneaky one. Now, I have life packs in over there at the paramedic level. As far as electrolytes, I could do an EKG, right? Something food for thought. Infection, think about like pneumonia, UTI, stuff like that. They coughing up any green or yellow sputum, right? Problems going to the bathroom. Overdose, we think about heroin overdose, sedative overdose, right? Drugs overdose, right? Oxygen deficit, check pulse ox. Is the oxygen level good? Are they hypoxic? Is there blue on the lips or on the nail bed, cyanosis, right? Uremia, self-explanatory. Trauma, so expose your patient. Any sneaky bleeding or trauma. Could it be like a brain tumor? It's possible, right? Temperature, is it up or down? Watch the environmental emergencies video on that too, okay? Insulin, so we have the diabetes review, right? Hypo or hyperglycemia, right? Mental health, could be simply a mental health patient, right? Poisons, another overdose, and then stroke and shock. The thing you notice about this mnemonic is we have overdose, drugs, and poisons. It's all kind of the same, but you will not forget it after this mnemonic. A-E-I-O-U, TIPS. As we get started with OBGYN, I want to go over some key terms that students get tripped up on. Let's go over them first, then we can progress from there, start going over emergencies. Let's take care of these first. We got to know these. So what is the umbilical cord? What is it? How does it work? So it connects the fetus to the placenta, right? And we have the artery and vein going through that, right? So blood flows through that. Okay, that's a blood flow. That's the link. The placenta is the actual organ. I like to think about it as it's the organ of nutrition, right? So oxygen and nutrients go in fetus, and then waste products go out. So we can go back and forth, right? It's a fetal maternal organ. So think it's going to absorb and waste. Placenta is connected to the umbilical cord, and that umbilical cord is connected to the fetus, right? So what is this amniotic sac and fluid? All it is, it's a thin-walled bag that has this amniotic fluid, which is the fluid that's in the sac. The fetus is in that sac, and it's surrounding the baby. So it's like, think of a wall, if you will, inside the uterus. Okay. Braxton Hicks contractions. Now here it is. Braxton Hicks contractions are an irregular So irregular, not regular, irregular tightening. Okay, it's an irregular tightening of the uterus that first comes up in first trimester, right? So if it appears, it comes in first trimester. Please remember that. Because in a scenario question, if you see they're having irregular contractions, oh, and it's only been a few weeks, it's Braxton Hicks. The answer. Now, with Braxton Hicks, it will get worse and worse and worse the longer the pregnancy goes. So as they move on in trimester, it will get worse, it will get more, okay? Now down here, the last piece here we got is meconium. We'll talk about meconium staining. Now, what is meconium? Meconium, what it is the baby's, fetus's first bowel movement. Usually this occurs a few hours after delivery. But what can happen is, imagine this. Imagine the baby has their first bowel movement when they're still in the uterus, like during labor. That can complicate things because what can happen is that bowel movement, we're in uterus, everything's moving around, and the baby can end up with something called meconium staining aspiration, which essentially is that bowel movement going down to the lungs. And then we can have respiratory issues, which will show itself. Let's say the baby is born and respiratory rate, heart rate isn't going up, they're not responding, you're warming, you're drying, you're stimulating. So what do you do? What do you have to do? Once you've tried all those basic efforts, which we're going to talk about in this OBGYN sections, just remember this: support their airway. Supporting their airway and solving their respiration problem, if you have a meconium staining, is most important. Gestational diabetes, gestational hypertension. Gestational meaning this is during pregnancy, and then what we have as the medical condition. Let's discuss these. So gestational diabetes is the mother's body is unable to utilize insulin or produce insulin. So we can have someone who's not a diabetic become a diabetic, okay, during pregnancy. So what happens? High levels of glucose are then sent to the fetus. Why? Well, if you're going over the diabetes section earlier, just talking about normal diabetes, if insulin, it's the key that opens the cell, glucose wants to go in the cell. If we have an insulin problem, anything we take in, we're going to have too much glucose hanging around. If we have excess glucose hanging around, guess who's getting it? The fetus. The fetus. Right. So what's going to happen? If this is not checked, then your baby is at risk later on down the line developing diabetes down the line, right? Type 2 diabetes later on. And also being a very large baby. Most of the times it's caught prenatal care, good doctors, right? It's found early, so there can be a plan in place for exercise and dietary restrictions, but usually, not a rule, but this usually goes away after the baby is delivered, but sometimes it can still last years later, just so you're aware of that. Gestational hypertension. Hypertension is high blood pressure, okay? A blood pressure over 140 over 90 is considered gestational hypertension. So the big thing about this and why I bring it up, we're going to talk about it in a later video in this section, OBGYN, is preeclampsia. Gestational hypertension can lead to preeclampsia. Preeclampsia can lead to eclampsia. That's the pathway. So that's usually how it starts. That blood pressure is our first indicator. Well, this could be preeclampsia, right? So that's what we have. Now, hyperemesis gravidarum. Hyper, too much. We got too much emesis, all right? So check this out. It is, right? Like I said, severe nausea, vomiting. See, if you know a few medical words, right, and we're learning about the course, you can pick things up. Okay, I'll remember that now, right? It's not a crazy word. Now you go, okay. It's a lot of nausea, vomiting going on. Okay, got it. So what happens with these patients with hyperemesis gravidarum? It usually starts 2 to 5 weeks after conception, right? So early on, first trimester, right? And it usually lasts until around week 20, and then it will cease. Sometimes it can go on the whole pregnancy, but it usually will get better. But in the beginning, it's really bad. Some people may call it a severe morning sickness. Okay, like very severe. Not just a normal morning sickness, really bad, severe. It's so severe that hyperemesis gravidarum can cause electrolyte imbalances, malnutrition to mother and fetus. So you got to watch out for that. If you have a patient in the ambulance that has that, you want to treat accordingly for that. Now, you're probably wondering, what are these little things in the bottom? Well, again, this first section is about picking up key terms. Picking up key terms. If we don't know these, we're going to get lost. I don't want you getting questions wrong that are just term questions, if you know it or you're not, right? So let's get these down. So para means how many live births have you actually had? The gravida is the number of pregnancies. Now the reason I've done this, I put live and I circled it, parentheses circled it. It's a way for you to remember it in your head, okay? Para is live. Gravida, number of pregnancies, okay? How many live births? How many pregnancies, okay? Now, if you ever get a question on NREMT and talks about how would you position the mother, could be any kind of call, the answer is always left lateral position. They talk about arrest, talk about this, that, left lateral. Trauma, it's left lateral. Remember, pregnant patients, left lateral position takes pressure off the aorta. Remember that. Let's start with identifying when you have to stay on scene and deliver a newborn. We call this imminent delivery. These are signs of an imminent delivery. Let's go through one by one. First, contractions lasting 45 to 60 seconds that are only 1 to 2 minutes apart. What does this mean? Let's say the contractions were 5 minutes apart. From contraction to contraction with a total of 5 minutes. You have time to transport the patient to the hospital. If you get on scene, they're saying contractions are 45, 6 seconds, and they're, let's say a minute apart. That's a sign that you have to deliver on scene. We're not going to be moving to the back of the ambulance. Deliver first, go from there. Crowning. Crowning meaning the head, okay, is coming out of the patient. Feeling of a bowel movement and a bloody show. Let's talk about this. So, the mother actually wants to have a bowel movement or feels that she wants to bear down. That's a sign. Now, what is this bloody show? What the bloody show is, it's a mucus plug that is actually in the mother. And right before delivery is about to take place, that bloody show occurs. Okay, it's mixed with blood. So that mucus plug mixed with blood will come out. Now, my advice to you, if all these things are happening, stay, set up shop, deliver. That's my advice to you. Now here, this is imminent delivery. This is a stage of labor. It's called labor and delivery. So labor is the process of the mother going through the steps to deliver the baby and the placenta too. Okay? Right? Delivery is the act of the newborn coming out. So these are stages of labor. So stage 1 of labor, let's go with it. Onset of contractions. So contractions start until the cervix is fully dilated. This can last anywhere from 6 to 20 hours, depending on the amount of newborns, how many pregnancies, and there's no clear-cut number. It's a range. Every body's different, but on average, 6 to 20 hours in stage 1. Stage 2 is from full dilation of the cervix to delivery of the newborn. Again, this was going to have a range, 30 minutes to 2 hours. Usually 1 to 2 hours, but there have been 30 minutes, to give you an example of that fast, in stage 2. Stage 3 of labor is delivery of the newborn until the placenta is expelled. Now this can be this is the shortest stage of labor, if you have that question. It's going to be anywhere from 5 minutes to 60 minutes. What stage of labor does delivery occur in? The answer to that is stage 2. Stage 2. Stage 2 is where delivery occurs. Okay? Stage 2. Right? So, here we have all this. What should you know next? Next, we're going to talk about actually the steps to deliver. What do we do? What are some key notes we need to know about delivery? Let's talk about it now. Let's go ahead and deliver this newborn baby. Here are the steps. Remember, folks, it's a natural process. We're just guiding this natural process. Now, here are the steps. I'm going to walk you through it all, and then we're going to talk about, at the end of this, clamping the umbilical cord, cutting it. Here we go. So, first things first. We talked about in the last piece here about signs of imminent delivery. So we have a deliverer on scene. We see crowning. Now we move forward, So the first thing we have is apply gentle pressure to the head. So as baby's coming out, we're going to apply gentle pressure on the head. We don't want an explosive delivery, right? So we want just a little bit of gentle pressure on the head so it doesn't come out too quick. Now, this may be funny, but it's true. The baby can be very slippery. So we do want to watch out for that. Okay, so we'll make sure you have all your BSI on, you're ready, mother is prepared, and we're ready to go. Now, you want to check while the head's coming out, you want to check for a nuchal cord, which is the umbilical cord wrapped in the neck. You want to slip it over the head if it's present. Most of the time it is not, but if it is, slip it over, okay? Now, the shoulders will come next. The next contraction, the shoulders will start to come. They can come naturally. The shoulders can come out. But if they need help, most of the time, the baby will come face down. So you'll have an anterior and a posterior shoulder. So you start by bringing the baby's head downward and to do the first anterior shoulder out. And then you're going to go upward to actually get the posterior shoulder to deliver. Once both shoulders are out, the rest of the body will actually come out with just Uridan smooth muscle contractions, just come out smooth, okay? Now, I've talked about the rest of that. Okay, so now we're on to this piece here, which is after the delivery, what do? We want to dry, we want to clean, we want to warm, we want to stimulate, and we want to give the baby an ABGAR score. So we're going to talk about ABGAR score at the end of this. The last piece of OBGYN will be ABGAR score. But remember that for now, the ABGAR score, we're going to need to get a score. How well are they doing? And we want to trend that, right? So we trend our GCS and vitals. We want to trend our ABGAR. Okay? Now, talking about clamping the cord. There are two schools of thought on this. So I've put you right in the middle, right? So you can't go wrong, okay? Some doctors will say you want to clamp and cut that cord within 30 seconds to a minute. I believe it's a little quick, and I'll explain why. There's been studies that have been done that show that if you wait a few more minutes, there is more nutrition that can be given from mother to fetus. It can be helpful. So, you may see in a lot of textbooks. You may see your instructor may say 1 to 2 minutes. I'm going to give you a range here, okay? People over here may say wait 5 minutes. People over here may say wait a minute. I'm going to put you right in the middle. How about 1 to 3 minutes, okay? So about 1 to 3 minutes, and remember, you have to wait until the cord stops pulsating before you actually, so you'd stop pulsating, you've waited 1 to 3 minutes, and then go ahead. You're going to clamp 4 to 6 inches away from the umbilicus here of the actual fetus. And then we're going to clamp, cut in between, and then you want to ensure there's no bleeding, right? So that's what we have here for actually getting this done. Now, one extra piece, once you've completed all this and you're getting this done, bring baby up to mother. You can place on the abdomen of the mother, up near her chest, and let them have their moment together. What to look at is the ABGAR score. This is kind of like a GCS of our normal patient that isn't a newborn, right? And we're kind of trending as they're getting better or worse. We're trending vital signs. We want to trend an ABGAR score. So here's what we have. So the ABGAR score, now, if you're wondering how often should you do this, you can do this every few minutes or so. There's no like clear-cut thing you need to do, but every 5 minutes is pretty standard. That's fine. Feel free at your own discretion. You know, every few minutes, 5 minutes is fine. So the ABGAR signs. First, we have appearance. So what is the skin color? We have the heart rate. What's the heart rate? Grimace means irritability. So how irritable are they? They've just been born. They should be pretty irritable about that. If they're not, a bad sign. What's their activity, meaning what's their muscle tone like? And then respirations. How are the respirations? What's the quality? What's the effort of them breathing? Now remember, I'm going to share, before we get into the specifics, warm, dry, clean, stimulate. Stimulate. If you find that the baby is in any of these 1s, right? Stimulation usually gets them over to a 2. 0 in any of these means we have a major problem going on, okay? But stimulate. It's not unheard of to come out with a pink core and blue extremities. They need to stimulate to take their first breath, right? This is a new thing. So 0 is blue and pale. 1 is a pink body, but blue extremities. 2 is completely pink, all right? So remember, a lot of these issues are solved by them taking their first breath. So we need to do all those things. No heart rate, that's going to be 0. If they're under 101, over 102. If we have no irritability, so basically, essentially the newborn is not making any sort of noise, that'd be 0. Minimal noise would be a 1. Coughing, sneezing, crying, actions like that would be a 2. Just like a limp, flaccid body would be 0. Some flexion going on in the body, so flexion coming in like this, that would be 1. And then number 2 would be active motion, like they're moving around all their extremities. Respirations would be 0 for 0. Pretty easy way to remember. Slow or irregular respirations would be a 1, and then crying and good strong respiration, chest rise and fall would be a number 2. Now, here's what we have for Apgar. You want to trend this. Know that when the newborn first comes out, there might be a 7 or an 8. If you didn't notice, there's 1, 2, 3, 4, 5. So 10 is a perfect score. They may come out a 7 or an 8. In the next 3 to 5 minutes, 2 to 5 minutes, they should perk up to 8, 9, 10. That's usually a good rule of thumb of what happens, right? So for example, they may come out because they haven't taken their first breath yet. They may have that blue extremities, right? They may not be coughing and sneezing and be minimal. They may have not active motion. They got to the first breath. So there's food for thought for you on Apgar. Hang with me, watch this. An abrupt movement of the placenta. That's abruptio. The way to remember it, the word abrupt, and we have placenta, right? Abrupt placenta. The placenta is making an abrupt move. This is what happens. Definition is a full or partial movement, early detachment of the placenta from the wall in the uterus. This occurs during what trimester? The 3rd trimester. The 3rd trimester, right? This is a 3rd trimester emergency. Risk factors: meth, cocaine use during pregnancy, and high blood pressure, any sort of gestational high blood pressure or known high blood pressure. Big key here. This is what differentiates abruptio from our other friend, placenta previa, coming up. Here it is. This is more about abdominal pain. There can be dark vaginal bleeding, but it's usually mild to moderate, where placenta previa, which we're going to talk about in a minute, is more of bright red and it's more painless bleeding. This has pain with it, right? Now, for all these OBGYN emergencies that we're going to cover in this little section here, it's rapid transport. It's rapid transport. It's rapid transport. But this is what you can think about with abruptio, 3rd trimester emergency. Placenta previa. Let's think about this. The placenta comes previous. The placenta comes first. That is what happens in placenta previa, or what the placenta is trying to do. The placenta is covering either fully or partially the cervical opening. It should not be doing that. The fetus comes first, the baby, the newborn is delivered, then the placenta. The placenta is trying to go in front of that in coming in front of that cervical opening. Okay? Now, two main risk factors are previous C-sections, and you're probably wondering, what is a grand multi-para? Well, let's break it down. Para, talking about live birth, right? Multi, so we've had multiple live births, but what makes it so grand? Let's talk about it, okay? Over 5. So this patient could potentially have over 5 live births, is a potential risk factor of placenta previa. So put in your head, if the patient has had multiple live births, they could be at more risk of placenta previa. Okay, so there it is. Now, how do we differentiate a paraptio from placenta previa? One, knowing the difference. We've learned that. But what about signs and symptoms? Here, right, number 3. That's number 3. So this is bright red vaginal bleeding that's painless. No pain. That is typical of placenta previa. Same deal, rapid transport, and there it is. Ureter rupture can happen due to a medical reason or a traumatic reason. Ureter rupture is a rupturing of the ureter wall, which we know is where our newborn is being held, our fetus is being held, okay? Now, the acute rupture of the uterus, that's definition, right? That's what occurs. Now, with this, what are the risk factors? Well, here they are. Prolonged labor, trauma, and outside trauma, and a big one is previous C-sections. So there could be a scarring that opens up on that ureter wall, okay? Now, we're going to do rapid transport for this. We get that. Now, what are some signs and symptoms for test question or scenario question? The big one that differentiates ureter rupture from all the other ones is the odd pause, the odd stopping of labor. Labor is going along good, and then all of a sudden, my stomach really hurts. It's a tearing pain, abdominal pain, like globally, kind of diffuse around the abdomen, but a new pain. The patient may say, this feels different, and then labor stops. Abdominal pain with bleeding, and labor stops. Ominous, ureter rupture. Watch out for these risk factors. There it is. This right here is preeclampsia and eclampsia. Now, preeclampsia simply means you're a patient that has gestational hypertension and you have protein in your urine. That can cause some kidney issues, right? So, if the patient that has preeclampsia now has an active seizure going on right now, they are called eclamptic or in eclampsia. And these seizures that in eclampsia, they're known to have apnea with the seizures. So once the patient's seizure activity is stopped, you want to help out with oxygen, respirations. Watch that, okay? Now, again, what is preeclampsia? Gestational hypertension with proteinuria. It's the medical term for it. Risk factors: family history, pregnancy over 35 years old, and high blood pressure. Now, a history, meaning they have a history of high blood pressure before they even had a pregnancy, right? Headache, edema in the legs, feet, even the hands, blurred vision, abdominal pain, rapid transport and oxygen for the preeclamptic patient that is under distress and trending towards eclampsia, right? Very high blood pressures. Their diastolic can even go close to 110 or higher. This is one of the biggest life threats in OBGYN. It's an ectopic pregnancy. What an ectopic pregnancy is, the egg, the ovum, it is implanted in the wrong spot. Where it should be is inside the uterus. Imagine that it is implanted in the fallopian tubes. That's the typical, it's a common spot for this ectopic pregnancy to occur. So imagine the ovum growing there. It cannot grow there. It will cause a rupture, it will cause a hemorrhage, massive internal bleeding. So, this is a life threat. Okay, this is a life threat. Now, with all this here, yes, it's lethal. Here are the risk factors. Pelvic inflammatory disease, also known as PID, if you see that in a question. Some say that intrauterine contraception devices, previous use of that could be a risk factor, and previous surgeries could be a risk factor. The triad of symptoms: abdominal pain, vaginal bleeding, amenorrhea. Amenorrhea means lack of menstruation. Okay. Now you're probably wondering, Evan, abdominal pain, vaginal bleeding, amenorrhea, I mean, that could be a lot of things, right? You're not wrong. The reason we need to know about this is this. Hear me. Any female patient that has any possibility of being pregnant and they call 911 with severe abdominal pain, whether they say they can be pregnant or not, whether they say they're in an early pregnancy or not. This occurs early on in the pregnancy, first trimester, right? We have to think about this and treat them accordingly. Vital signs will tell a lot here if they're really in distress. Look out for this. Now look, rapid transport, treat for shock. And you know how I talked to you about, if you watched earlier section of the course, how if your patient has difficulty breathing, you should always think about that sneaky pulmonary embolism in the adult patient. Well, I'm telling you, in female patients of childbearing age, to always think about ectopic pregnancy. It's the sneaky emergency of OBGYN. And there it is. Okay, folks, inside this video right here, this is my ultimate lesson. I call this lesson my EMS Operations Mastery Lesson. The reason I call it that is because if you understand the content inside this lecture that I'm about to deliver to you, you will understand everything you need to know for EMS operations on exam day, and also EMS ops to prepare you for working out in the field. Both go hand in hand. So here we go. Let's start with the types of ambulances. So type 1 ambulance, you have to, here are the buzzwords, okay? The type 1 and type 3 ambulance look almost identical. They're the big box style ambulances. Type 2 ambulances are van ambulances, okay? The only difference between a type 1 ambulance and a type 3 ambulance is the type of chassis, cab, that's on the actual ambulance. So here's what I need you to remember. A type 2 ambulance would be like a Sprinter ambulance or an older van ambulance. So modern style van ambulances or any style of like a full van ambulance is type 2. A type 1 ambulance has a chassis cab that is similar to a light duty pickup truck of the chassis cab. The type 3 ambulance has a chassis cab that is like a light duty van, but they're both box style ambulances. The only difference is the chassis cab. Okay? So now let's get into our next piece here. So the next piece here, we're going to talk about some scene safety stuff for EMS operations. So the first thing I want to talk about is scene operations. So the fend-off position is a position where you are placing the ambulance approximately 50 feet or so away from the scene for scene safety. So the fend-off position is this. Let's say we have fire department on scene, law enforcement on scene, EMS on scene. We're placed in a position where we can enter and exit easily, but traffic continues still to be able to flow by the vehicles, okay? And we're placed in a way where we're close to the scene, but not right on top of it exactly. Like, you know, we're right there so we can bring the patient over and then easily escape, and we're safe. We position the ambulance uphill and upwind whenever possible, okay? And again, if there's responders are there before you, just place right behind them, right? Or you're going to go to the uphill, upwind, and you need to go in front of them. Whatever the best egress is for you, okay? Whatever the best area is for you, that's where you want to go, okay? Now, here are some other scene tips that I have for you. There are giant fog lights on every ambulance that can light up a nighttime scene. So before getting, let's say you're in an area and it's nighttime, you can put the fog lights on to see more of the view before actually getting out of the ambulance, okay? The other thing that you would do is you always want to apply the parking brake every time you get out of the ambulance. So if you have that emergency parking brake, you want to, usually you use your foot, you put it in place in most ambulances. So you have that. You also want to have a spotter when you back up, and you want to always wear your reflective clothing, those yellow jackets and vests, when you're on road scenes, okay? And here is the big thing when you're approaching the scene. You want to scan the scene. Your head should be like a swivel, scanning the scene for any hazards as you approach, and that will determine where the ambulance should be best positioned. Now, street tip, a lot of times if the fire department will beat you there and you're EMS, they will direct you on where the ambulance is best placed because they've already been on scene. So just so you're aware about that too, okay? Now, the term landing zone. So you have a test. So you're going to see throughout this a bunch of buzzwords, okay? Some are in quotations, some are in bold, some I'll just bring up. Landing zone is these buzzwords. What's a landing zone? A landing zone is an area that's prepared for a landing aircraft. Let's say a flight medic is coming, or let's say it's coming to get your patient. It's usually an area of 100 by 100 feet. That you would want to know, okay? Excuse me. Now, the command post. These are just two things that you may not be familiar with, so I just want to make sure you are. The command post is the area that the incident command is stationed at. So we're going to get into now the next piece of this, which is the incident command system, also known as the ICS. And when these are brought in, most commonly, is an MCI, which stands for a mass casualty events, my friends, and we're going to explain about all this. Here we go. Now, when we're talking about the command post, we're going to talk later whether it's single command or unified command. That's where the command is stationed at. The communication center is a facility that will dispatch emergency equipments and persons to the scene and coordinate all the different field units, right? Like dispatch, okay? So here we have the incident command system. It is defined as a program and system of management that controls and directs emergency services and resources and operations for an MCI event. Okay. Now, what is an MCI event? So here it is. A mass casualty event, what it means is we're at an event that has happened where we have persons, casualties, victims that outnumber the available resources in that community, in that locale, in that town. That's what we mean, okay? That's a mass casualty event. The victims, the casualties outweigh the available resources. Now, I have 2 parts to explain to you about mutual aid. How many parts? 2. If we're at MCI and we need more resources, we would call for mutual aid, which is an agreement between EMS systems or town cities to coordinate with each other. Yes, we would. But mutual aid is more than just that. So can I share a scenario with you about mutual aid? Okay, thank you. I'm going to do that. So here it is. Let's say town A has 2 ambulances and town B has 5 ambulances. In town A with the 2 ambulances, let's say that we have 3 calls going on, right? And there's 2 ambulances. Oh, if we have 3 active calls and 2 ambulances, well, so 2 ambulances go out, take the first 2 calls. We have a 3rd call, and there's no units available. This is why EMS towns, EMS cities, EMS systems, private ambulance services, hospital-based systems coordinate mutual aid agreements with all the systems of EMS in towns around them. So now town B says, well, we got ambulances. We have one available, and they call mutual aid, and they start with town B. Town B says, yes, we have 2 ambulances available at this time. We can send one now. And they send one over. The call is taken care of. Beautiful. This mutual aid, my friends, happens not an MCI. MCI does not happen every week. A mutual aid event, on average, will happen, I would say, at least multiple times a month. And possibly, I would say, multiple times per week, depending on where you work. And sometimes every other day, depending on where you work. Okay? Makes sense? Okay. Now, this is very simple, but again, I got to cover these buzzwords because I can't. The last thing you want to do in an exam is have an EMS ops question and you just don't know the key term. So we're reviewing all the key terms right here, right now. Single command means that MCI command, the incident commander, is in control of one person. A unified command is where different services, for example, EMS, fire department, Red Cross, law, state, they complement each other and they share the command. Here's what I think about it. Single command is one incident commander sitting at the incident command table. At the unified command, we have the police chief, the fire department chief, the EMS chief, the director of the Red Cross. We have the state government. We have the, see? And they're all at the table. There it is. Okay? Now, I'm going to tell you, this is the big pearl. This is some of the most important information I can tell you. You will get asked about this at some point throughout your career, 100% on exam day. Here we go. Incident command is the incident command where it's single or unified is the top of the chart, right? Below incident command, you have 4 sections. How many sections? You have 4 sections. How many sections? There's 4 sections underneath incident command. Okay, now here they are. The logistics section has to do with exactly what it sounds like. Gear and responder allocation. So what are we doing with, do we need facilities? Do we need services? Do we need food, supplies, equipment? The operations section has to do with the direct oversee of the scene. They're in control of the scene, who's going in, who's going out, and the safety of the provider and the strategy of the scene is going to be more on the operations. The planning section is all about information. Okay, can we get info from the last MCI event so we can help this one? Can we get info on this? Can I give you an example? Let's say we have a scene with gas and there is 125 victims that need to be triaged, which we're going to get into in a second, okay? Wouldn't it be nice to know the homes around this area? Wouldn't it be nice to know how many residents are around this area? How, can you give me more information about this gas? You see where I'm going with this? That's planning section, okay? The finance and admin section simply track the costs of what we're spending throughout the event. Simple as that. So now we're going to get into smart tag triage. I will say one thing to you real quick before I continue. If you watch this video twice, you will learn twice as much. Let's continue. So we have the smart tag triage system, okay? What is this? What is triage? Triage, the word, what it is you're at it. Okay, so I'm going to paint a picture for you. You are a brand new EMT and you're with your EMT partner. You're both two new EMT recruits. You're cleared on the ambulance. You're waiting at post for a 911 call. You get a call from dispatch that 3 towns over there's an MCI, a mass casualty event occurring. Okay? All right? Mass casualty incident occurring. Okay? So you respond. When you respond, you go and get your orders from the operations section, the incident command, and they tell you that you and your partner are going to be part of the primary triage. You remember watching this lesson about smart tag triage. They hand you a bag of smart tag triage and say, okay, the scene's cleared. We're going to send you in for primary triage. Okay? Your partner and you get suited up and you go out for primary triage. Here's what you need to know. Let's do a quick overview. There are 4 tags. How many tags? There are 4 tags. The green tag is the walking wounded. These are patients who have injuries, but there's no life threats whatsoever. The yellow, they are moderate to almost severe injuries, but they're stable at the moment and they don't have any present life threats, but they are definitely injured, and 9 out of 10 times, they're gonna need transport to the ER. Red or critical patients are breathing with a pulse, but they have what I like to call shaky vitals, kind of poor vitals. To make it even simpler for you, the red, they are alive, but they have life threats that need to be managed right now, and they need rapid transport. They are the #1 priority on the MCI scene is the red, because they will become black in secondary triage if we don't act now. Black is dead on arrival. For example, during triage, you find a patient in cardiac arrest. You would tag them black and no care is done. The reason for this, and it's not a rule that I made up with, I'm just telling you what it is. The reason for this is very simple. If you have an MCI event, which we define as an event that there's too many casualties, there's too many victims, and not enough resources, we need to use our resources effectively. If someone's dead on arrival, the odds of getting back a traumatic arrest out in the field is usually lower than 2%. So if we focus our resources on red, yellow, and green, we can save lives. That's the idea behind smart tag triage. Okay? So here we go. Let's follow these steps during triage. So let's go back to our scene, and we're back in the scene. Okay, you are a new EMT, you're back on the scene, you're suited up, you're ready to go, you're doing your primary triage. Here we go. We approach the patients. You approach patient 1. These are the steps. Now, when you approach patient number 1, before you've done this, can I tell you what's happened? What has happened is if you are at an MCI event, the first thing is they will get out an air horn and they will call out to the victims and they will say, essentially something along these lines, hello, if you can hear me and you can walk and you're able to walk, move toward this direction, which is basically a safe area to gather those walking wounded, the green tags. So the green tags are going to be able to already walk out of the scene, okay, in most scenarios that we can paint a picture of, okay? So the green are pretty easy to identify. They're ambulatory patients. They can move. So your patient is walking and talking and moving around all about. They're walking wounded, okay? So now, what we have here in a typical sense is a patient who cannot move because they are injured and they're on the floor because they're injured. So we're trying to figure out, are they black? Are they red? Are they yellow? Step 1 is we open the patient's airway. Now, if the patient's airway is already opened, or they're speaking, but they just can't walk, they have injuries, okay, well, are they breathing? Okay, so if we open the airway and they are breathing, we have to ask ourselves the first question. If their respirations are over 30, they immediately get tagged red. There are 3 steps, and these 3 steps that you see on the screen here are 3 tests. If you fail a test, you get tagged red. If you pass a test, then you move on. If you really fail the test, like this one right here, after 2 attempts to open the airway and no breathing, we actually tag them black, which means the patient is not breathing. We open the airway twice, we tag them black. Okay? Now, what if they're under 30 respirations? We would actually move to step 2, okay? Now, I have something I want to share with you here. You might be saying, Evan, well, if they're under 30, what if the respirations are 6? Do you move them? Do you continue on? What I would say here is, if the respirations are between 12 and 30, I would say this would be move to step 2. If the respirations are under 12, but they're breathing on their own, I would tag them. I would stop here and tag red. That's what I would do. Okay, I would stop here and tag red because they're not ventilating. That's red. Make sense? Okay, let's continue. So now we figure out if we're on step 2, this means that the respirations have to be between 12 and 30, and they have an open airway. That's what it has to mean. So we open the airway, and the respirations are 12 and 30. Now, do they have a radial pulse? If the radial pulse is present, we can just move right to step 3. They're looking like a yellow, but we got to see. Now, what if the radial pulse is not present? If the radial pulse is not present, we're going to check capillary refill and look for any expose the patient quickly, look for any major bleeding. If we see it, we're going to have bandages and pressure dressing on it. Go ahead and bandage. Go ahead and pressure dress. If the patient's awake, say, hold this, direct pressure, and continue. If cap refill is over 2 seconds, you tag them red and say, in control major bleeding, I'm going to explain what happens, after this assessment in a second. Okay, if their cap refill is good, their capillary refill, which is touching their finger and seeing the skin come back to the normal color. Okay, if it is under, which is normal, under 2 seconds is normal, go to step 3. Okay. Step 3, are they red or yellow? Let's find out. We're gonna check their mental status. Give the patient a simple command like squeeze my hand, grip my hand. If they do not respond, they're red. If they respond, they're yellow. They passed all 3 tests. So what does this mean? If they're yellow, that would mean the respirations are between 12 and 30 in an adult patient. That would mean that they either have a radial pulse or at least have good cap refill in their finger. And finally, they responded to gripping your hand. That's yellow. You see, picture that patient. That's yellow. Now, you know what red? Now, what red could be is the respirations are over 30. They don't have a good radial pulse. They don't have good cap refill. They don't have good mental status. What we're looking for is a sign that they're in shock but still alive. So a red patient, what they get, you're going to open their airway, put them in a shock position, and control bleeding. Now, you're probably wondering, Evan, what happens after you tag? Okay, so let's go back to our role play. You're on scene taking care of these patients. We enter the arena here and doing our tags. Your job is to tag. We're tagging all the people. There'll be another crew of people taking the tagged people out to secondary triage. Then there's going to be a treatment group. Then there's going to be a transport group. And then they're in the hospital. Okay? So, primary triage, I just taught you how to do primary triage. Secondary triage is moving that patient, getting them into a different area than when you first found them. And once the patient is moved to the treatment area, they'll be categorized again for that time. The staging area is where all the transport and emergency vehicles are held until needed. The treatment group leads to the transportation group. Pretty cool? Pretty cool? Now, I got more buzzwords for you we need to go over, okay? Make sure I got my, okay, we're good, perfect. So here are my buzzwords for hazardous materials, okay? Let's go through them. Asphyxiants. They will displace oxygen in the air and dilute oxygen concentrations in the air. An example would be methane gas. Carcinogens simply are cancer-causing agents like asbestos. Now, I'm going to give you a pearl here. This is medical terminology. Cardiotoxins. Toxin equals poison. Cardio equals heart. That's heart poison. Okay? Hemotoxins. Hemo means blood. Toxins, poison. Blood poison. Hepatoxin. Hepa or even hepata, okay, is liver. So hepatoxins, liver poison. Nephrotoxins. Nephro, kidney poison. Nerve poisons. Nervous system poison. Now, the only two here that I can't do that with is corrosives, carcinogens, and asphyxiants. Asphyxiants, right? See that X in the middle? If you have an asphyxiant in the room, you're going to be X'd out. That's how I remember it. Okay, you can't breathe anymore. A carcinogen, Ca, and there's an N in there. Ca, oh, it's almost cancer. There's another C in there. Almost. E, okay, that works. I remember carcinogen, cancer. That could work. That's the best I can do for you with carcinogens. Corrosive is the only one left, so that's your acid and bases. So corrosives you do A for acids, B for bases, C for corrosives. There it is. Okay? So let's do some examples. Carcinogens are asbestos. Okay? Cardiotoxins, snake venom. So with cardiotoxins, you can see here it could cause a heart attack or EKG disturbance, which an EKG disturbance means it can get you in a lethal heart rhythm. Okay? So sulfuric acid. So sulfuric acid would be the acid. Bromine's like a base. Hemotoxins, destruction of red blood cells. Snake venom, spider bites. Hepatoxins, damage liver over time. Now, alcohol and Tylenol are actual examples of hepatoxins. So can I give you an example? Let's take a man who's 30 years old, another man who's 30 years old. One man drinks alcohol and Tylenol every day for 30 years. The other one does dozens and just drinks water. What do you think is going to happen to that man's liver? That's why it is. It's a hepatotoxin, okay? Chloroform is as well, okay? Now, we got mercury, arsenic, and lead for nephrotoxins, and sarin, tabun, and VX for nerve poisons, okay? Now, final piece here, the hot zone is the exact location of the hazard is seen. So we have a hot zone, a warm zone, and a cold zone. The hot zone this is where the hazardous, the hot zone is where the hazardous material event is right now. That's where the bad stuff is. The warm zone is a buffer where we can kind of like decom and get through to the cold zone. The cold zone is that's where we are. That's where EMS is. EMS will have, minimal, PPE, but enough PPE. But we'll be in the cold zone, so we're not going to get exposed to any of those hazardous materials, right? Think fire might be in the hot zone, EMS would be in the cold. Okay. So a few pearls here. MDS sheets, so material data safety sheets. These are written product info required by OSHA, which I'm going to give you the definition of OSHA down below. Every compound produced, stored, and used in the U.S. requires it. That's all it is. So it's basically a info sheet on the exact product or of the compound. That's it. Primary contamination would be like someone in the fire department going to the hot zone and getting contaminated. And then secondary contamination would be the fire department member going in the hot zone, and then going into the cold zone and having everybody touch his uniform. Make sense? Okay. So placards. There are 9 classes. How many classes? 9 classes of placards. Okay, we're going to talk about truckers. So I'm a trucker. I'm driving down the road. I'm a trucker. And I got hazardous materials in the back of my truck, and I'm driving. As you drive by me on the highway, you see I got these 4-sided diamond placards or signs on my truck. There are 9 classes of those placards that tell the general public and you as a first responder what's inside of that truck. The shipping papers gives you the info, the name, classification, and United Nations ID number of the substance. OSHA stands for Occupational Safety and Health Administration. Just so you know, I don't want you to get that question on the test and be like, oh, I don't know. That would be terrible, right? We don't want that. So here we go, folks. Class 1 is explosives. Class 2 is gases. Class 3 is flammable liquids. Class 4 is flammable solids. Class 5 is oxidizers. Class 6 is poisonous. Class 7 is radioactive. Class 8 is corrosives. Class 9 is miscellaneous. There it is. My friends, I want you to watch this video over again. It could be now or a different time. If you do this, this is your EMS operation. If you know this cold, just check off EMS Ops. You're going to know it. You're going to do well in EMS Ops. Remember, EMS Ops is 1/5 of your exam. I'll see you there. Peace out.
I want to start with a little bit of a review. What are some of the main influences or factors when we're talking about the respiratory rate and the actual depth of respirations? So how deep we breathe and the rate at which we breathe at. So these are some of the most common things you'll see in your patient. So if the rate and or depth increases, for example, in anxiety and pain, if we have a strong need for oxygen, and also in a metabolic acidosis, the rate and depth will decrease, commonly in opiate overdoses, CNS depression, and metabolic alkalosis. Let's continue. I want to break down for you all of our abnormal patterns of how we breathe. You'll notice these abnormal respiratory patterns have to do with rate and how deep we breathe. And it is usually, obviously, a cause on why this actually happens. So, let's start for the easiest one, which is I have 0 respirations. Agonal respirations is the patient making strung out gasps. For the patient is either in respiratory or cardiac arrest with agonal breathing. It's not an actual respiration. They get a 0. That's agonal breathing. The last few breaths someone takes would be agonal. Now, what about too slow on the Brady side? This is a respiratory rate of under 12. Now, what are some things that will cause your respiratory rate to be too low? Could it be a chest wall injury? Yes. Could it be a drug overdose, like on opiates, or if you were to overdose on benzodiazepines? Yes. These things will cause you respiratory, key word here, depression. Do not get confused between respiratory distress and respiratory failure and respiratory depression. I want to tackle that right now. Respiratory distress is when our respiratory rate is too high and we have accessory muscle use. We may have retractions pulling in between the ribs. Distress comes first in a lot of medical emergencies. But which emergencies skip the distress step? The ones that cause this, that cause respiratory depression. Like an opiate overdose. Now, I'm going to flip this for you. Watch. Notice on the tachy side when it's too high and we're over 20. The majority of medical and traumatic emergencies, your respiratory rate would start too high in respiratory distress, and then when you enter respiratory failure, it gets too slow and sluggish. And then you get so slow and sluggish, you become agonal and you're in cardiac or respiratory arrest. We talked about where we skip the distress. Well, that's if we overdose, right? For example, pain and anxiety, that will cause your rate to go up. What is one of the hallmark signs of pulmonary embolism? Tachycardia, hypoxia, low SpO2, high heart rate. Pneumothorax starts off, I'm distressed, I have my respiratory rate too high. Now here are the 3 ataxic respirations. These are simply irregular respirations. So I'm breathing in an irregular pattern with pauses. So I'm breathing irregular, then I have periods of pausing. I'm breathing irregular, I have periods of pausing. These are common in strokes. These are common in trauma. And this is why there's damage to the medulla oblongata. That could be a test question right there. So, ataxic. Okay, it's irregular. There's pauses. My medulla oblongata is under attack. Strokes, trauma. Okay, got it. There it is. Cheyne-Stokes. Now, Cheyne-Stokes, common in trauma, common in tumors. It can happen while your patient's asleep, right? Heart failure patients. Different. It's fast and shallow breathing. So I'm fast and shallowly breathing. And then we switch to deep and slower respirations. So heavy, deep respirations. Okay? Kussmaul is simply put, we are in diabetic ketoacidosis. Do we have acidosis? Yeah, it's in the name. What else do we have? Well, our blood glucose is way too high. So we get this pattern of deep, rapid, so it's constant. Kussmaul respirations are constant, deep and rapid breathing pattern. These are the patterns you got to know. You will hear throughout your entire EMS education about respiratory distress versus respiratory failure. It is one of the most important concepts you need to understand. So I'm going to break this down for you right now. So I want you to imagine your patient. They're going through a respiratory emergency, which is causing them to not bring in enough oxygen. Now, what's the first thing that's going to happen? They're going to enter a state called respiratory distress, which means the patient has to work harder. They have to increase their work of breathing. And the body has to work harder than it usually does in order to keep the oxygen demand that the body needs up to par, right? Now, with respiratory distress, I'll read it to you here, increased work of breathing, which is going to happen. Why is this work of breathing increased? Because the respiratory emergency attacking this patient right now, name it, asthma, COPD, anaphylaxis, heart failure, pulmonary embolism, right? Just naming a few off the top of my head here. Inadequate gas exchange is going on in the body. So the body says, okay, we got to increase our work of breathing to combat this. So that's what happens here. When we enter respiratory distress is an oxygenation problem. We need to treat the patient's emergency and give them oxygen. Okay, that's distress. You're going to see, I'm going to go over signs and symptoms here in a minute, but just a little to get ahead of the game here. This is when the heart rate goes up, the SpO2 goes down. Okay? Respiratory failure. I'm going to read it to you here. Respirations begin to slow. Think, respirations begin to slow. Your patient gets tired. Sluggish respirations. At this point here, respiratory failure, your patient begins to not manage their own airway because they get so tired. The respiratory failure patient most likely is going to need ventilations by you. Okay? So, respirations begin to slow, patient gets tired, oxygenation and ventilation can't support the demands of the patient's body. This is where most commonly ventilation starts to begin. This is where action needs to begin, right? So we think more of NEBS, CPAP, right? Up in here. Oxygen. This is more, they probably are going to need ventilation support. Okay? Now, over here, obviously they're going to need ventilation support. Respiratory arrest. So, what is the difference between respiratory arrest and cardiac arrest? Respiratory arrest means you've stopped breathing, but your heart could still be beating, right? Cardiac arrest means your heart stopped beating, right? Which by default, you're not breathing, right? So respiratory arrest means patient stops breathing. Their respiratory rate is 0. Okay, now, there's another key term you're going to hear about throughout the course of your EMS education. I don't want to confuse you. It shouldn't. Just listen to me here. Respiratory depression means that some event could be an emergency, could be an overdose, is cause your patient's respiratory drive, which means their ability to breathe normally, is depressed. Respiratory depression, the most likely scenario you're going to find this, could be head trauma, yes, but would also, and most commonly, would be like a benzodiazepine overdose, which is a sedative. An opiate overdose is most common. So we hear this key term, respiratory depression, which means, for example, opiates will depress your respirations. So if someone is going to overdose on opiates, they're going to enter a state called respiratory depression, meaning your patient's respiratory drive is depressed, which means they're going to end up with slow respirations. Okay, so that's the key term I want to put this in, just to make sure you're aware about it. Now what I want to do is break down what are the signs and symptoms of distress versus failure. Let's do that next. So I've created this chart to show you respiratory distress versus respiratory failure. So the stress is all here, and then failure is over here. So we can do a comparison. So here's the stress. Remember that happens first. So a patient would still be alert, but they're maybe agitated or anxious. Obviously, they're having a hard time breathing. The airway would still be open. So, for example, the patient is still able to speak. Maybe they're speaking in 1 to 2 word sentences. They're going to have a little bit of labored breathing, but they're still awake. Their eyes are open. They're speaking, but probably only 1 or 2 word sentences. They have some labored breathing going on. They could be agitated or anxious, right? But they're still aware of what's going on around them, right? The airway is open because they're able to speak. Remember, if someone's speaking to you, then they can manage their own airway. If they're not able to speak at all, then they probably can't control their airway. That's a quick tip there. Now, what about the respiratory rate? So the respiratory rate and the heart rate both go up in distress. So I give you an example here. Let's just say the respiratory rate was 28, for example. Could it be 32? Could it be 26? Could it be 34? Yes. We know 12 to 20 in an adult is normal. So let's say 28, for example. That's an example, right? Try breathing 28 breaths a minute. You're breathing pretty quick. Skin condition would be more pale, okay? Now, respiratory failure. You're going to have confusion. You're going to have altered mental status. The patient's going to be tired, fatigued, right? Also, the airway most likely is not going to be pain. They're not going to be speaking to you. They may not even be aware of their surroundings because they're that tired, right? The respiratory rate is going to be lower than 12 in an adult. I give you an example, 8. Also, the heart rate goes down, bradycardia, and you have cyanosis, so it could be ballooning in the nail beds or around the lips. So we want to check for that. The ballooning of the skin would be really the worst. Now, what about some physical exam findings? You may have heard about retractions. Retractions is pulling of the skin in between the ribs. Accessory muscle use, most commonly around the clavicles and the upper part of the chest and the neck. So that is when the muscles, accessory muscles are being used in order to get that breath into the patient. This is not normal. We don't normally see that. That's why we need to expose our patient. You're in distress, right? Nasal flaring is an additional flaring of the nostrils. And then we have actual tripod position. So tripod position is when the patient is basically leaned over, their arms are like this. They're trying to get as much breath as they can. In pediatrics, we talk about something called head bobbing, where they're going to breathe to get the most air in they can. So basically it's inhale and then exhale. Inhale, exhale. If I position, obviously if we have a patient in the sniffing position, I get the most air if I go like this. So this all has to do with trying to get the most air in that we can, right? That's the stress. In failure, the biggest thing here, you give a patient, they're going to be slow, maybe described as slow, sluggish, tired respirations, and they're going to be low. And you're going to see bradycardia, cyanosis, respiratory rate is low, they're confused. That's failure. Now, I'd like to start with going over CPAP. So CPAP is continuous positive airway pressure. So remembering what CPAP is going to do. So picture our patient. They're struggling to breathe. They have a high work of breathing. And at the same time, their alveoli, where oxygen and carbon dioxide do their gas exchange. The alveoli is either a combination of filled with fluid, pus, or it's collapsing. Usually both works are happening at the same time. So what CPAP does is it pushes positive pressure into the patient's lungs, thus opening the lungs, opening up the entire airway tracts, but most importantly, opening up that collapsed alveoli. So the alveoli is collapsing, now it's open. So now we can get better oxygenation of our patient. That's great. But what else did it do? It's going to push off the pus and the fluid on the alveoli. So now we have a clear alveoli and it's open. SpO2 goes up. Work of breathing, now it's more calm. So let's go over a few things. So again, CPAP brings positive pressure into the airways. The increase in pressure allows the alveoli to remain open for gas exchange and push fluid off. So we think about our patient, let's say with CHF. What is their problem with CHF? They have pulmonary edema. We hear rales in their lungs, right? Bilaterally, right? Yeah. So that patient, their problem is they want to bring in oxygen, but they can't because there's fluid on their alveoli. CPAP can push it off and then open up the alveoli. Now they feel much better. Now they're thanking you. That's CPAP, right? But there's a few things that they need to have in order to get CPAP, right? The mask CPAP, right? We're talking about. So indications. Think about what I just told you. So in CHF, why we use CPAP? Just explained it. Asthma and COPD, well, what's that about? Well, we know that in asthma, we have tight airways, but we also have hypersecretion of pus in the airways too. Hypersecretion of mucus in the airways, right? Pneumonia is more, pus, mucus, but at the end of the day, the lungs are not going to know the difference. It's a hypersecretion in the lungs that's causing you not to breathe. So with asthma, COPD, pneumonia obviously is going to be pus-filled lungs from infection. We're able to open up the airways using positive pressure. So remember, the entire airways are being expanded. That helps asthma and COPD. We know that emphysema, which is part of COPD, already has, we could say, fractured or, not strong alveoli to begin with, right? So CPAP can open it up the best it can to its highest ability during this COPD attack, if you will. And obviously drownings, well, if we have fluid, we're still able to push that off, right? Like a submersion event. Now, when can we not give CPAP? Well, the patient has to be awake and able to obey commands to use the mask CPAP. Now, CPAP, it can be hooked up to the oxygen unit in the ambulance. It can also be hooked up to your airway support or a ventilator in the ambulance as well, right? Depending on what settings you have, right? So contraindications, unresponsive patients, well, they can't protect their own airway and they can't obey commands, so we can't use mask CPAP on them. If you're hypotensive, so the great thing about CPAP, is it's going to decrease the patient's work of breathing and the work demand on the heart. So that's going to decrease the blood return to the heart, which is good, for example, in a heart that's failing and already weak, right? So the heart is able to get to its best ability in the situation. The problem is, if you're hypotensive, we already don't have enough blood coming back to the heart. So that's why the hypotensive issue. So, pneumothorax, of course, we're not going to blast pressure into someone's chest when they have a pneumothorax. Nausea, vomiting, and any respiratory or cardiac arrest are not responsive. So nausea, vomiting is pretty simple, but if your patient is vomiting, the mask is well fitted. So they're going to vomit in the mask and then that's going to go down their airway. There it is. Now BiPAP. BiPAP stands for bi-level positive airway pressure. I want to plant this in your mind to remember it forever. And here it is. CPAP is continuous pressure. For BiPAP, there's a difference in pressure between the inspiration and the expiration, where there is no difference in CPAP. It's just continuous pressure. So think about it like this. BiPAP, we have a stronger pressure on inspiration to achieve our goal, which we just talked about. But then the patient still has to exhale. So to make it easier on the patient to get that breath out and exhale past this great pressure that we have, we lower the pressure down and exhale to make it easier to push back against that pressure. Right? So in your mind, think about it like this. CPAP is they're both for emergencies, yes, but for lack of a better term, CPAP is an emergent move. We're not going to keep somebody on CPAP throughout their entire hospital stay. BiPAP, someone can and they will. And why? Because the whole goal of CPAP and then later BiPAP is we don't want to intubate the patient. We don't want to have to do ET intubation. That is not good for anyone. That's the worst case scenario. Someone gets intubated and put in a ventilator. So if we use BiPAP, we have a good chance of having that not happen, reducing that. So let's go over all these terms here. So BiPAP, when the patient inhales, the pressure is similar to CPAP. It's the same as CPAP, right? So for example, with CPAP, there is no inspiratory and expiratory. It's continuous pressure. So it can be hard to exhale against that pressure, which makes the patient so anxious. But BiPAP is a little more comfortable for the patient. Again, think about it as more long-term. So the pressure drops and make it easier to exhale. Now, typical settings. So there's IPAP and the EPAP. That stands for inspiratory, the I, and obviously the E is expiratory, positive airway pressure. So when we have our settings on our respiratory device, our ventilator, what do we do? Here's what we do. Typical settings. The inspiratory pressure is always higher than the expiratory pressure. You got to remember that always. Now, typical settings would be, for example, 10 inspiratory, 5 expiratory. That's a good base to start with. Now, as the needs of the patient change, right? We have from 4 to 24 and then 2 to 20. But when in doubt, or if the exam asks you what's typical, this is typical. And remember, the inspiratory is always higher. They try and trick you with this being higher. Well, that's wrong. Inspiratory is always higher. Now remember, the goal to withhold ET intubation. Now, you're going to hear a word called pressure support. It's a key term. I just want to explain it to you. Pressure support is very simple. It just, these are the pressure settings, right? So you have your patient on BiPAP. It is hooked up to your ventilation device, your ventilator, and it's providing a certain pressure support. This is the pressure support right here. So I'm just going to read it to you here. Spontaneous mode of ventilation, where a ventilator delivers support with a preset valve based upon the respiratory rate. That's all pressure support is. It's the pressure provided by the ventilator. So here's BiPAP. I just wanted to make a point here about something called PEEP. Talked about a lot. I want to make sure you understand it. It's very simple. Earlier in this video, we talked about how the positive pressure keeps the alveoli open. That's what PEEP does. Anytime we mechanically ventilate the patient, whether it's through a BVM, through CPAP, through BiPAP, through ET intubation, because it's mechanical ventilation, there's some sort of PEEP, which is positive end expiratory pressure. What this does is keep the alveoli open from it being collapsed. That's all it is. So PEEP, that's what we have, okay? So CPAP, BiPAP both use PEEP at the end of exhalation. All this means is that the positive pressure at the end of exhalation keeps the alveoli open. So if anyone asks you what PEEP is, that's all it is, okay? And they all use it. Now, how do we walk a patient through starting CPAP, right? Here's what we need. So obviously we need CPAP mask. We need the oxygen delivery, of course. And then we have to kind of walk the patient through the procedure. So first, if we're thinking about doing CPAP on someone, first we have to look for indications and contraindications. Are the indications there? Make sure there's no contraindication. We talked about that already. Great. From there, we're going to gain vitals, sit the patient upright. Now, what do vitals look like? Everything. This is ALS. So, vital signs. We want to get them on cardiac monitoring. I would recommend doing an EKG. End-tidal CO2, pulse oximetry, lung sounds, all that. We want to get a determination and think, okay, here we are before CPAP, and then what do we look like, 3 to 5 minutes into CPAP, right? Cool. Now, the biggest thing here is you got to coach your patient. So remember, you just learned CPAP is going to be continuous. The patient's going to be a little anxious, but in about 3 to 5 minutes, then they're going to feel a lot better once they let it work into them. Now, what do I recommend as far as starting? You may have heard that with patients that have, asthma or COPD, start lower, CHF work higher. That's not wrong. It's not wrong, but there is a range. So the range is 5 to 10 is going to be your actual setting as far as the pressure. Okay, now, you can always start low and work your way up, and that's what I recommend. So I would say with any patient, start at 5, and then you can work your way up. There is a titrating to effect with pressure, and like with all patients, even with their being ventilated, okay, in different scenarios, right? So that's what we have here. Now, the last thing I want to talk about this is, what if things go wrong? What if they go bad? What if your patient gets worse? What to look out for? You need to continuously be doing lung sounds in your patient. We want to make sure that the lung sounds are either improving or watch out for pneumothorax. A lot of pressure being put in the chest, right? We know they're hooked to the end-tidal CO2 and SpO2. That's all great. We're monitoring EKG. We're trending vitals 3 to 5 minutes. That's all great. But what if your patient has a deterioration of mental status, or we see the vitals slip, or end-tidal CO2 slips, or SpO2 slips while using CPAP? This means your patient is, unfortunately, they've crossed into a point where now it looks like they're in respiratory failure. They've entered that. They're nearing arrest. We're going to have to take the patient off because usually at this time, remember, mental status. They're not able to obey commands anymore. They're getting sluggish. This is where we're going to have to intubate the patient. There it is. Understanding trauma is that it's different from a medical emergency. But we can have a medical and traumatic event also happen at the same time. But most of the time, it is 2 separate emergencies. I'll make show you some examples. First, I want to define with some definitions. So a traumatic emergency versus a medical emergency. Trauma is physical force on the body. Medical emergencies is an illness or condition not caused by an outside force. If we have a heart attack, a car running into me didn't cause the heart attack. The heart attack was the heart's fault. See? Physical force on the body is trauma. Illness condition is medical. So now we have that defined. You always want to have a high index of suspicion for medical and traumatic events that occur in your patient. Now, one of the most common ways you'll hear about medical and traumatic injuries and illnesses combining is someone who's driving a car and they have a stroke while they're driving, then they get in an accident. They have a heart attack while they're driving, then they get in an accident. You will see that in your career because it does happen. So remember, these can happen at the same time, but most of the time it's different. Most of the time, for example, a fall victim who falls as a trauma, a stroke or anaphylaxis, pulmonary embolism, asthma, medical. MOI. MOI means mechanism of injury. What does that actually mean? The mechanism of injury describes how the force, the physical force, was actually enacted on the body. So what happened? How did you hurt yourself? That's the MOI. We are going to go over in a little bit what a significant or severe MOI looks like. Okay, so hang with me. Now next, we're doing all key terms here. Kinetic versus potential energy. Kinetic energy is a perfect example I can give you. There's a man on top of a roof. The man on top of the roof falls off the roof. When he's sitting on top of the roof, he's in potential energy. He has the potential to create energy by falling off the roof. okay? When the man accidentally falls off the roof, he has kinetic energy because he's moving, all right? Just the way I always remember it. So kinetic is moving energy, or at rest energy is potential energy, the way I think about it. Blunt versus penetrating. If I have a baseball bat and I swing the baseball bat and I strike someone in the abdomen, the baseball bat is not entering their soft tissues. If I take a sword and do the same thing, now I'm penetrating, I'm entering soft tissue. So, blunt trauma isn't, again, this can be a motor vehicle accident, a fall, same deal, right? If someone was to fall and were to fall onto a spike, the spike would penetrate them. That's penetrating trauma. If they were to fall on the cement, that would be blunt trauma. So, I'll read it to you here if you can't read it. Force without entry into soft tissues is blunt. Positive penetration to soft tissues, penetrating trauma. So what's the classic? I get in a motor vehicle accident, oh, I hit my head. Let's just say, for example, I wasn't wearing my seatbelt, I hit my head, blunt trauma. Penetrating, gunshot wound, knife wound. There it is. So here are key terms. Let's continue. So let's start with motor vehicle accidents. You're going to hear in class, and you had to know this for NREMT, there's three main phases of a motor vehicle accident. I like to call this the 3 phases of impact. So these are the 3 impacts that are going to occur in a motor vehicle accident. So I'm driving the car, I'm about to get into an accident, I'm driving. Let's just say, for example, I strike a guardrail or a wall. Picture one of that. I'm driving, boom, I hit the wall. The first impact is the vehicle to the actual object the car is striking. Secondly, me as the passenger, I'm then going to strike the inside of the car, right? Whether I'm not wearing my seatbelt and I get ejected, I'm still going to hit either the windshield, something in the car is going to happen first, right? Now, if you're wearing your seatbelt, obviously in this stage 2, that helps a lot, right? We're not going to move as much, okay? If we're not, we can be flown around. We can be moved around a lot, okay? We can end up in another seat in the car, okay? Just to give you an idea. Number 3 is our internal organs are going to strike against solid structures in the body, aka bones in the body, okay? So we have to think about it. Vehicle versus object, passenger hits something in the car. The last step is your internal organs are going to hit solid structures. So I like to think about the brain hitting the skull. So the brain will go back and forth in the skull. That can cause a head injury, of course, right? So these are your 3 phases of impact. You got to know these. This is your significant mechanism of injury events. We're talking about the motor vehicle accident. What this means, your patient, more than likely, will be severely injured by this event. So, the first one I want to talk about, you can have this happen, and it's usually a test question. And what it has to do with is your patient is still alive, but another patient in the same vehicle has died. Is that considered severe MLI? Yes. This is always a test question, so remember this. If your patient's still alive, well, obviously that's great news. But if we have a death or a dead arrival in the same vehicle, that whether the patient's doing well or not, there was a high amount of physical force enacted on the patient. This is the key. Well, remember, significant MLI means a large amount of physical force has been enacted on your patient's body. We can't always see everything internally, but we can see this. You see where I'm going here? So this is what I'm saying is, if you see any of these here, you want to have a high index of suspicion for bad stuff going on here. Now, death of anyone in the vehicle, severe deformity of the vehicle, or we have a new word here, or severe intrusion. Intrusion means essentially that we have, for lack of a better word, we have deformity going into the vehicle. So if I'm sitting here like this, right, intrusion means that literally the car is moved closer to me. Whether the outside of the car is bent in towards me. That's intrusion, right? And then deformity is just severe deformity of the vehicle, right? Obviously, if you're not wearing your seatbelt, it's possible that you can get ejected from the vehicle. That's not impossible. Ejection from the vehicle. Now, I've put a with here, but I just want to share this with you. If you have a type of motor vehicle accident, please hear me on this because it reads a little differently than I wrote here. If you have a rollover a rotational event or a T-bone, and I'm going to explain this in more detail in a little bit. Now, a rollover is when the car rolls back on itself. Rotational is the car going like this. A T-bone is here's let's say this is my vehicle. Here's a vehicle striking me on the side here, right? So what this means, any rollover, rotational, or T-bone like motor vehicle accident, those should be looked at as significant. But what I'm telling you is this. Remember the severe deformity and severe intrusion? If we have, moderate to severe intrusion, if we have intrusion or severe deformity with these type of MVAs, that is something I want you to look at and go, this could be really significant. So we have 5 main types of motor vehicle accidents. Now, it goes without saying that, remember, if we have a high amount of physical force, a high amount of speed, acceleration, of course, we can have a really bad outcome with motor vehicle accidents. So a frontal MVA, what that means, I'm the driver and my car goes straight into a wall this way. That is I am the patient and I'm in a frontal motor vehicle accident. This is your classic accident. It's the most common accident. So the biggest thing here, it's when I say classic, we're going to check all this stuff, but everything, our airbags, our intrusion, is the vehicle safe, seat belt, all that good stuff. That's classic. But when I'm in front like this, and I can look at you this way, here I am driving, right? If I do not have my seatbelt on, I have 2 places I can go. I can go up and over the dashboard, see you later, or I can go down and under, right? If I wear my seatbelt incorrectly, I can also go down and under from not wearing the lap portion in like older vehicles, right? So those are some of the things that we're thinking about. Am I down and under? Am I up and over? Knees going straight into the dashboard, right? Those are some of the things we're looking at, which you can call as hip injuries, with a frontal MVA, right? Now, what's the pearl about airbags? Well, the whole idea of airbags was so that our head isn't striking. So it helps a lot with the head, face, and neck injuries. But we still have our legs and the rest of the body that could be struck, right? Seatbelts make sure we don't eject out of the vehicle. Airbags make sure we don't have a massive head injury or neck injury. With a frontal crash, you're going to see that, the airbags aren't going to help they can help, but you can't avoid some injuries depending on the force. So let me share it with you. Rear end motor vehicle accident is most common for whiplash. So your neck going back like that. Lateral MVA, the lateral MVA is your T-bone. Remember, here I am going this way, car comes this way, boom, this car got T-boned, okay? So a T-bone is lateral. It's one of the most deadly because we have multiple forces. You can roll over. You're going to rotate, right? It hits the car at the wrong point of its gravity. So T-bone, deadly as we discussed. Negative can be, not always, can be. It has potential for it. It's key. Lateral injuries to the whole body. So the whole body is going to be turning. So you have lateral injuries literally from the head down is what we're looking for. Rollover motor vehicle accident is more common with vehicles that are more tall. So I'll give you a perfect example. Sprinter vans, those high potential for turning over. The ambulance, SUVs, large trucks, anything with a very tall build, they're at a higher risk. Watch for ejections or partial ejections with a rollover. Rotational, basically, the whole idea that it's spinning. So if I'm in a rotational accident and I'm spinning, let's say a picture a highway, and I can kind of come over here. Let's say I'm in the left lane, the middle lane, and let's say there's 3 lanes, and then we have over here the slow lane, for example, right? Let's say I'm over here in the left lane, right? And I get a rotational accident over here. I could hit cars in the middle lane. I can hit cars over here in this lane. I can hit the guardrail over here. I can go into it could be a house over, whatever, right, on the highway. The spinning action causes you to strike other objects, where in some of these other MVAs, you're not moving as much. So that's the danger with rotational, is that other objects that wouldn't be involved get involved. So now we're talking about falls. So obviously the most common fall victim that we think about is someone falling from standing height who is an older patient. Now, why do these falls occur? Well, I'll give you a few reasons that could be the culprit of why patients fall as they get older. 1, lack of strength, coordination, and balance. 2, could even be medication mismanagement. 3 is falling hazards in their home or environment, like area rugs, like clutter, right? If a patient has to make an awkward movement, they might fall, right? Their balance is not what this used to be. So those are some of the first things that I've seen and come to mind, all right? Off the top of my mind, I'm kind of going to give you one more that can happen, is when a patient may have a near syncope or a dizziness episode. For example, going from a seated position to standing up, or going from getting out of bed to standing up, they may get dizzy, causing a fall. So those are some of the most common ones that come to mind. So let's continue. I've got to give you a few falls. So falls, we're talking in this case about adult patients. I have a pearl for you and a little bit about children, so hang with me. Falls. Fall should be considered significant over 20 feet. If you hear over 20 feet, significant, that's period on that. Now, we think about falls that are 3 times the patient height. That's significant. I would even say twice patient height is significant, right? But 3 times, that's really severe. So think about this. Falling from standing height is falling from let's just say you were 6 feet. Fall 6 feet, okay. 12 feet is double, 18 feet is 3 times. That's why I'm saying 20 feet is significant. What if someone's only 5 feet? See? Now, here's what we evaluate. What was the height of the fall? What did they land on? And then also, what body part hit first? Let me explain to you. So what this means. A patient who does not have a lot of strength, coordination, and balance, for whatever reason, not only just an older adult, but even patients that are have cognitive impairment, for example, they may be the sort of patient where they don't have the strength to brace their fall. They literally just fall right over, right? Whereby someone who has strength and coordination will try to brace their fall with their, usually most likely is their arm, and they break their wrist, right? So broken wrists, broken hips are very common with falls, right? If I just fall right over, I might just break my hip, right? If I was to fall over and then I try to brace myself, I can break my wrist, right? So that's the key. Now, why do older adults break their bones? Like, they're falling on a carpet, right? So we do our evaluation. Let's say they fall on a carpet. They're falling from standing height. They're not falling from a roof. Why are their bones just breaking so easily, right? Osteoporosis. So osteoporosis, what this means, the bone structure is not what it used to be. So the bones fail, fracture, break, under relatively low stress versus when they were younger. So we should assume as EMS that every single elderly fall has osteoporosis until proven otherwise. That fall is significant even from standing height. So here's some keys. I got a pearl about children I want to give you real quick. When we're discussing children that fall, I had to give you a pearl. So young children, remember, proportionally with their body, their head is quite large proportional to their body. So what this means is young children are top heavy, which means even a small fall, they end up landing on their head. So we want to consider head trauma always with young children and really assess for that. The other thing is, what do we call significant in children? Well, obviously it's different because children aren't as tall. So what we say is falls greater than 10 feet, that's significant, and or 2 to 3 times the height of the patient is significant. A good rule of thumb always in falls is if the fall height is 2 to 3 times the patient's height, it's significant. There are 4 main levels, 4 main phases of a blast injury. So here I am on the patient. There's a giant explosion next to me. There's 4 main phases of what's going to happen to me as the patient. This is something that is taught in trauma, and we just need to understand this concept. Do not overthink this. A simple question on an exam will just say, this happens, this event happens, what blast injury category is this? And it'll be 1, 2, 3, or 4, which I'm going to explain to you now, okay? We can see our names here, the primary, secondary, tertiary, and then our 4th level here, okay? All the names are here for you. Now, at the 1st level, the energy and pressure from the blast itself goes to our patient. The second part is when there's basically like missiles, like not actual missiles, but literally like debris in the air that gets turned into projectiles striking the patient. The third, well, we have to land at some point as we're being expelled in the air. So the impact with another object, meaning like we hit into a wall or fall, whatever. Then 4 is, well, what's the aftermath basically? So we may have gotten burned, we may have a crush injury, toxic injuries, acids, alkalis, what happened, right? Or skin. So that's the way I like to think about it. Blast itself, primary, we move, debris hits in the air. Third, we gotta land. 4, what's the aftermath? What do I end up with, right? Because of this blast. There it is. Now, wrapping up our trauma overview is understanding what a level 1 trauma center is. So a level 1 trauma center is the highest level of actually talking about the hospital. The hospital being at the highest level possible for trauma care. So what this means, a few key terms we'll go over here. So 1, there is total care for every type of injury. So you name an injury, that hospital can take care of it. They have the physician teams in order to take care of any injury. Secondly, it's a 24-hour in-house, on-call, on-standby coverage for surgery and includes specialties. Now, I put a few different ones here just for examples. But essentially, any specialty, they're on call, they're there. Orthopedics, neurology, radiology, critical care, pediatrics, cardiovascular, you name it. They are 24-hour, they're on call, they're there. Now, 2 other things that the Level 1 Trauma Center does off of patient care. 1, they're usually the leader of education, and also they're usually the leader of getting research and studies done, directing, we're talking about trauma. So you can see here, leader in region for trauma education, and performs research to direct new care innovation. So that's what makes up a Level 1 Trauma Center. It has to do with that coverage. It has to do with the specializations being all available, the education, and the research. So let's start with external bleeding. We're then going to talk about internal bleeding. Then we're going to talk about some skills. We're going to talk about hemostatic agents, tourniquets, application. Here we go. Now, first things first. You may have heard the word hemorrhage. Hemorrhage is a fancy word for bleeding. Hemorrhage, bleeding, same thing, same word, so you see it here. Now, I want to just read this to you real quick. The average adult male has 70 mLs per kilogram of body weight of blood. The average adult female has 65 mLs per kilogram of body weight of blood. What this means, we take a 175-pound male, his blood volume's around 6 liters. Now, at around 20% or more, the body can't tolerate this blood loss, and we're going to start seeing signs and symptoms in our patient that are ominous. The first thing we're going to see is an increased heart rate, an increased respiratory rate. When we're into hypovolemic shock, that's when we see low blood pressure because we don't have enough volume in our body, right? Now, take a 1-year-old. This is key, okay? Take a 1-year-old. A 1-year-old has a blood volume of only 800 mLs. So a 1-year-old only has 800 mLs of blood. They're a lot smaller than a 175-pound male. Agreed? Right. So what this means, using our 20% rule, okay, if they lose, say, 100 or 200 mLs, which is not a lot of, like 100 mLs is, you know, a 10 ml normal saline syringe, right? Times that by 10. That's significant blood loss in a 1-year-old pediatric. It's significant. So 20% is based upon who we're talking about, right? Now, just so you're aware, the average whole blood donation is about 500 mLs. And if that's, you know, over 15 or 20 minutes in time, The body can handle that as long as the patient's healthy. That's like a normal blood donation. Just so you're aware of the levels. If you have any questions on this, we tackled it. There are 3 main types of bleeding with external bleeds. The worst and the least likely to clot is an arterial bleed. It is bright red blood that is spurting out of the patient, and it's timed with the patient's pulse and heartbeat, their pulse, right? So, bright red, spurting in time with the heartbeat, the pulse, is the worst case. The least likely to clot, most sinister, arterial bleed. Why? It has the most pressure. It's spurting out in time with the pulse. The venous bleeding is darker color. Now, what to deal with the color? The arterial bleed. Remember, the arteries carry more rich oxygenated blood, and the veins are going to be oxygen poor. So, they're darker in color. So now flow could be rapid or slow, but it's not spurting out of the patient. There's less pressure, so there's no spurting, and it's darker in color. Venous bleeding can clot. It's possible, but it's also more sinister than capillary bleeding. Now, capillary bleeding is the most likely to clot. It's dark red, it's oozing, and steadily but slow. Now let's talk a little more deep about bleeding. Now, most bleeding stops within 10 minutes. So let's just say, for example, this here is a little diagram I have here of the blood vessel. Here's the actual cut, or the bleed, or the hemorrhage. Remember our key terms, right? So here are the arrows. That's the blood pouring out of the vessel. Let's say it's the capillary bleed. So one skin is cut. You go, oh, I cut myself, I'm bleeding. Okay, skin's cut. Blood pours out, right? This is what happens. Now, remember, most bleeds stop within 10 minutes. Now, number 2, see how this is open right here? So what's going to happen is the body is going to say, okay, we need to vasoconstrict, which means narrow the opening, right? So we have a cut here, an opening in the vessel. So the body is going to narrow, vasoconstrict, kind of narrow this up. Okay, so let's say we're left going down, going down, going down. So now we will start out here, right? We've narrowed it down, vasoconstrict. Now the next part is clotting, which in medicine is called coagulation. You may have heard about drugs called anticoagulants. That is called a blood thinner, an anticoagulant medication. There's other videos on that inside the course. You can see under Prescription Meds Mastery more on that. But this is the key term. Coagulation is how you clot. If you're on an anticoagulant, that means that you, if you bleed, are going to have a harder time clotting, which means if a patient on a blood thinner, aka an anticoagulant, hits their head, cuts themselves, they should probably be transported to hospital because the risks are higher with those patients. There's also a class of patients called hemophilia, meaning that the patient can't clot. Okay? Now, the third step is a clot. So what's going to happen is the body is going to now basically plug the hole. So now we're going to clot up, and now we're back to normal. So if we think of the most minor cut that we've ever had, that's what happens. Now what happens if the skin's cut, vasoconstriction occurs, great, and then we do some clotting, but what if that's not enough? What if the damage is so bad to this vessel and so deep to this vessel, say it's that we can't actually clot. The constriction fails. All these, the human body process fails. What do we do? Well, at this point, we have what we call an uncontrolled bleed. This is where patients have a life-threatening event. So what do we do now? That's what we're going to talk about next. I'm going to show you something really cool. Internal bleeding is a lot more sneakier than external bleeding. Here's why. All we need to do to find external bleeding is expose our patient. If we expose our patient well enough, guess what? We find the bleed. With internal bleeding, it's sneaky because an internal bleed could literally simply present, I'm tired, I'm weak, and I'm dizzy, I don't feel right. But then they find an internal bleed, right? So let's go through a few different scenarios and patients we may see. Let's start by going through all this, then we'll talk a little bit. Internal bleeding, not as easy to detect. We went over that. Now, a contusion, okay, which a contusion is bruising, over the skin that we can see. A contusion can clue you in to internal bleeding, right? Now, watch out for broken bones, fractures. For example, a fractured femur, that can result up to 1 liter of blood in the patient's thigh. And any sort of broken bones or fractures, you gotta think there's a risk of internal bleeding. A fractured rib can puncture the lung, for example, right? We talked about the femur. The pelvis can store a ton of blood in it if there's a bleed or a fractured pelvis in here. So that's what we want to look at. Now, signs and symptoms. I've put your clear-cut hallmark signs here. Tachycardia, dizziness. For the patient may say they feel like they're going to pass out, like we call that a syncope if they pass out. A near syncope is that they're about to pass out. Syncope. Cool, clammy skin, shortness of breath, weak capillary refill. That's a big sign in children. Hypotension and altered mentation. So you go to your patient, I just don't feel right today. I'm a little short of breath and I'm dizzy. I feel like I'm going to pass out. What happened? Internal bleeding. Right? So watch for blood in. They could be, where could we find out? Well, we expose the patient, we see a contusion. That could be it. Right? Now let's talk about things. Blunt trauma, but there's no cut. Obviously, that can cause an internal bleed. Okay, we got that. Sneaky ones. If I'm coughing up blood, if I'm urinating blood, or if in my stool there's blood. Also, the stomach. Like we leave an ulcer and it's bleeding, right? Esophageal varices, bleeding, right? So we want to look out for and ask, hey, have you had any dark, it's basically black stool is how you know that there's blood in your stool. Dark black stool. Urine, that's hematuria. And then vomiting is hemoptysis, okay? So we want to look out for these signs in our patients for internal bleeding. So here's our look at EMS treatment for bleeding. Quite simply, here it is. So EMS treatment, apply direct pressure with a bandage. So we're going to use our pressure dressing, our bandage. Let's say I was bleeding from right here. Okay, to give you an example, we'll start with an extremity and then we'll do like an odd area. Okay, so here's an extremity, right? I'm bleeding from here. First thing I'm going to do, I, of course, wear gloves, eye protection, direct pressure, bandage. Question, is my bleeding controlled or not controlled? Let's say it's not controlled. Then the question is, could I use a tourniquet? Well, in extremities, we can use a tourniquet. Now, let's say the bleeding was from here. I can't tourniquet my stomach, right? So, if we can use a tourniquet and it's on the extremities and we're able to use a tourniquet there and it makes sense, we'll apply a tourniquet to stop the bleeding. Let's say we're unable to the tourniquet to be used. We're going to use a topical hemostatic agent. And I'm going to explain a little bit more on that in a second, okay? Now, a question I always get, let's say someone was impaled with an object, do you remove the object, stabilize it? What do? You will only remove an impaled object if it is blocking the patient's airway from literally breathing. Besides that, the impaled object, you're going to stabilize it with some dressings, some bulky dressings, and apply direct pressure, okay? Now, you want to stabilize the object so it's not moving around and making it worse. That's the impaled objects by the books. Now, here's what we have. Let's move on, and I'm going to talk about right here how we actually apply a tourniquet and how do we do the topical hemostatic agent. Now, let's go over our tourniquet application. We're going to go over this first, and I'm going to actually show you the tourniquet so you can just get your eyes on it and be more familiar with it. So, tourniquet application. The tourniquet is placed about 2 to 3 inches above the bleeding site. Remember, we're using it on the extremity. We're going to wrap it. Now, step one is we're going to wrap a tourniquet around the extremity until it is tight. And I'll explain what tight is. So, tight means your fingers, if I take 3 fingers, let's say I had a tourniquet here, and I was trying to slip the fingers underneath the tourniquet. I shouldn't be able to do that. That's considered tight, okay? Called the 3-finger rule. Now, we're then going to turn this, this is the dial, and I'll go through all the features. We're going to turn this dial until the bleeding stops and we have no pulse. So let's say our bleeding site was here again. The bleeding would stop, and then I'd go check for a pulse distally, which is down here. I would check for a pulse, no pulse, okay? Distal to the injury, so below the injury, there's no pulse. And then you're going to mark your time. So what I've done is I actually opened the entire tourniquet just so I can show you and so you can get used to it. So this little red piece is here to remind you actually where we can enter in here on the tourniquet. So here's our cat tourniquet. Here's our time. Here's our turn dial. So red goes into here. Ready? Boom. Okay, this is the cat tourniquet. Okay, so now my tourniquet is ready to go. So now all I gotta do now is wrap this around the patient, tight. Remember our 3-finger rule. Once I have actually tightened this tight, there's my turn dial. I'm gonna turn this piece right here. I'm gonna keep turning it. And you can see how there's a little opening here. I'm gonna lock this inside of here. And then this is my top part. I'm gonna throw it over here. And then our tourniquet's gonna be in place. So these right here is your setup. And remember, you're going to place this tourniquet 2 or 3 inches above the site. We use hemostatic agents where a tourniquet, it's not able to be used. For example, if I have an uncontrolled bleed in my abdomen, I can't tourniquet my abdomen, right? A tourniquet's used on extremities, right? So, if we have an uncontrolled bleed, direct pressure has and bandaging has failed, and we're still having uncontrolled bleed, this is where we use our hemostatic agents. So you may have heard about Quick Clot. It's probably one of the most common brands. So let's talk about this real quick. It's a dressing that has built-in chemical compounds in the actual dressing that you're going to pack into the wound that promotes clotting. So the body has failed to do the clot, so we use this to assist it. Okay? Just the 3 simple steps. 1, identify the wound. 2, pack the wound with the dressing. And then 3, we're going to continue to apply direct pressure, and then we can obviously bandage on top of that. So that's going to be our steps. Our final piece is epistaxis, which is a nosebleed. I want to show you also how this works, how we treat it. So the goal is to maintain the clear airway. The old school thinking was we put the head back, but what happens is the blood goes in the airway. And then we have a lot of bad stuff. We have blood going in the stomach. We have blood going in the airway. Patient gets more anxious. Nobody wants that. So that's not how we do it. Not how we do it. Here's how we do it. Sit the patient down. Have them lean their head forward. And what we're going to do, that promotes the blood coming out and not actually going this way. Instead of down, we go into their airway, right? So, sit, have the patient, and PT means patient, by the way. Sit, have patient lean forward with direct pressure, pinching the nostrils like this. So what you want, this is like the bony part of the nose. See, this is the fleshy part of the nose. You want to go right here and pinch it here, okay? That's going to be a direct pressure, hard pressure pinch. Then you can apply an ice pack over the nose with direct pressure. You want to do this for at least 10 to 15 minutes. 15 minutes would be ideal. Now, why would we have a nosebleed? Well, sinus infections, direct trauma, right? Cocaine use, drug use, any sort of drug use with the nose. Some cancers, high blood pressure promotes it, hence the cocaine, high blood pressure, right? And then finally, could be a head injury or a skull fracture. Soft tissue injuries has to do with the skin and the underlying tissues underneath the skin. The easiest way to differentiate a closed soft tissue injury versus an open soft tissue injury is determining, is there a break in the skin or did blunt trauma cause damage underneath the skin, right? Now, I'm going to talk more about this, but let me just break down the basics. So closed soft tissue injuries, soft tissue damage occurs underneath the skin with no break in the skin. So blunt trauma, right? Open soft tissue injuries, there is, yes, a break in the skin. That's more like penetrating trauma, right? The skin at the surface exposing deeper tissues, right? Now, the big key with soft tissue is soft tissue, very similar to like falls. One of the most common calls you're called to in EMS. You can get called to a simple cut, maybe you need like stitches in the ER, to a life-threatening bleed. So this is the start of soft tissue. So starting our closed soft tissue injury, what we're looking at is, remember, closed soft tissue, we think about blunt trauma. Right. Now, what do we see? Well, if we have a closed soft tissue injury, we're going to see it. Well, there's the history of the event is probably blunt trauma, pain in the site, discoloration at the site, and swelling at the site. So pain, swelling, discoloration, blunt trauma history. Now, what do we have here? A few key terms I want to go over, okay? Contusion. So a contusion is the medical term for a bruise. Now, what's a bruise? Well, a bruise means there's bleeding underneath your skin, okay? Now, you may have heard about someone getting a black and blue eye or a black and blue, right? What this means, that discoloration is the later stage of you having a contusion, and what that causes ecchymosis, okay? Now, hematoma. Hematoma is when a blood vessel has been damaged enough where blood will actually pool in that site. So hematoma can be minor or be really severe and can actually pool a lot of blood. A lot of blood meaning 500 cc's, a liter, right? Depending on where it is. So hematomas can pool a lot of blood. A hematoma would be more ominous that there's been a large MOI enacted on the patient's body. So hematoma is a blood vessel that has damaged and bleeds and that blood vessel bleeds into the surrounding tissues. So that's pretty bad, right? So blood pools together. So here are a few key things we're talking about with closed soft tissue. Crush injuries. What we're talking about when you hear a crush injury is a patient that is pinned. So I want you to, for example, let's say a patient was pinned under some rocks, for example, right? Or let's say there was a building destruction. The patient was pinned under a building collapse. The patient's unable to move and the body's pinned. We always commonly think of the legs being pinned, right? So we can picture that in our minds. So there's a crushing and or you can call it a crush injury versus a crush syndrome. I'm going to explain. So the crush injury is the injury itself. Crush syndrome occurs after 4 hours or more of being pinned. So the crushing injury is significant force applied to the body. Damage depends on how long the force was applied and how heavy. This can cause circulation to be cut off in that region. So what are we saying here? Well, what we're saying here, the patient's pinned. The patient's pinned, arterial blood flow is having a hard time getting down to that pinned section. So all the circulation that's in that area is literally just at rest in stasis. And there's no blood movement to that area. So the tissues start to die, right? So this is what we're looking at, right? So this can cause circulation to be cut off in that region. Crush syndrome is when a patient has been trapped for over 4 hours. Arterial blood flow is compromised. Crushed beyond repair. So with crush syndrome, let's say I'm pinned and my legs are pinned. If my legs are pinned, I do not have good blood flow going to that part of my legs. So what happens? What's going to happen is the body releases these harmful substances to the tissues that are being affected, that are being injured beyond repair in that area of the leg. But the circulation is not that. Those harmful substances are just sitting there and they're waiting to the circulation to return back once we actually free the patient. So, I recommend highly, if you are an EMT provider watching this, that you call ALS, call a paramedic to have ALS on standby so they can treat the patient. But also, you want to give IV fluids before releasing and freeing the patient. So you want to clear out some of that harmful substance. Now, the other thing I want to tell you about is these harmful substances in some patients can even cause cardiac arrest. So you want to be very careful when moving this patient. In practical real life, it's not unheard of. Like, put the pads in the patient, like while you're having to extricate them. Especially call a paramedic for a long extrication like this, or we're thinking about crush syndrome. So that's what we're looking at here. Now, in school, you may have heard about compartment syndrome. What this is we have a compartment of soft tissue. That soft tissue is very limited in how it can expand and contract. So what happens is, let's say we have a soft tissue injury, right? In this compartment, we can have edema, we can have swelling, so much so that it increases that pressure inside the compartment, and what happens? Well, when we have that edema and swelling, circulation to that area can be decreased because there's so much swelling and pressure in that compartment. This is called compartment syndrome. So what happens is this can lead up to tissue death due to lack of circulation. And this is more common in the extremities. The other thing you want to realize is the longer this pressure is inside this compartment, and then we have that increased edema and swelling, the more likely we could have tissue death. So now we're talking about open injuries, open soft tissue injuries. What we're talking about here is our most superficial layer, our layer of skin has been broken. So our protective barrier of our skin has been broken, causing a soft tissue injury underneath and to the actual skin itself. Now, with open soft tissue injuries, it's very common for the site to be contaminated or infected. So we want to really caution and big concern here for infection. Infection is very common with these wounds. Now, I've put a few here. We're going to talk a little more about open injuries. We have abrasions. So abrasions is caused by friction, like a rug burn you may have heard that's an abrasion. So that's caused by friction. It's a wound, and it can be oozing blood, right? Like capillary bleeding could be. Wound to the superficial skin, okay? A laceration versus incision. So we hear the word, let's talk about the word cut. Oh, they cut their skin, right? Well, that's what we're talking about. But you commonly hear an incision when you talk about surgery. Well, an incision is defined as a sharp, smooth cut. A laceration is a jagged cut, right? So that's how we think about these two key terms. A few more for you. What's an avulsion? Well, an avulsion is like a flap of skin coming off like this, right? At the flap of skin. So basically, we're separating multiple layers of the soft tissue. So that's an avulsion. So it separates layers of soft tissues. Now, I can have a flap of skin completely detached. That's an avulsion. Or it can be left as a flap. Again, it's a flap of skin. It could be like this, put it back over, right? That's an avulsion. Then finally, we have amputation. So with amputation, that is a full severing of a body part. Now, it could be any body part, but commonly we think of, let's say we have a severed leg or a severed arm that would need a tourniquet most likely. I want to give you a game plan for someone with a soft tissue injury on the closed and the open side for treatment. So here's what we have. On the closed side, I give you the mnemonic RICES. So here it is. R is for rest. That's comfort. So keep your patient comfortable, right? Now, this is used a lot in sports, athletics, therapies. What I've done is here's a mnemonic, then I've put an EMS twist on it. So I'm going to explain. So R is going to be rest, which in our case is going to be keep the patient calm and comfortable. I, ice. So an ice pack for keep it iced, that we have that. C, compression, so apply pressure, okay. E is going to be elevation to decrease swelling. And then S is going to be splint, which splinting a closed soft tissue injury does the following. Decreases swelling, pain, and bleeding. So that's pretty cool. Now what about open? Well, an open soft tissue injury is basically an external bleed. So the same thing as we do for external bleed. Direct pressure with bandage dressings, and then if needed, if we need to, it gets that far, tourniquet if we're able to, like an extremity. And then if not an extremity, but still bleeding and uncontrollably, hemostatic agent. There it is. And evisceration is when an organ is protruding through the open wound. A common example is like intestines, coming through the abdominal wall out into the open through a wound. Now, we don't want to touch or move the organs. What we want to do is cover with a sterile gauze that is moistened with a saline solution. Then we want to cover and secure over that with an occlusive dressing and then taping it together. So the whole goal is we want to keep the organs that are protruding warm, moist, and what we want to do is block it out from further contamination or infection. That's the goal. What about impaled objects? Well, the impaled object is only removed if it is literally blocking the airway. If it's not blocking the airway, we're not going to remove it, okay? So what are we going to do? Which means in 99.9% of times we're not removing it, right? So what do? We are going to control bleeding, stabilize the site. We can put dressings on either side of the impaled object. Then we want to tape around it and secure it so it's not moving around. If a patient's already impaled, we don't want the object moving around, especially in a bumping ambulance. We want to stabilize the object so it doesn't do further harm than the harm it's already done. And then control bleeding because obviously it's bleeding. Now, people ask about bites. The bites are very simple. You could be worried, the patient may be worried about rabies, an animal bite, infections, stuff like that. All we're going to do with bites is cover with a dry, sterile dressing and pain management, for the patient. Again, position of comfort, be there emotionally for the patient. It's pretty, can be pretty scary for the patient. And then if it is at an extremity and it helps, you could also splint. Again, it is possible for pain management too. With face and neck injuries, a few things you want to watch for. So with the head, soft tissue injuries, you will use roller gauze to wrap around, so the whole circumference of the patient's head. Remember, the brain is exposed. We want to keep our dressing sterile and moist. That's the big key. Now, a few other things here. If we have, let's say, an impaled object into the eye, we want to use that same roller gauze. What we want to do is we want to make a donut out of that gauze, a circle. I want to place that over the eye, then wrap around the patient's head in order to stabilize the impaled object in the eye. We're not going to take it out. So that's a big key, okay? Another key, with chemical burns to the eye, they need to be irrigated, which means you're going to put sterile saline or water onto the patient's eye to clean it out. That needs to be done as soon as possible. It is also very painful. So you got to tell the patient when you're doing a chemical eye irrigation, it's going to be painful, but it has to be done. We need to save your eye. So there's some keys. Let's move on. Now, some neck injuries I want to point out. The first one you might see is subcutaneous emphysema. Now, what is that? What that is air underneath the skin. So basically air in the soft tissues. It will be bulging out a little bit from the neck. And then what you'll see is it's like a crackling sensation is what it will appear with subcutaneous emphysema. Now, obviously with the neck, what else do we have at the front of the neck? Well, we have two major vessels. We have the carotid artery and the jugular veins, right? So this artery and vein, this could be a major bleed. So you want to watch out for that. Now, what if we do have a bleed? Let's just say, for example, we had a bleed to the jugular vein, right? What do we do? Well, check this out. There's something called an air embolism. An air embolism is life-threatening. So what an air embolism is let's say we cut our jugular vein. Air can enter that vein. And then where do the veins go? Towards the heart. So then air goes towards the heart, and then we end up in cardiac arrest because we have an air embolism. Remember, embolism means a clot, right? So if a vein is actually punctured, air can travel, thus causing an air embolism. So what do we do? So if someone does end up cutting, let's say they did cut their jugular vein, what do we do? Direct pressure, and then what do we do? We're going to apply an occlusive dressing. So the word occlusive means it's covered up, right? Occlusive dressing to prevent this. That's going to be our goal. Rib fractures can be very painful. The biggest thing you need to know about rib fractures is that the pain from rib fractures can cause your patient to breathe more shallow and rapid. Now, why is this? So imagine this. You have a lot of pain in your ribs. It hurts to breathe. So what ends up happening is you start to breathe a little more shallow because the pain hurts. But then your body says, we're not breathing adequately enough, so now we got to speed up our respirations. then we get anxious and we're in pain. So our heart rate speeds up, right? So we have an increased respirations, we have tachycardia, and then we're breathing rapid and shallowly, and we got broken ribs. Not good, right? But this is what happens. So rib fractures are common in trauma, especially in older patients, or any high MOI event, right? Mechanism of injury event. Remember, the bones are more brittle in the elderly. Now, with fractured ribs, we're talking about this due to the pain. Here's what I would recommend. If you have somebody that has fractured ribs, I would recommend to you to call ALS for pain management, because they'll be able to breathe better. The reason this whole cycle is that's happening with tachycardia, increased respirations, rapid shallow breathing, it's the pain. If the pain's treated, they can breathe easier. So you see, so that helps. Remember that crepitus is the sensation we get when we have the fractured bone ends rubbing against each other. And what do we do at the EMT level? We're going to give oxygen, and we're going to airway management and ventilate as needed if we need to. And what's the paramedic level going to do? Well, paramedic level is good at pain medicine, and the same thing. Simple as that. Now, what is a flail chest? Now, a flail chest is 2 or more ribs that are adjacent next to each other, and they're broken in 2 or more places. So that's what a flail chest is. So what are the signs and symptoms? Well, we went over a lot of them already, but the hallmark one is paradoxical chest movement. So the chest normally moves together when you breathe in and out, and when we breathe on the same level. Paradoxical movement is, let's say, one side going up and one side going back, or the opposite, right? So that is paradoxical chest movement. It's unequal chest movement, right? Severe chest pain, probably the worst pain of their life, increased respirations, tachycardia, and then again, rapid shallow breathing due to these fractured ribs. So pain control, pain control, pain control, call ALS, manage their airway if needed, if there's that much trauma going on, and they're probably going to need some oxygen. So how do most orthopedic injuries occur? Sporting events, athletic contests, could be motor vehicle accidents, falls, assaults. So there's 4 main ways. We have direct blows, indirect forces, twisting forces, high energy and high MOI events. So with high energy, high MOI events, we think about, obviously, high-speed car crash. Obviously, that can cause it, right? Twisting forces, you think about twisting your ankle, landing the wrong way, rotational twisting forces. Direct and indirect. The best example of direct and indirect I can give you, someone goes to fall, they put their arm out, they land, they end up fracturing their wrist, but indirectly, my elbow didn't touch the floor, but boom, I dislocate my elbow, right? So that is direct versus indirect. So what touches would be direct, and then indirect, it shoots up, and then indirect. So that's an example. So there's a few things over here I want to talk about. Everybody, quite simply, if I say a fracture, I mean a broken bone. That's the definition of it. So a fracture, a broken bone, same thing. Now, there's closed versus open fractures. A closed fracture means the bone there's no wound on top of the fracture. The fracture is internalized. So I'm pointing my leg down here, right? But show you my arm. Let's just say I was going to break my arm, right? Closed would mean there's no wound. Open would mean the bone is actually coming out, right? And there's a wound with the fracture. Now, non-displaced versus displaced fractures. So non-displaced is very hard to tell without getting some imaging done, right? Now, non-displaced simply means there is one fracture. There's one site that is fractured, where displaced means that we actually have deformity. We actually have deformity or shortening, and there's a fracture going on. So the way I like to think about it, non-displaced, it's very sticky to tell if the patient has not a fracture, an injury that's less, like a strain or a sprain, versus a small non-displaced fracture, where displaced fractures are very obvious because there's little deformity or shortening going on. Dislocation is when the bone ends are no longer in contact with each other. Some common sites of dislocation would be the shoulder, elbow, hip, knee, and also fingers are very common sites. Now, we talk about reduce. You may have heard the term reducing a dislocation. That is bringing the joint back to its normal anatomical positioning. Now, this can happen naturally in the body, or that can happen by force, by someone actually forcing it back in. Now, there's sprains and strains, okay? So a sprain, remember this, sprain, joint. Strain, muscle or tendon, okay? So sprain, it's a joint, it's twisted, it's stretched beyond normal range, where strain is stretching or tearing of muscle and or tendon. And there it is. Now we've learned a little bit, I just want to get your mind thinking about different injuries and like categorize them. Are they minor? Are they moderate? Are they severe, life-threatening? And based on what we learned, just so we can grasp our head around. So, like, what are some minor injuries? Like minor strains, minor sprains, maybe like fractured fingers or toes, right? Now, what's a moderate? Well, like a long bone fracture. Maybe let's just say it was a non-displaced long bone fracture, right? It was a single long bone fracture, right? Now, more severe stuff would be like a displaced pelvic or long bone fracture, an open any sort of open fracture, any sort of amputation, bilateral. Let's say we had bilateral femur fractures, right? Or multiple open fractures. So we have to picture these patients and go, wow, that one's more severe, that one's more minor, just so we can get a grasp of different patients we might see. So I just want to do a quick overview of splints. So we have a rigid splint, and then we have formed splints, like the SAM splint. So our rigid splint would be like a padded board splint. So that's our classic padded board splint for the legs, right? We have padded boards, we have cravats for that. So that's like your common, let's say you had a leg fracture and you want to straighten it out on the stretcher, that's your pad board. Now, the formed splints, like our SAM splint, those you can actually mold, and you have a little more creativity with those. Commonly, for what I'm touching right here, if like a forearm fracture, those are great for that. And now remember, with both these, we can place ice packs in there too for pain control and swelling. Now, we have a few other things here I want to talk about. Well, the sling and swath. Sling and swath is good at stabilizing different fractures. Up here could be even in the clavicles as well, as for pain control. So sling and swath, the sling is going to be the first piece. The swath is going to go around, okay? That's going to relieve pain and stabilize. Now the pelvic binder is going to be around the pelvis. The goal of this is to reduce to reduce the possible hemorrhage that could occur with a pelvic fracture, right? We know the pelvis can easily store a lot of blood, and also pain control. And then now with a traction splint is for mid-shaft femur fractures. The goal of the traction is to pull the body back to its normal anatomical position. And remember, the traction splint is only used on mid-shaft femur fractures. So that is going to be the big key. So we're going to pull back to natural position and alignment, which is going to stabilize the femur and then provide really good pain control. Patient assessment breaks down the entire 911 call. Essentially from the time you're dispatched all the way until your final checks of the patient before transferring care to the hospital staff. There's 5 main parts of patient assessment. The first is the scene size up. So with scene size up, what do we think about? Well, we think about safety and we think about considerations. Essentially, this is you and your partner saying, what are we about to walk into? What people do we need? What equipment do we need? Do we need specialized resources? That's the thought process of the scene size up. Now, before I go any farther, I'm going to be going through all these in great detail. So by the end of this little series, you're going to know patient assessment down cold. So don't worry about that. Primary assessment. Now with primary assessment, there's 3 main things to think about. 1, we're first going to see the patient in this step right here under primary assessment. The first time we actually see the patient. So now we're at the patient's side. We're going to get a general impression. So we see the patient. On the first look, how ill does the patient look? What do we see on the scene that might clue us in on some things with the patient? We're going to look at life threats. And if we see it, we're going to treat it. We're obviously going to treat it. And we're going to do a rapid exam. The main goal of the primary assessment is to obviously get to the patient's side, treat life threats, and make a decision. Like, how ill is this patient? Where are we going? Where are we transporting? And what are we going to do next? History taking. We want to gather the information about the event, one, so it can help us, but also so we can relay the information to the hospital staff. So the mnemonic is sample. We'll be going over that in a little bit. Secondary assessment is when we do a detailed physical exam. In primary, we're doing a rapid exam to find life threats. In secondary assessment, we are basically doing a more thorough and detailed exam to make sure that we didn't miss any other injuries. The biggest thing to remember, we need to expose our patient anytime we do an exam. Please remember that. Now, with reassessment. Reassessment, just like it says, you're just rechecking. Look how much you've done on this call. Everything you've done in reassessment, you're rechecking, you're reassessing, and then treating anything that comes up. That's reassessment. Now let's break all these down in great detail so we understand every little detail of patient assessment. Now, a big part of patient assessment is the information that we gather. We're gathering information from dispatch, from bystanders, family, the patient, our exams, getting vital signs, measurements, right? We're gathering all this information to make what we call a field impression of how sick the patient is or how injured the patient is. And that will determine, well, what hospital the patient will go to. It also will determine as well if we go license sirens to the hospital or not, right? Now, I want to first go over some key terms. Then we will jump into our 5 main things, but this is so important, and I want to make sure you're clear on this before we go any farther. So watch this. Symptoms. A symptom is subjective. Subjective is what the patient tells you. I have chest pain is a symptom. A sign is an objective finding you can observe or measure. So, unequal chest rise would be a sign. JVD would be a sign. Oh, I have a cramp in my leg. Subjective. You get what I'm saying? Right. Now, I present to you 3 patients that I've hand-selected with hallmark signs and symptoms. When you go through National Registry, they're going to give you hallmark signs and symptoms. Your job is to pick up on it and figure out what to do next and how to treat it, right? That's putting it all together. But if we can't pick up on these clear-cut examples, then we're going to have a hard time with tricky questions. You see where I'm going with this? All right, good. So here we go. You have a 68-year-old male with 10 out of 10 crushing pain in their chest. They're in the tripod position to trying to get in air. They're diabetic and have hypertension, high blood pressure in their history. Pain radiates down the left arm and the patient is diaphoretic, right? They're sweating a lot. What do you think is going on with this patient? Now, why do I say this? I wrote up here, chest pain with difficulty breathing. Every one of these patients has chest pain and difficulty breathing. But we're going to think of our field impression, what might be going on with this patient? Well, this is a clear-cut heart attack, a myocardial infarction. Myos, muscle, cardiac, the heart. Infarction means death, which means heart muscles dying. That's a heart attack. Our coronary artery blocked, and the heart muscle ain't getting no blood and oxygen. Okay? So, I'm going to put here, MI. Why is this clear cut? Hang on. Age is greater than 40, so that's for sure. 10 out of 10. If I hear crushing chest pain, that gets me nervous. Could you have a heart attack with sharp or stabbing? Yes, but crushing is really a sinister one. Now with this case here, we have the patient in the tripod position. That's sinister because they're really trying to position their body to get the most amount of air in. Being a diabetic is the #1 risk factor for heart attack, and so is high blood pressure, right? if you have chest pain that radiates down your left arm, it can go up into your jaw, but down the left arm, you're diaphoretic and have chest pain, that alone is alarm bells for MI. Now, in our second case here, we have a 35-year-old female. 10 out of 10 sharp pain. So I'm going to underline sharp, okay? Sharp. Now, sharp, we tend to think more of respiratory. Tend to. It's not a rule, just a thought, okay? Remember, we got to critically think about this case. Now, we had 68, now we're a 35-year-old female. Okay, I'll keep that in mind. 10 out of 10 sharp pain. Okay, wow, okay. Struggles to get 1 to 2 word sentences. Okay, underline that. She's a smoker, on birth control, and just landed from a 16-hour flight. This is clear cut for pulmonary embolism. Now, what are the hallmark signs and symptoms here? Well, I'm doing my field impression. Smoking and birth control are both risk factors for pulmonary embolism. Okay, what else? Well, respiratory tends to be more sharp pain, so I noticed that. I also noticed that she just got off a 16-hour flight. Being in a period of rest or stasis, not moving for a long amount of time, that gets you at more higher risk of having a blood clot. So this patient went on a long 16-hour flight and has risk factors of getting a pulmonary embolism. And now she got 10 out of 10 sharp pain with chest pain and difficulty breathing. I'm thinking pulmonary embolism based on what I've learned in this course. You get where I'm going? Beautiful. Now look at this patient with chest pain and difficulty breathing. Every patient got chest pain and difficulty breathing, but look how it's nuanced. And we can see, well, this might be a tension pneumothorax. That's what we're going over here. Hang with me. Well, why is it? Watch out. I'm going to put just here, tension, pneumo. Okay, now look here. 10 out of 10 pain in right chest with accessory muscle use. Okay, so I'm going to go right chest, accessory muscle use. Accessory muscle use is respiratory distress. Okay, let's see what else is going on here. We have absent lung sounds on the right side. That matches the chest pain. Okay. The patient was involved in a head-on motor vehicle accident. Head-on, okay? JVD's present. So what am I thinking about here? Well, when I think about absent lung sounds, if I have bilateral absence, that's more of like a silent chest, like an asthma patient that is like so constricted I can't hear anything, or anaphylaxis. Well, if only one side is absent, that's more pneumothorax. Now, pneumothorax could occur spontaneously. It's possible if you didn't know that, medically. But it's more common traumatically. This person was involved in a head-on motor vehicle accident. JVD is an actual sign of tension pneumothorax. It's one of the signs. So, when I put the chest pain, difficulty breathing, the fact that he was in a head-on motor vehicle accident, has JVD, has absent lung sounds on the same side where the pain is. Tension pneumothorax. It looks like it, doesn't it? So this is how you're going to break down calls and situations when you are a competent provider. And this is the first steps of understanding this. It's called patient assessment. Our first step of patient assessment is scene size up. The first thing is to ensure scene safety. So, I'm going to give you a good example here. Let's say you're going to a call for an assault, or let's say a stabbing, or a gunshot wound victim, or a violent patient. Law enforcement would come before you. You would stage. Then, law enforcement would make the scene safe, then you enter. Even so, even if you're going to a call that's not quote-unquote violence or whatever it is, you always ensure scene safety no matter what. Just want to give you that quick pearl. So ensure scene safety. 2, you're going to get dispatched and you're going to have some sort of information from dispatch. Some calls that are dispatched, there's a lot of information, some there's not as much. But whatever information we get, let's say we got abdominal pain. Now, we got abdominal pain. Okay, we're going to abdominal pain. Lights and sirens. Okay. We want to think, what's the worst case scenario of abdominal pain? Well, we'll give you an example. One of the things that it could be a abdominal aortic aneurysm, right? Right? That's life-threatening. Right? That's something. What else can abdominal pain be? Could be ectopic pregnancy. That's really bad. Right. Right. What else could it be? It could also be a hepatitis flare-up. Right? It could be some stomach pain, like pain from acid reflux. Right? It could be diverticulitis pain. It could be appendicitis. You see where I'm going with this? So these are the things we want to talk about on the way to the call. Now, there's two different things here. Determine the MOI, the mechanism of injury, versus and/or the nature of illness. So one of the things that I described to you was nature of illness. Those are medicals. So on the trauma side is mechanism of injury. So you're going to a fall victim. How high did the patient fall from? If the patient fell from a house versus standing, what would the difference in injuries be? How old is the person involved, right? Was it a pedestrian versus car? Was it a motor vehicle accident, right? That's what we're thinking about. So this is what I personally call the pre-call talk you want to have with your partner based upon this patient information, so you're best prepared to deal with this patient once you get on scene. That's what this step's all about. Number 3, take standard precautions. Now, you are in the ambulance. By the time you step out of that ambulance, your gloves should already be on. When that foot goes out the door, your gloves are on. Now, could you have a mask? Could you have eye protection? Could you have a gown? Yes. Depends on what situation you have. But at the minimum, you have gloves on at the very minimum, right? Every call with accident. Foot hits the ground, your gloves are already on. Okay? 4, determine number of patients. So when we're making our first steps to approach the scene, we got to figure out how many patients do we have. And that is going to tell us the last part. Do we need additional resources? And I didn't write it here, but I'm just going to tell it to you. Consider additional resources and or specialized resources, right? So for example, let's say that you are completely shocked. You get called to a motor vehicle accident. You were told it was 1 patient. You get there, there's 10 patients. You need additional resources. Let's say that you get to a scene, and to give you an example with additional resources. You get on the scene, scene's not safe. You need additional resource. You need law. Get what I'm saying? So, additional or specialized resources. What if you need the fire department for some reason, right? So that's what we're looking at here with our scene size. Now, I want to start with an overview of our primary assessments. Then we're going to break this down and go over some key terms. Now, first, with primary assessment, we want to form a general impression. So as we approach the patient, what is our impression of the patient and the scene around the patient? For example, let's say your patient was resting comfortably in a chair versus the patient being unresponsive on the floor, or versus the patient in a tripod position, or versus the patient vomiting on scene, right? Scene environment. It could be an immaculate home. There could be debris everywhere, right? So that's the general impression. Now, talking about number 2, which is assessing our level of consciousness. We have our AFPU score, which determines how alert, how responsive is the patient. And then over here is the orientation of the patient. So when we say someone's alert and oriented, it means they passed all this, right? They passed it. So the AFPU score determines how responsive is your patient. Are they alert or not? So the A in AFPU is you're alert, right? That means like right now I'm alert. My eyes are open, right? If you call me by name, hey, here I am, right? I'm speaking, obviously, I'm alert. Now, V is for verbal response only. So let's say you walk in and you talk to the patient, and they only respond to verbal, but they're not actually alert. So you stop talking, they go back to the way they were. Verbal response only. If they respond to a painful stimuli, right? Let's say it was a sternal rub, for example, right? A painful stimuli is P, and an unresponsive is you try speaking to the patient, you try calling them by name, you try painful stimulus, and they're unresponsive. That's a U for unresponsive. So orientation means, are you oriented to the world around you, right? And yourself. So watch this. Person, place, time, and event. So, person. Does the patient know who they are? Place. Do they know where they are? Time. Do they know roughly, of course, not everyone knows exactly what time it is, but roughly about what time it is and, obviously what year it is, right? And then the event. Do they know what's going on right now on the world around them? So that's alert and oriented. Now down here, next, we're going to assess airway, breathing, circulation. Why is there a star here? This is why. People talk about, what do I do first? Airway, breathing, circulation? Circulation first, what do I do? Well, circulation is kind of always first. Can I share with you why? When you're doing your scenario, you want to ask, I've exposed my patient. Do I see any obvious signs of uncontrolled bleeding? Yes or no? If you do, you need to treat that first. If you don't, you can go airway, breathing, circulation. So circulation comes first if you have a life threat under circulation, which is a major bleeding, uncontrolled bleed, which you got to expose your patient. Say, do I have any uncontrolled bleeding, right? There will be, obviously blood pooling around the patient, blood staining the shirt, right? Just for examples. So this is where we treat our life threats. Now, what are the main life threats underneath this? Now, I'm going to go into more detail in this a little bit, but just giving you an idea, someone with a fully obstructed airway, that would be a major issue, right? If they're unresponsive, they need their airway managed, that would be a big life threat. Obviously, breathing, right? We could figure out what a respiratory rate, if it's too high or too low, can help manage that, right? Lung sound, stuff like that. We could hear for stridor under airway. You hear stridor across the room. Stridor could be an airway obstruction. Circulation goes back to really they're having a major bleed. That's the biggest thing. And we'll talk more about this in a little bit. Just want to get your brain going. Now, next is performing the primary assessment / rapid exam. So we're going to do a rapid assessment, head to toe, rapid. But it's going to be fast. Not going to be detailed. We're not taking out our pen light and look in the ears, and look in the nose, look in the mouth. We're just basically scanning the body, looking for any obvious life threats. It's a quick scan of the body. Is what we're going to think about it. Now, lastly, from all this that we've done, we make a determination. How injured or how ill is our patient, and make a transport decision. What hospital are we going to? How are we getting the patient out of where they are right now in the scene? Like, how are we going to move them to the ambulance? And also, are we going to be going lights and sirens or no lights and sirens to the hospital? So that's our transport decision and patient priority. When we're doing our patient assessment and we're evaluating airway under the primary assessment, the question is the airway open? Another word for open is you might hear, is the airway patent? Is the airway open? Can the person manage their own airway, and is it open or not, right? So if the patient is able to speak, or if it's pediatric and they're crying, we hear noise, the airway is open. If I can speak to you, my airway is open, right? Now, here's the biggest thing. In some patients who are unresponsive, we will need to manage their airway for them because they're either not breathing or they can't manage their own airway because they're unresponsive. Now, with these unresponsive patients, they need better airway positioning to open the airway. And then for a lot of these unresponsive patients, we're going to have to ventilate for them because they're not going to be spontaneous breathing on their own at the good rate. We know for adults it's 12 to 20, right? So if we don't suspect any trauma, we hear nothing about trauma. Say someone was found laying in their bed, right? Head, toe, chin lift, medical. Jaw thrust maneuver is, if we suspect any trauma, just go with a jaw thrust maneuver. You can't go wrong. You're still opening the airway, right? Now, the reason we have these two different ones is we're worried about going like this and hurting the cervical spine if there's trauma. Charlotte's maneuver where we can open the airway without having to move the head back. So first, we're going to open the airway. That's positioning. We just talked about that. Next, we're going to clear the airway. Is there blood, vomit, secretions that need to be cleared? Is there an obstruction that needs to be removed in order to clear the airway? That's suction, right? Then once we have the clear airway, so it's open, we've cleared it, now we're going to keep it open with an OPA or NPA, right? An airway adjunct. That's how we keep it open. Then we get a ventilator patient and actually make the breathing done for the patient with a BVM, bag valve mask. Attached to oxygen. Give them oxygen, it's nice, right? Those are our 4 steps of airway, right? This is in the worst case scenario, an unresponsive who's not breathing adequately. Now, what are the signs and symptoms of a full airway obstruction? For example, you may hear, and this could be a partial or full obstruction. You can hear both of these, right? Obviously, absent is complete. If we hear any of these, probably either partial or could possibly be a full one. Stridor, snoring respirations, bubbling respirations, gurgling respirations, shallow respirations. Absent is obviously, it could be a full obstruction or they're just not breathing because they're in respiratory arrest, right? So watch out for these buzzwords. If you hear these buzzwords, you got to do these airway steps. Then the answer is going to be, well, where am I on these steps? What's been done? And if let's say open and clear has been done, the answer is this. Let's say that, open's been done, but we haven't cleared. Clear's next. Let's say we did all 3, but we haven't ventilated yet. Time to ventilate. There it is. The question we have to ask ourselves, is the patient breathing normally or not? So we look at 2 main things first. What's the patient's position like? And what's their speech look like? A patient who's breathing normally, they won't need to put their head up to get in the sniffing position. They won't have their arm extended like they're in the tripod position. They're not going to have accessory muscle use. They're not going to have retractions between the ribs, right? They're going to be speaking in full sentences. They're not going to have to take breaks in between breathing. That's someone who's speaking normally. And someone who's breathing normally. You see where I'm going with this? So, I didn't write it down here, but remember this. Positioning and speech. That's the first place to start, whether we're normal or not. Now, what else do we look at? Well, we can look at the chest rise and fall of the patient. Just looking at that, we could see how fast is the respiratory rate. That's how we actually count it, right? So I have a mnemonic here, okay, that I learned from one of my mentors and I want to pass to you, okay? It's called the Pirate Owl mnemonic. In these 4 quick steps, I can determine if someone is sick or not sick based on breathing. So the first thing I look at is the respiratory rate. Is it normal or not? Too high, too low, or normal? What's the O2 sat? Am I above 94? Am I below 94? Am I good or bad, essentially? What are the words percents? I read speech. Then labored. Signs that your breathing is labored is seeing signs of respiratory distress or failure, which you talked about in another video inside the accelerator, so make sure to watch that one. And the positioning of the patient, right? What do we ventilate? We ventilate when the respirations are slow and shallow. They're too slow, they're too shallow. We're going to provide BVM ventilations. And any signs of distress or failure, we want to look for that too. Are there any signs of distress or failure? Does this patient need oxygen, for example, right? So, to give you an example, it was this chart here. Let's say the patient's respiratory rate was 8, and the O2 sat came back at 90%, and the worst percents was 0 because they were unresponsive. And then the breathing came back, and let's say it was shallow breathing, BVM. So see how we can use this mnemonic to figure things out? That's how we do it. The circulation step deals with bleeding and the skin condition. So remember, if we see a major bleed, like let's say blood around the patient, or the patient says, I'm bleeding, or let's say the patient has blood, you find it on the clothing, we need to tackle that immediately, stop the major bleed immediately. It's the first step of primary assessment. So if we see that, we got to tackle it before anything else. Now, with circulation, let's say we have a major bleed. What do we do? Direct pressure, sterile bandage. If that solves it, great. If it doesn't, let's say it's on an extremity, tourniquet, okay? Now, We talked about this already. Now skin. We're going to check skin color, temperature, and then the skin moisture, and then cap refill. So let's start with the color. There's two main things that are abnormal colors, if you will. Jaundice is yellowing of the skin. Cyanosis is bluing of the skin. Jaundice, yellowing of the skin, means your liver is inflamed or infected. There's something wrong with your liver, hepatitis, okay? Bluing of the skin, cyanosis, it can be in the nail beds, for example, the lips, right? Even the skin, like say, talking about like a brand new newborn, right? What does that mean? Lack of oxygen, and that is a sign of respiratory failure, okay? Skin color, and also obviously, is the patient like pale, stuff like that, right? Skin temperature. So, is the skin hot? Is it cool? Right? Is it warm? How is it? Skin moisture. Skin should be more on the dry side. Skin shouldn't be sweating profusely. That's called being diaphoretic, is excessive sweating, diaphoretic, right? Cap refill. So we go like this, we go to the patient's finger, we press the end of it, go like that. Within about 2 seconds, the skin should go back to the color that it was, right? That's capillary refill. But at the fingers, you can also do it in the toe, and it goes back. So under 2 seconds is good. If you see, a 5-6 second delay, that means blood probably isn't getting out all the way to the extremities. So I hope that helps. So here's a demonstration of a quick, rapid physical exam. This is under 90 seconds. So we got to be quick, but we want to make sure that we do all the steps. So remember, we have to hit every single part of the patient's body, but we're doing it in a rapid way. We're not being detailed. We're just looking for anything obvious. So the mnemonic is DCAT BTLS, which is what we're looking for. Deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, or swelling. If we see any of this, we want to note it, right? And a key term I want to give you real quick is called crepitus. Crepitus is basically when you fracture a rib and you have bone ends that are grating together. It's a sensation. Okay, now let's start our assessment. So I'm scanning the patient's head, looking at the back of the head, the front of the head, looking for a DCAT BTLS. Moving on from there, going to the patient's neck. And neck has a few key points. I want you to say, I'm looking for JVD. I'm looking for, is the trachea midline or not? I'm feeling the back of the patient's neck to see if there's any step-offs. From there, I'm going to see, okay, my patient now is fully exposed, and I'm going to now start looking for lung sounds. Lung sounds, lung sounds, lung sounds, lung sounds. We can even go here, okay? So, lung sounds, we're getting all those, right? What do we get back on that? Then we're looking for the chest rise and fall, and we can see if there's anything else abnormal going on just by exposing, right? From there, palpate the abdomen, okay? We're feeling, is it soft, is it rigid? The pelvis, we're going to push in, push out. Scan the legs, scan the arms, looking for pulse motor sensory. Then we have the back. Now, when I go to the back, you want to feel on that spine. Again, and the whole time we're saying, any DCAT BTLS, any DCAT BTLS, we're looking for that. Now, that's what we have in our assessments. That is the big thing that we're looking for, is DCAT BTLS, and anything that we may have missed, and make sure, remember, fully expose your patient. All right, we're up to history taking. History taking has two main mnemonics we got to know, and what we're doing here with history taking is this. We're getting the patient's history of themselves, their medical history, and the history of the event for us to make a determination on what's going on. Remember, in the first starting stage of patient assessment, I gave you those 3 scenarios. The history of the event caused us to make a decision on a lot of those, right? That's why we do history taking. So first, before the mnemonics, I've put in a box here something called pertinent negatives. And I want to explain it to you first. These are the mnemonics, but first this box, pertinent negatives. What is that? So this is an example of a pertinent negative. The easiest one I can give you is this. We all know the clear-cut hallmark signs and symptoms of having a heart attack. Chest pain, difficulty breathing, pain going up to your jaw, down your left arm. It's a crushing pain. Oh, it's like an elephant is on my chest. Pain, right? That kind of description. Nausea, vomiting. Their history. would be like high cholesterol, high blood pressure, diabetes, family history of a heart attack under 40, right? These are things we think about, right? Right. So what this means, if you evaluate somebody for chest pain and they deny difficulty breathing, they deny nausea, vomiting, they deny a family history, they tell you they have no medical history, that is a pertinent negative. Pertinent meaning it's important. Negative meaning it's a negative finding. That's why they call it pertinent negative. You see where I'm going? So on your chart, you would write in your narrative, patient denies difficulty breathing. Patient denies nausea, vomiting. Patient denies family history of cardiac disease. Patient denies any medical history. See? Now, how do we get this information? By doing these two mnemonics. Here we go. So when I'm talking about investigating a pain, here's how I do it. OPQRST. O is for onset. What were you doing when these symptoms started? Remember, signs are things that we are going to observe or monitor. Symptoms, what the patient tells you. Okay? So what was the patient doing? Provokes. Provokes. Does anything make the pain better or worse? Like, usually it's like patient positioning, like sitting up, sitting down, right? Laying down. Quality. Could you describe the pain to me? Radiates. Does the pain go anywhere? What region of the body is the pain also? Severity. From 0 to 10, how bad is the pain? And T is for time. About how long it's been going on, when did it all start? Now, in sample history, this is about their medical history. So, what were the signs and symptoms when this first started, right? We want to find that out. Do they have any allergies? Do they take any medications? What is their medical history? Like, they diagnosed with anything? Do they have any past medical history? A great one is, have they ever called the ambulance for this before? That's a great one too, I'll throw in there. Last oral intake, so when was the last time, this is a two-part one. When's the last time they ate, but also if they take medications, when's the last time you took your medications? Okay, and then I would throw that one in there. E, events leading up. So what were you doing before this all started, the events leading up? So these two mnemonics, knowing about pertinent negatives, you get 100% history taking. So now we're on to our secondary assessment. There's a lot of steps to the head, and then it moves pretty quick. So starting with the patient's head here, the first thing we're just doing, inspecting the patient's head, front and back. Okay, we're still looking for DCAT BTLS, still, okay? Now, I'm moving on here. I'm inspecting and looking around. I first start up here, with my ears and my eyes. I'm gonna take a pen light, look in both eyes, and what am I looking for? Well, I'm looking for dilated or constricted pupils. I'm looking for redness in the eye. The ears, I'm looking for any fluid coming out of the ears. I'm also looking for battle sign back here right behind the ear, which is basically bruising behind the ear, which could be a sign of a basilar skull fracture, or a fracture of the base of the skull. Then I'm going to look at through the forehead, cheekbones. Then I have the same pen light, look in the patient's nose, open your mouth, look in the mouth. And that pretty much completes my head assessment. Again, make sure you look at the front and the back of the head. You don't want to miss anything. Now, patient's neck, again, front and back, looking for JVD, any trachea deviation, looking for any step-offs in the back of the neck, and I'm just looking here. Now, again, you're going to go through again with your chest. It's a secondary assessment, and I'm going to go ahead and I'm going to oscillaate lung sounds. So let's say I go here, this is right below the clavicle. I go here, over in the armpit area, over here, middle of the chest right here in the sternum, right? And I'm getting some lung sounds, right? So we get a reassessment based on that. I'm going to look at the patient's chest for as far as rise and fall, right? If there's a painful area, I may need to palpate that area. Then from there, I'm going down to the abdomen. Same deal. I'm going to look for any patient guarding. I'm going to palpate the patient's abdomen, go through that abdomen, then obviously pelvis. Is the abdomen rigid or soft, right? Is there any pain in any of these areas that I'm palpating? Scan the legs again, scan the arms again, get pulse motor sensory again, do all that. Then don't forget the patient's back again. So the back, we have the go back, do your whole spine, do the whole spine. Get another set of lung sounds at the back. In a lot of patients, the actual lung sounds are more clear in the back too, so don't forget that. Go through all the way down the patient's back. Then you can lean them back, there we go. And that is our secondary assessments. It is more detailed and more thorough then the primary assessments. Now, our final piece of patient assessment is reassessment. You can picture this, yes, you can picture this as you're transporting, you're nearing the hospital, you're doing your reassessments, but obviously you can have a long transport time. You may be doing reassessment a lot more than just once. So reassessment means reassessing everything that we've talked about. So let's start from the start. Reassessing your primary assessments, making sure you have all your history taking place, reassessing your secondary assessment, reassessing your vital signs, reassessing the chief complaint, as you can see here. Repeat primary, secondary assessment, repeat your vital signs, chief complaint, and then treat any changes. Now, by the books, meaning what NREMT is looking for, in unstable patients, every 5 minutes, you're going to reassess. This is going to be a test question. In stable patients, every 15 minutes, you're going to do a reassessment. That's just going to be an NREMT thing, so I want to put it here. Is it true in real life? Yes. But I just want to make sure that was a key point here because that is some important information for you. Pharmacology is the study and science of medications and drugs. So you can see here, science of drugs, study of drugs, that's pharmacology. Now, some key terms here you got to know. Let's start with medication. So medication is a substance that treats and or prevents a disease or emergency. And also, a medication obviously could be used for pain relief as well. That's what medications are. Now, these are two big key terms to kick off. And I'm going to show you a way to remember this the rest of your life. Now, just hang with me. Pharmacodynamics. Pharmacokinetics. When I say dynamics, think of dynamic action. Pharmacokinetics. Kinetic has to do with movement. So very simply, folks, pharmacodynamics is what action takes place when the medication is administered. Pharmacokinetics is how the medication will move throughout the body, its life cycle throughout the body when it's administered. So, pharmacodynamics, what will the medication do to the body? Pharmacokinetics, how will the drug move throughout the body until it's ultimately eliminated through the body? What's that look like? These are the key terms. Let's move on. An agonist turns on a receptor in the body. An antagonist blocks that receptor from being activated. So let me just break this down for you simply. I'm going to share two different drugs with you and two different processes you can understand this. Now, there are a ton of different receptors in the body. They all have different names, and they all have different effects. When a drug enters the body, what's going to happen is that drug is going to bind to a receptor. If it binds to it, it's going to activate it. That's an agonist. If it goes and blocks a receptor from being turned on, it's an antagonist, right? Now, let's say your patient takes heroin, or let's say in that same class of drugs, other opiates, opium, right? Let's talk about them. Heroin, oxycodone, Oxycontin, Vicodin, right? These are all opiates. So let's just say your patient takes heroin. Heroin would go into the body and it would attach to the particular receptor. It's called the mu opiate receptor. So it turns it on and we get the effect of heroin. Now let's say your patient overdosed. We would give a drug called Narcan or naloxone. The drug enters the body, goes to the mu opiate receptor, and says, hey, I'm going to block this from being turned on. Thus the heroin doesn't work anymore. Patient wakes up. So that's the agonist versus antagonist system, right? I'll give you another example. You may have heard of a drug called epinephrine. Epinephrine acts on the alpha and beta receptors in our body, specifically the alpha 1, which increases our blood pressure. The beta 1 increases our heart rate and how strong the heart contracts. And beta 2, it's going to dilate our lungs. That's why when someone is in anaphylaxis, when they have very tight lungs, that's why when someone's an asthmatic, we could give them epinephrine, right? So as a paramedic, you could give epinephrine to somebody who's in asthma. As an EMT, you can give epinephrine via EpiPen to someone who's in anaphylaxis, right? Right. Because we know that epi acts on the beta-2 receptor, and it causes the bronchial tree in the lungs, the bronchioles, to open, right? In anaphylaxis, they're being constricted. You see how this is all making sense? Now, another type of antagonist you may hear about is, I just told you, that the beta receptors, right, cause an increase in heart rate. So what if we had a patient who, let's say the heart rate was running too high, or let's just say, for example, a patient that wanted to lower the stress and demand on the heart, right? I can give that patient a beta blocker. So now their heart doesn't need to contract as much. The heart rate gets lowered. A medication like that is metoprolol. It's also commonly given to combat high blood pressure. Again, less stress on the heart. See where I'm going with this? So that's agonist versus antagonist. Drugs either turn a receptor on, we get an effect, we block a receptor, and we also get an effect because now it's blocked. See where I'm going? Now, this is what a drug profile looks like. So I was going to define what these are. You can see the order here. First is mechanism of action. That describes what the drug does when it enters the body. Indications has to do with when do we give this drug. Contraindications, when do we not give the drug. Adverse effects, what are the side effects of this drug potentially. Dose, how much do we give. The majority of drugs that we see are either going to be in milligrams or micrograms. Some drugs could be in grams. I'd say the most common is milligrams. Also, pediatric dosing is by weight. So it'd be milligrams per kilogram, something that's very common. Again, you could also have micrograms per kilogram. Just know that there's different dosing, right? Milligrams, give me an example. If I was going to give somebody 100 milligrams versus 100 micrograms, milligrams is more, just so you're aware. Special considerations, for example, very common is a special consideration. If someone's pregnant, caution the use on this. Give you an example. If someone's elderly or if someone's a pediatric, right? So certain types of patients, you might want to caution. It's not saying don't give it, it's saying think about it, special considerations. And then finally, the class of the drug. So what family does the drug belong to, right? So I'll give you an example. We talked about a few different meds. So we talked about oxycodone. That's an opiate, right? That's the class it comes from. Epinephrine, it's a sympathomimetic. Epinephrine is going to enter your body and it's going to mimic your own sympathetic nervous system. Blood pressure up, heart rate up, lungs open, right? So there we go. Now the brand name, also known as the trade name, I like to refer to as like the marketing name. So you might see on like TV commercial, like so to get you to remember the drug. So another way to look at it could be like the business name or the corporate name, right? That's the brand name of the drug. It's called brand or trade name by the books. Think of it as the marketing name. So for example, let's say we were talking about the drug. Let's say it was Advil, right? So Advil would be your brand name. Your generic name would be ibuprofen, right? So the generic name is closer to the chemical name, but it's clear and concise so people can actually, read it. A chemical name is what the drug is referred to in a lab setting. It's extremely long. It'd be, as long as its entire sentence, basically. So we're never going to see that in medicine. That's for, lab scientists. Now, prescriptions versus over-the-counter. Prescriptions are by a physician's order, so you have to see a doctor for that. And then over-the-counter would be no orders needed. You can walk in the pharmacy and then just go buy it. Now, real clear, I want to talk about something real quick. Brand name drugs versus generic drugs, it's the same exact drug. There's no difference in the drug. One is a brand, one is generic. The generic is just cheaper. That's all it is. It's the same thing. So, same drug, same chemical. And this is the same drug throughout. Just want to make sure it's clear. It just goes by different names, right? To put it in your brain to remember, a generic name might not be as palatable for marketing as the brand name, hence why they have the brand name to remember in your head. There it is. So we've learned a little bit here. Now I want to talk about the actual route of how the drugs enter. Let's talk about that. So these are some of the more faster ways. And I would also say, I just ran out of room here, but intramuscular would also be pretty fast as well. And then you have some of the more slower ways here. These would be the 3 slowest. There's no particular order. I'm just giving you an idea to plant in your brain. If you go along like this, it gives you an idea of how fast it is. So intravenous. So that is starting an IV in the patient, and we're going to place a catheter into the patient's vein that will allow drugs to go through that plastic catheter into the vein directly. Intraosseous, that has to do with entering drugs in the bone marrow. At the advanced DMT and paramedic level, what you're able to do is you're able to actually drill into the patient's bone, commonly either up here in the humeral head or down on the leg and down by the tibia. And what you're